So basically, the issue is that can we turn down the house audio? Okay, so
Do you hear me, Sean? Yep, I'm here. Okay. Is it ready to go? All right, so welcome everybody. We're officially going to kick off the start of TTST 2023 and Collaterals 2023. First, what I'd like to do is thank everybody for making this happen. This is a huge effort, particularly this year. We have the Collaterals meeting every year, but this is an unusual year because we're hosting the TTST as well this year. We've had combined meetings a couple of times in the past over the years. Collaterals has been a meeting that's been running since 2012, and we do it most years, almost all years annually. And we've had several meetings that have been paired up with Collaterals in the past. Most recently, a few years ago, just before the pandemic, when we did the intracranial atherosclerotic disease or sclerosis conference in combination with Collaterals. Thank you for everybody that has come from near and far. I'll explain a little bit about the format and who's here, who's virtual from around the world, how the two together, a little bit about the history of the TTST meeting and how it's evolved over time, what we're doing differently this time, as well as in terms of not just format, but the nature of the discussions, because so much has changed over the years in the stroke field. So it goes without saying that the entire focus of TTST as well as Collaterals is on stroke, very focused around everything neurovascular. So thank you first to everybody that's made these events possible this year. And then thank you for individuals like Jim and Werner, Greg, and many others were essential elements of the TTST over all the years. Now, first, in terms of what is TTST? TTST is thrombolysis, thrombectomy, and stroke treatment. And what I'd like to say is, and more. Because the treatment of acute ischemic stroke has been increasingly expanding over the years. Even this year, as we'll talk about throughout the next couple of days, the number of different treatment options and combinations continues to expand. I also like to think about it in a different way, philosophically, in terms of not just the treatments. As you'll hear me speak about precision medicine in a few minutes, it's also about who you're treating with what. And pairing up the right patient with the right drug or device at the right time to optimize that outcome. We can't always improve and make everybody have a good outcome after stroke, but what we can do is figure out what we're doing both in terms of diagnosis and therapy, do the best we can to help patients in terms of their outcomes, their clinical outcomes, long term. So TTST has evolved. TTST originally was centered around thrombolysis. Thrombolysis, as you know, has been in the works along with thrombectomy now for a few decades, and it took a long time for each to evolve. The thrombolysis meetings took place every few years, and this was a largely academically oriented group that was really focused on clot lysis, thrombolysis, of course, and then subsequently integrated the emerging techniques from an endovascular standpoint and other options we had available. Most recently, this has expanded to other treatments that we have. And at this juncture, we can start to consider things like neuroprotection and other adjunctive treatments. So just a little bit about how this is going to run. So TTST is, as mentioned, thrombolysis, thrombectomy, and stroke treatment, as well as other topics in terms of strategies to approach acute ischemic stroke. In terms of the flow of this meeting, today through tonight and all day tomorrow, followed by Sunday morning, is TTST formally, with the transition towards Collaterals. Collaterals overlaps on global strategies on Sunday and continues till Tuesday with our regional sessions from around the world. A lot of virtual participants, a lot of people here as well, and a real mix in between. People are connecting from airports, from soccer fields, and in the middle of the night, and I greatly appreciate that. This is how we do things on the fly. We're always focused about stroke. In terms of the methods, the methods are very relaxed. I'd like to say, we don't require formal slide presentations. This is meant to be a discussion and an open discussion, and I think it'll evolve and flow that way very nicely. The sections of the meeting of TTST are really split thematically in terms of the approach to stroke, understanding first what I mean by precision medicine and stroke treatment, starting out with diagnostic approaches, novel diagnostic techniques and approaches as well, how we figure out perhaps what each patient needs, a session on large core, which is very important nowadays, and then continuing on towards the therapy, drugs, devices, different types of devices, different types of trial design, how we recruit patients for treatment for ischemic stroke around the world, and emerging towards a global approach. Just so everybody's aware, we are recording everything, and this will be summarized and included with all the presenters in terms of publications that will emerge from this meeting, because it's important to document and demonstrate what we know as of the moment. And in the last year, there's a lot to talk about, and a lot to talk about immediately this week after we come from the World Stroke meeting as well, and some results that are coming out within days as well. So that being said, thank you. That's an overview of TTST 2023 in conjunction with collaterals. And I'm going to switch over to the first topic. We are going to keep these topics on time with 9-minute sessions. It seems incredibly short. The reason we're doing this is because we accommodate some of the pre-recorded sessions that are limited length, make sure that people can connect virtually from around the world, and keep the whole agenda intact as much as possible. There will be other times that we can have extra discussion as well. As you know, so many people are passionate about this topic. So when it comes to precision and the next topic, or the first topic of the meeting, I thought it was a good idea to give an overview of what we mean by precision medicine and what I mean by precision medicine in stroke, and explain to you about brainstorming concepts and what we're doing with Brainstorm as a company. So precision medicine started, as you know, based on genomics and genome project. So much of when you look at precision medicine in the literature has to do with genetics, understanding that the very detailed specifics of an individual may be documented in terms of the whole genome, and that perhaps there is a genetic signature that may tell us what's right for treatment of that individual patient, whatever they are afflicted with at the moment. In stroke, I like to think of this as using detailed information, diagnostic as well as other information about a patient, other variables we have available, to hone our treatments. And if you take a step back and you think about what we've been doing in acute stroke for so many years, we've sort of been doing this, but we mix back and forth in terms of all the variables we focus on. I tend to think that we think for a while along one variable, or time windows, or an imaging variable, and then focus on another. And I think we trip over ourselves in terms of understanding and amalgamating and how we interpret all the different trials and studies that come out. And part of that has to do with we're not considering all the data all at once, and that's very, very important. And it's incredibly important from a clinical standpoint, because from a clinical standpoint, we only get to treat sometimes more than one, but usually one stroke patient at a time. And we're trying to synthesize all this information. And I think what we tend to do is we go through the back of our minds to think about the one variable that may stand out and may bias us in one direction. We tend to think, well, that's not a favorable prognostic factor or stroke severity, and therefore it may tilt us in a certain direction. But often we get fooled by that. And it's important to think about all the data at once. And this is not easy. It is difficult. Imaging plays a big part in this. Imaging is very important in acute stroke and acute ischemic stroke. I hesitate to say that imaging is everything. It's not. Even the interpretation of imaging is dependent on the timing and a lot of other factors, the way we measure the imaging, the way we consider the imaging, and the way we place it in the clinical workflow. So it's incredibly important to focus on imaging, but take it as just another set of data that we have. Brainstorm is a company with a few years now that is a cloud-based platform that we use to bring together all the imaging data we have on stroke for several different purposes. One of which is for use from the core lab standpoint, where we can efficiently analyze data from trials and meta-analyses to provide these data to many different readers from around the world that have expertise that provide their input independently blind to clinical information. This is important because it fuels a lot of trials. Many trials have used Brainstorm so far. And it's also important because it provides a platform for data mining as well. So novel iterations of this have to do with AI in the back end, the machine learning that can be done with large data sets, and things that we can learn at a very large scale. I'll talk a little bit about this later this afternoon, but about Encore, which is probably the first largest patient-level meta-analysis of imaging from the recent large core trials. But that's one example where we can blind the data and have many different readers separately interpret this. And we need such a platform that's separate from the clinical data and separated from the other apparatus or elements of the clinical trials, so we don't get biased by those individual variables, and we take a giant step back. So in the last few minutes on this session on precision medicine, and I'd like to just emphasize why we're focusing on precision medicine, because in terms of the recent trials that just were announced and came out in publication, it is very confusing. We anchor around specific variables, as I mentioned, and then we try and interpret trials altogether, and that's not easy to do. We need to be able to consider all the data with all the variables on an even playing field to understand what we're doing, because otherwise we go from one trial to the next and not always with positive results. And what we need is positive results to move the field forward, to advance our therapies, whether they be drugs or devices, and to understand how we can improve individual patient care. So precision medicine as an approach is important. Understanding what we're doing from characterization of an individual patient, and figuring out and recognizing that one device, the same device or drug, is not going to work for everybody. It's going to work differently for different individuals. And I think this is true of any therapeutic intervention. So I'm going to stop there and then turn it over to coordinate the next session. And I think this is Sean, this is a virtual spin or remote, right?
No. I don't hear anything, but I see my picture on the collaterals Zoom, so I'm thinking I should maybe start. Hello? Okay, looks like I'm on. Great, thanks, Bruce. Great. Now I'm getting an echo. All right. It says I can't share my screen, guys. When I try to share my screen, it says host is disabled screen sharing. There we go. All right. Hello, everyone, and thank you for the chance to speak. Pretty excited to share this information with you. Sorry for the little technical glitches getting started. So I was asked to speak on pre-stroke functional status, which I'm excited to do.
Make sure the audio is coming through the right period, but not overall.
I feel like I hear something, someone talking or something. Am I? I'll keep going. Anyways, here are my disclosures. The only thing that's relevant is the Pcori Award for Tested, which is a trial, which I'll discuss a little bit later. So when talking about pre-stroke functional status, there's some literature to discuss and sort of what's out there. But whenever I talk about literature review, I get a little worried that I'm going to put everyone to sleep. But I'm hopeful because this is an incredibly large and important population, one that maybe people don't even realize.
Jay, can you hear us for a second?
Yeah, now that's the first time I hear someone. Yes, I just heard.
Jay, hold on one second because we're having trouble hearing you. We see your slides.
Okay.
Jay, can you please hold for a moment?
Yep, I hear everyone
Thank
now for
you.
the first time.
Hey, we're not getting his audio.
Jay, can you try speaking, saying something?
Hello, can you hear me?
We hear you on the computer, but not up front. So we're just trying to get it in the room.
Yeah, no problem. I'm here. You let me know.
All right. Try saying something.
Testing. Pre-functional status. Stroke therapy.
We need the overhead audio.
Hello.
Yeah, one more second, Jay.
No problem at all. Just checking to see if, just trying to give you some noise so you can see if it goes through.
Yeah, we hear you on the computer, but not overhead. Not over.
Oh.
The problem is here. The problem is here. The problem is here. The problem is He's hearing him on the computer, but not in the room.
I'm getting massive echo. I don't know if you guys are.
Should he try? Should he try? Should he try? Jay, can you say something? Jay, can you
Yeah,
say something? Jay?
I can talk, but when you talk, David, I get 1,000 reverb.
Hold on one more second. 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 How do we just get this audio from here onto the room? It's in 10 minutes. It's in 10 minutes. Yeah. How do we? Let's do that now. Let's do that. Let's do that.
Well, what did that do? Why did that do that? Why did that do that?
With 100 foot? What? Or want me to go with DI? With 100 foot?
It's okay. We just
No,
lost it
there's-
because
There's a DI on the podium.
Let's go up there.
Is it all Zoom or is it just me?
No, Jay, it's just us hearing you on our end. So we're trying to get the one of the computers to the front so we can hear you. We see you. We see your slides. Okay. Can we Okay. Are we ready? Test. Ready? Test. Test.
Hello? Hello? Hello?
Yeah, Jay, that's
Speak.
good. That's good.
Yeah, but the problem is we hear on Zoom 1,000 reverb. No, now I don't hear myself reverbing. Yes, I do.
Good.
No, I do. It's coming back. Oh, maybe it's stopped now.
All right.
And there it
Jay,
is
why don't you
again.
go ahead. Your slides and we
All right.
can hear you.
All right, I'll go as fast as I can. All right, here we go. So I was asked to talk about stroke functional status. Guys, I still hear myself coming back. Oh, you know what? Maybe I can do this. All right, I just muted myself so I can't hear you. So send me a chat if you want to, something isn't working. So here are my disclosures. None of them are relevant except for the tested award, which is specifically about this topic. It's a PCORI award. And so basically, I don't want to go through a literature review and put you guys to sleep, especially since we're short on time now. But I do want to emphasize this is a very large and important population, something that you may not realize unless you really think about it and go over it. So hopefully that'll get you all very excited. Basically, talk about pre-stroke functional status. You got to start that conversation really with any thrombectomy trial. Well, someone's advancing. My slides are moving ahead without me. I don't know what's going on here. Basically, I do want to highlight in the AHA current guidelines, the recommendation for level 1 treatment is pre-stroke MRS score of 0 to 1. And they say it may be reasonable to consider treatment of patients greater than 1. That's, in my mind, a bit of a problem because a quarter of the US adult population lives with disability, and stroke patients are even more disabled because obviously there's a reason they're having stroke. So about 30% of stroke patients have existing disability. Right now, endovascular therapy is not consistently offered to patients with pre-stroke disability. And in fact, Eva Mistry and her team performed a survey of 81 interventional and international and national interventional physicians and asked how often do you offer endovascular therapy for patients that would otherwise be eligible if they have pre-existing disability. And you can see that it's the results are all over the place. Now, obviously for modified Rankin 2, they skew towards more often they'll offer it. For modified, this was 3 and 4. For modified Rankin 3, they skew more often that they will. For 4, they more often won't. But there's a lot of people that are in the sometimes space. There was an analysis done of patients with pre-stroke disability performed by Eva and a number of others, which it was at Cincinnati and Vanderbilt, I believe. 2 centers out of 900 patients, they had 761 patients that were modified Rankin 0 to 3. There were 2 cohorts. They looked at those that had no disability, and those were MRS of 2 to 3. And the outcome was the 90-day modified Rankin was either 0, 1, or there was no worsening in the pre-stroke modified Rankin score. And there was no, and although there was a slight difference, it was very promising towards benefit for the patients, even that had basically 25% of the disabled patients still get back to their baseline functional status. And when the multivariate analysis and propensity score matching was done, odds ratio was suggestive that there was benefit in this patient population comparable to the modified Rankin 0 to 1 groups. However, it is notable, and this is, by the way, confirmed across multiple studies, I'm not going to go through all of them, that the mortality rate does appear to be higher in the disabled patient population. We don't know why that is. It may be have to do with functional capacity reserve or other things, but it's very interesting. But here's also very interesting. 34% of the anterior circulation thrombectomy patients in this cohort had a modified Rankin 2 to 3. So if you think about that, that's quite impressive. It's a third. And so this is a huge patient population that we need to get answers for. And so that's why we're running Tested, which was that PCORI grant I was talking to you about before. Actually, Heidi has replaced Chris as a co-PI. But the aim is basically to evaluate patients with pre-stroke modified Rankin scores of 3 to 4 that are experiencing an LVO and evaluate comparative effectiveness of endovascular therapy compared to medical management, as well as to look for what signals might be existed, what specific characteristics might be associated with the treatment benefit. These are the inclusion and exclusion criteria, which are pretty routine. We'd be very happy to talk to people about it. And these are just some interesting headlines that very much highlight the importance of not forgetting about patients who have baseline disability and what we can provide them, particularly when we're talking about a disease state that has a 30% incidence of disability amongst patients eligible for large vessel occlusion therapy. And with that, I'll say thank you very much. Sorry for all the technical difficulties. Happy to answer any questions if the audio works. I don't hear anything if people are speaking. I just heard a something.
Hi, Jay. Thank you so much for your presentation.
I'm sorry for the technical difficulty, guys. I hope it's just me and not anyone else. Well, I just heard very faintly. Jay, can you hear me? Yes.
Okay, so I'm glad you brought up the whole, the project that you and Eva are doing in Tested, and just because this is a high level audience, I just wanted to throw out there that you have a junior faculty actually working on using that data to create new utilities that take into account not just an overall moderate to temporary population, but one that includes patients with pre-stroke disability to sort out how it all works out. So I think that's really great stuff for our field.
Wait, you're going too fast. It starts blurry. I'm sorry. Can you just slow down a little bit? Yep. Yep.
The microphone's not working right now, but maybe the podium, the laptop will.
So this one should work.
Well, that sounds better.
Here, this should work.
Is this one working? Can you hear me? Okay, so, test is McCrory funded, it has performance centers and, ramp up phase now. Hope to enroll. It's a non-randomized study, because we thought that, and McCrory agreed there was insufficient equipoise among individual clinicians, but we are looking for sites differ in their treatment tendencies, so we'll be able to do a comparative analysis by looking across sites.
I'm very glad that I can hear that Jeff is there because, as usual, I'll defer to whatever he's saying.
Can you hear us now, Jay?
I can hear you, Jeff.
Okay. We have a working microphone now. So that's good.
But I don't hear anything else now.
Jay, thank you very much. I appreciate it. And we're going to move on to the next. Is Tudor on? Tudor, can you hear us?
Thanks, everybody.
Yes, can you hear me, David?
Yes, we hear you well, and you can go ahead and share your screen.
Okay.
Perfect. We see.
Okay, well, thank you, David, for inviting me. I'm sorry I can't be there in person. We can't be at all the meetings in this world, unfortunately. So I'm going to talk about endovascular therapy for stroke in the late time window. And I should say that by late time window, we generally mean 6 to 24 hours, although this is all completely arbitrary. But you got to put a cutoff somewhere, and conventionally that's what we set, and probably these certainly the upper end of the time window is going to be extended, in my opinion. So these are my disclosures. When I approach patients with in the extended time window, I keep in mind that we're dealing primarily with slow progressors, right? So, and these slow progressors, the ones with good collaterals who grow their stroke slowly, their infarct slowly, are the object of the, or the subjects of dawn and diffuse trials that have sort of given us proof of benefit in the extended time window. And as a consequence, these are now, the treatment is now in the guidelines, but it comes with strings attached. First of all, for reasons that are unclear to me, the guidelines endorse class 1 recommendation, only treatment in the 6 to 16 hours in dawn and diffuse 3 eligible patients. And then class 2A, 6 to 24 hours, or 16 to 24 hours. And the big strings attached are the requirements for advanced imaging. And the problem with advanced imaging is that, as you can see here, if you look at the NINS trial, ECAS, these are all, and even the endovascular trials, the less advanced imaging, the the higher the number needed to treat. But even in ECAS-3, this is a well-established, uniformly utilized treatment. And so a number needed to treat of 14 is plenty, is highly, still highly effective. So when we go to these kind of super low numbers needed to treat, the problem is that we over-select patients, and we're leaving behind patients who would otherwise benefit. And that's a problem because these are rate of utilization of thrombectomy worldwide relative to numbers of large vessel occlusion. And it's a sad story. Even in Australia, which has the highest rate of utilization, there's less than 40%, 50% eligible patients treated. This is recent data from MT 2020 initiative, and very remarkable effort led by MT 2020 and SVIN. So the question becomes, is there benefit for thrombectomy when we don't use advanced imaging? And what are lessons to learn from treatment beyond 6 hours? So first of all, the first kind of hints came from the Aurora meta-analysis, which included almost 500 patients, all randomized between 6 and 24 hours. And one interesting aspect is that the treatment effect, while the prognosis is not necessarily better in the late time window, the treatment effect is stronger. And that's because in the late time window patients, control patients tend to do particularly poor. I'm not sure why that is necessarily, but my theory is that probably many of the ones who improve, the control patients that improve, probably do so because of spontaneous recanalization. And the later you present, the lower the likelihood that you're going to recanalize spontaneously. And that's, in my mind, one of the explanations for why we see this paradox of larger treatment effect in the late time window. The other hints that we see here that we all ignored because there were just few patients enrolled, but aspect 07 versus 810, there was no difference in treatment effect. And then the other interesting aspect was that while the dawn and diffuse selected patients, of course, Aurora included most of the patients that were included in Aurora were dawn and diffuse, and there was a very robust treatment effect in these combined patients. Patients were selected based on non-quantitative core penumbra, if we can call it quantitative, so sort of pseudo-quantitative core and penumbra assessment. And some of them just on selected based on a plain CT. The point estimate is also in favor of thrombectomy. And so this was then confirmed later on with the ACT trial led by Tan Nguyen, showing basically that patients, this is a retrospective trial, but showing that patients, and it's a large retrospective registry. You can see here it's about 1,500 patients. And this is and what it shows is that there is really no differences in outcomes in patients selected based on a plain CT versus CTP versus MRI. So this is the clear study with the first sort of strong signals of benefit or equivalence in terms of outcomes when patients are selected based on a plain CT versus other modalities. Data from a prospective randomized trial comes from Mr. Clean Late. This trial has selected patients based on CT and CTA, specifically presence of a good or moderately good collaterals on CTA. And this is in patients who did not qualify based on dawn and diffuse 3 criteria. So you're taking out the population that benefits most in this trial. And despite that, there is significant benefit, a very robust difference with an odds ratio of 1.7 in favor of endovascular treatment in these patients who were not selected based on advanced imaging. Another interesting piece of evidence comes from the UK, University of Nottingham, large thrombectomy center. Unfortunately, in the UK, they don't do thrombectomy, specifically at that center. There's very few centers in the UK where thrombectomy is done 24/7. They only do thrombectomy during regular hours. So that afforded the opportunity, because this center only selected patients based on a plain CT. They recorded aspects on intake. They recorded vessel status on intake. So they had a so-called sort of a pseudo-randomized trial, because the controls were the patients presenting outside of regular hours. It's a sad story, of course, but no single patient during the study period, and it's a retrospective study, no single patient was treated outside of regular hours. And this is a study of about 150 patients. And what you can see here is that, number one, there is a mortality benefit. Twice as many patients died in the control group, in the non-treated group, with a benefit with an odds ratio that is similar to dawn and diffuse 3 with thrombectomy, when patients are selected just based on a plain CT, an aspect score of 6 or greater. So another piece of evidence that advanced imaging is not necessary. Another piece of evidence comes from the large core trials, which enrolled patients, all 3 patients that papers that were published in the first wave, so to speak, or first and second wave, enrolled patients up to 24 hours, and there was no heterogeneity of treatment effect based on time window. So again, some evidence that not only we don't need advanced imaging, but it's not clear that we should exclude patients with large infarcts. And then recently, Tesla was presented at ESOC. This is a 0 to 24 hour time window trial with aspects 2 to 5. This is a large core trial. Patients selected purely based on a plain CT. This trial, you can see here, almost made it to statistical significance, very strong trends towards benefit. And interestingly, with respect to time window, and I'm sorry that's not well seen here, but there is a significant difference in point estimate between the 0 to 6 and 6 to 24 hour, with strong trends of heterogeneity, with benefit in the 0 to 6 hours, but no benefit in the 6 to 24 hour window noted. And of course, the last piece of evidence, which now suggests that perhaps there is not much of a difference between the early and delayed time window with respect to large core trials. This is the fresh, hot off the press tension trial reported this week at WSO. I was lucky to be in the audience at that time. This is a study that goes out to 12 hours in patients with aspects 3 to 5. And you can see here a very strong treatment effect in favor of thrombectomy with an odds ratio of 2.58. This is sort of dawn diffuse 3 territory. And there is also mortality benefit. And this is a picture that I got while I was in there. The forest plot shows basically that the treatment effects are similar in the early and delayed time window. So we have some sort of conflicting information with regards to large infarcts, whether benefit is maintained in the beyond the 6-hour time window. Although most of the data suggests that at least with cores of 2 or above, that there's probably benefit throughout the entire 0 to 24-hour time window. How about IV thrombolysis? Is there benefit for IV thrombolysis in these late window patients who will or plan to undergo thrombectomy? And I think the Timeless study answered this question. The answer is no. These were patients who had mismatch presented within 4.5 to 24 hours and received TNK prior to thrombectomy, either at their spoke or at the mothership hospitals. And there is no evidence of benefit with this approach, although this approach was safe. So I think the answer is no. And that is supported by data from the IRIS meta-analysis, IV TPA prior to endovascular therapy, that a subgroup analysis, which I don't have the slides, but the bottom line is that the benefit of IV thrombolysis prior to thrombectomy appears to be only in very early treated patients. In this subgroup analysis of the IRIS meta-analysis, there was a benefit up to 2 hours and 15 minutes. So that makes sense that in the extended time window, there is not much added value of thrombolysis. So in conclusion, sort of reflecting on a talk that I gave in 2020 about beyond a 6-hour time window, and I mentioned the known knowns at that time. We know that in dawn and diffuse 3 patients, it's highly effective. Benefit is not that strongly associated with time to treatment and not associated with mode of presentation. And there were no major safety concerns. And at that time, there were a few known unknowns, such as, for instance, benefit in populations that do not meet dawn and diffuse criteria. You heard about pre-existing disability, distal occlusions. We still don't know the answer to these questions, but large infarcts, I think we kind of know at least moderate large infarcts. It appears there is benefit, less or no mismatch. We really don't need mismatch. Beyond 24 hours, we have some signals of benefit, but no randomized trials as such. But everything that has been published in the beyond 24 hours suggests that there is benefit. And I think that makes sense because we know that these slow progressors continue to progress and infarct growth continues, and there is no reason to just put a time limit to when there is benefit. Optimal imaging modality for mismatch, I think that's kind of settled because we really don't need mismatch necessarily. Whether we can't detect it on imaging accurately or whether it's not a predictor of for benefit from treatment remains to be seen. But the data that we have from all trials so far suggest that mismatch is not necessary for benefit. Harm in subpopulation, I think that's a big question. What is the largest, what is the infarct limit where there is benefit or even harm? From the data that we have so far, we have 0 signals of harm, but certainly we haven't studied this procedure in patients with the largest infarct 0-2. We will have data on these patients in the early time window, but not in the late time window. So we still don't know how these and will not know anytime soon how these patients behave when they present in the late time window with the largest possible infarcts. And then, of course, there's still procedural and peri-procedural aspects that I'm not going to discuss here. Role of IV thrombolysis, I think, is kind of settled. I don't think there's much role for IV thrombolysis. We know now that I would say the added piece of information compared to 3 years ago, no need for advanced imaging, no need for mismatch demonstration, and no need for thrombolysis. And with that, I'm going to end. Thank you very much.
Thank you, Tudor. I see, yeah, we have time for 1 or 2 comments or questions. When you mentioned thrombolysis at the end, I looked over at Jim and Andre, and this is one of the drawbacks of the virtual position is you can't get the pulse in the room.
Well, I'm ready for the thrombolysis challenge, but I need to see any data that suggests that.
I have just a comment and a question. I think that reperfusion has a benefit that in and of itself, or raise the question whether we think it does. I mean, we see with thrombolysis and with thrombectomy, infarcts are still there, but patients get better. And I mean, we see this with IV TPA. I'll see a patient, we'll give them IV TPA. I'll come in the morning and they still have a relatively large infarct, and I go to the bedside and the patient's a lot better than what I thought they would be. And you're showing us these thrombectomy cases that have established large infarcts. We're reperfusing them and they're still doing better. I don't know whether anybody has actually looked at infarct volume in these two populations, but my guess is there's probably not that much reduction in infarct volume. And I think we need to think about whether reperfusion itself has a benefit on the brain besides just reducing infarct volume, maybe improving synaptogenesis and stuff like that. So that's just sort of my thinking from these data, because otherwise I don't know how else to understand how you can just basically treat anybody with reperfusion and they're going to do better.
Yeah, so Jim, I completely agree with you, and we were talking about it actually in Toronto. I've been thinking a lot about it, and I completely agree that there must be some. I think there's 2 explanations for this large core story. One is that we have zero idea. I mean, we just got it completely wrong in terms of imaging, in terms of what is dead. What we see on our scans is just not what is actually dead. And there's islands of viable tissue that are actually functional. So that's one possibility. And the other possibility is exactly what you're saying, that, you know, there's, as we discussed in Toronto, I think perhaps there's recovery benefits that are related to reperfusion. And there's a recent paper from the from Götz Tomala's group, from the Hamburg group in Germany, suggesting that in the large core patients, the biggest component of benefit from reperfusion is reduction in edema rather than penumbral salvage. But yes, we're missing something in this story. That's for sure. That theory of core penumbra mismatch and penumbral salvage and all that is kind of being put into question by the large core trials. And I just want to just make a plug to or just announce that just a few days from now, Wednesday, I think, during SLICE, there will be a presentation of the largest of the large core trial. Last day, I was privileged to be one of the PIs, co-PIs on this study. And I can tell you, and David has seen all the scans, the median infarct volume is 150 cc's. And this is a 0 to 5 aspect score trial with patients, about 100 patients that had aspects of 0, 1, and 2. So, that will, I think, that will clarify a lot more this theory, whether there is benefit of reperfusion or not, regardless of the size of the core.
Tudor, this is Jeff Saber.
Yeah.
And I rise to defend the penumbra hypothesis. The large core trials have not looked at penumbra in these patients. So you can't say that just because you select without using penumbra, that penumbra wouldn't have improved your selection. I would suggest that if you have a 150 cc core and a 300 cc perfusion lesion, which probably the majority of these patients have, there'll be a great deal of benefit. If you have a 150 cc core and a 75 cc perfusion deficit, I doubt there would be benefit, and we simply don't know. So be careful about absence of evidence is not evidence of absence. Thanks.
Well, I mean, look, I do respectfully, I do partially agree with you, but I must point out that, Select 2 had patients with mismatch, and there was no evidence of any kind of differential treatment response in patients with mismatch versus those without mismatch. And you can say that we don't know how to measure penumbra, and I agree with you. But just based on the criteria that we have in terms of measuring penumbra, and in support of what Jim said about the infarct volumes, in tension there is a minimal difference in final infarct volumes between treated and non-treated patients. So that also supports the theory that perhaps, and I'm not saying that penumbral salvage is not a major mechanism of benefit, but perhaps there are other benefits that we don't understand. And again, this data from tension where 24-hour infarct volumes were very close and very large in both groups, suggests the same to me.
And I'll add in here related to that, and I'll be very interested in Greg's thoughts too. I think when we talk about the penumbra, what we haven't and I suspect that there's more going on than meets the eye that we have opportunities to measure within the infarct. So we kind of joke in our stroke team right now that an infarct is like a chocolate chip cookie, and there are these chocolate chips that we're trying to fill in the gaps in. So it's about the quality of the infarct, and then it's about the degree of infarct. So it might just be also like almost like micro penumbras within that infarct volume that we've wondered about, and I'm sure a lot of you have thought about too. So I just wanted to throw that out there.
That and exactly, Pooja, that has been published by I think Greg Albers was one of the authors, and Jean-Claude Baron, and that's exactly what they're saying, that that there are micro penumbras and micro cores, and maybe something must explain this, because that would be we have no idea what we're measuring component. That again, what we think is infarct is different shades of gray, and we can't appreciate everything that is dead and everything that is alive, even on the final infarcts by imaging.
Hey, Tudor, this is Greg. Thanks for the nice summary of the studies. A couple comments. One on the IV thrombolysis and the late window being dead. I think we still need more data. One of the things that was impressive in Extend IA-TNK was that there was a 20% early recanalization of large vessel occlusions. We didn't get to assess that in Timeless because for various reasons we couldn't treat anybody out at the outside hospitals, and we had very short dwell time. We did have a small number of patients who did recanalize early with TNK versus placebo, but the number was too small to move the dial. I think if people are using more TNK, and I was just talking to Michael Hill about this a couple of weeks ago, they're seeing a lot of patients, and they estimate 20% do recanalize early with TNK. If you're doing the, drip and ship, it's now just inject and ship. So there's a potential benefit for those that we couldn't examine in Timeless. And then there's also this interesting data looking at the patients who got treated right at the time of the endovascular procedure, where it looks like there may be impressive trend for those patients. So again, the idea that maybe there's some cleanup or some improvement in TICI scores if you have the thrombolytic on board, I think that deserves more evaluation. In terms of SELECT showing that no mismatch doesn't benefit, there's going to be more data coming out in a separate paper, but the definition from the New England Journal was a definition we've never used for no mismatch before. It was a definition where they looked at really hypodensity on the non-con CT for the part of that definition. The patients who had a standard, typical no mismatch as we've defined it in prior studies, what the investigators saw at the site, there were 9 no mismatch patients in the endovascular arm and 18 in the control arm. So there was, obviously no statistically significant difference. There was no patients there. So I agree with Jeff. I think we've got more to do to clarify some of the mismatch questions.
Yeah, I mean, we can always get more data, but I think I just think that what the data that we have right now points towards absence of mismatch indicating benefit, and pointing towards no evidence that mismatch is predictive of response to treatment. And maybe we're going to generate more data. And with regards to the Timeless results, I do think that when we have and the role of intravenous thrombolysis prior to endovascular, I think that when we have IRIS with 2,000 patients showing a very clear relationship between time to treatment and benefit from IV, I mean, we can try more, but what are the chances of being successful? I think perhaps there are other approaches. I do believe that perhaps the benefit from thrombolysis may not be with regards to large vessel recanalization, although we've seen that 20% reperfusion, but these patients reperfuse with endovascular anyway, and they're all slow progressors. So that time that it takes to be transferred, and when they present directly at endovascular centers, it's even less, may not be that important. I think that the big benefit of lytics before thrombectomy has to do with microcirculation, and maybe we have better drugs for that than TNK. I mean, I'm not saying that we should give up on antithrombotics prior to a thrombectomy, but I'm not sure that TNK or TPA or these class of drugs are the best. I'd like to see what most will show. There's a lot of unanswered questions, but I think perhaps the answer may be in the microcirculation, and there may be drugs that are better than TNK and TPA. And then, of course, neuroprotection, even though it's a disappointing story, that to me still has more potential than going with lytics.
Thank you very much, Tudor. So we're going to move on. Pooja is going to give the next talk. And we're going to move Santi's talk to a little bit later because otherwise he almost missed his flight. He was on the edge of his seat. Go ahead, Steve.
Okay. So we're going to switch gears a little. Hopefully I'm effectively sharing my slides. I think we need to project them up there.
it shows up as shared here. There we go. Okay, great. So shifting gears to low night stroke scale score, and I assumed based on TTST, we probably want to talk about it from both thrombolysis and thrombectomy perspective. So I hope I got that right. And so I'll just really briefly kind of give an overview of, I think, where we're at and look forward to the discussion. I think I'll just note that, Sarah Novis, I'm one of the MPIs for the ENDO-LOW trial and getting a grant through them, and then was getting money from Genentech running the PRISMS trial a few years ago. So, when we talk about mild stroke, think about it in terms of those we don't know for sure that we should reperfuse. And so low night stroke scale score is definitely not the right, definition for that for IV thrombolysis. I think this group here has thought about this a lot and agrees with me. We're really thinking about those who are 0 to 5 without clearly disabling deficits. And the reason for that is we've gone through the trials, all had exclusions for minor deficits. And, way back, we actually did structured interviews of the NINDS trialists. And for what it's worth, that was their intention too, to not include those. That way they thought that we're going to end up having relatively mild deficits and that weren't clearly disabling. Whereas for thrombectomy, we have like a systematic exclusion in our trials of patients with NIH stroke scale score 0 to 5. And I think that many of the proceduralists in the room would agree that there are distinct procedural aspects that change that risk-benefit ratio that are very specific for that low NIH stroke scale score population. So let me start by just talking about IV thrombolysis then. As many of you know, we all, and Jeff's in the room here, was part of the team. We tackled this question with the PRISMS trial. And we worked really hard on that definition, and we operationalized those with not clearly disabling deficits as those when you judged at the bedside to not have clearly disabling deficits based on activities of daily living or the ability to return to work. It was a joint decision between patients and families. And we made a real emphasis about doing a bedside swallow study and walking the patient. And I worry that sometimes that gets lost in translation, so it bears repeating. And I'll just remind everybody that we gave examples of patients that should and shouldn't be enrolled, and so to always, consider individual circumstances. So long story short, the trial stopped early for operational futility. Excellent outcome was numerically higher in the aspirin arm compared to the alteplase arm, 81.5% versus 78.2%. You can see our primary endpoint here, the adjusted risk difference of minus 1.10%, basically favoring the aspirin arm. And this was published, I guess it's 5 years ago now. So, and the bleeds were there. They were real. They were around the rate we anticipated at about 3.1%, 3.3% when you do the risk difference calculation. And so it kind of left us in the situation of saying, you know what, I'm not seeing evidence of benefit numerically, and I'm seeing a real harm in these patients that were judged as not clearly disabling. The recommendations changed in our guidelines. And there we were. And I have to admit, I lost sleep because I worried this could have been a spurious result. I also really worried that, we didn't have potentially the most sensitive endpoints. And maybe if we had a more sensitive endpoint, we would have seen, a clear difference between these two treatments in favor of thrombolysis. But we really didn't. And so I felt a lot better, though, when Aramis came out. And I don't know how this has hit the radar of everyone, but it was published in JAMA. I think I mistyped that. I think it was JAMA, not JAMA Neurology, right? Yeah, JAMA. And this was in China. And interestingly, and this is some context that I actually found really helpful after reading the paper. It was in China, they're actually mandated to treat as much as possible with IV thrombolysis, to the point that they feel mandated to treat even the most minor symptoms. So even though our guidelines actually recommend against it, they treat those patients. And then so they did a non-inferiority study where they said, okay, these patients are all going to get IV thrombolysis, even though they're very mild. And then we're going to randomize them to dual antiplatelet therapy. And we're going to see if dual antiplatelet therapy is non-inferior to IV thrombolysis. So they used clopidogrel and aspirin, and basically sort of what was basically the chance formula with the lower dose loading of clopidogrel, and then treated out to 10 to 14 days, as we all know is about the optimal time for DAPT. They defined their mild strokes a little differently. It was 1 point or less on single NIH stroke scale score items and no score on the consciousness item. But in some ways pretty similar. I think I found that, to be comparable enough. It's the best data we've got. And to my surprise, and maybe too reassuringly, it numerically went in favor of the dual antiplatelet therapy. So 93.8% had excellent outcomes by the modified rank in 0 to 1 at 90 days. And it was 91.4% in those in the alteplase group. And if you look at the risk difference, it's 2.3% favoring DAPT. So they actually met their pre-planned minus 4.5% non-inferiority margin. In fact, it went in the direction of superiority, if anything, and they were able to declare that. So now I kind of, and I look forward to any provocation or debate, but I find myself thinking just kind of more like logically, if you've got two cruder, endpoints that are going in the wrong direction, it's sort of hard to imagine that a more sensitive endpoint is going to take you in the other direction, but certainly open to ideas and start to think that frankly, this probably isn't the right treatment for our patients, certainly not IV alteplase. We could make some debate whether tenecteplase would act differently. And I certainly say that, there are probably patient subgroups where this risk-benefit ratio would be different. And those with LVOs, I think we all think about that because they have a significant risk of decline. Those with any visualized occlusion or perfusion deficits like TEMPO2 is testing. And then it's been brought up those with MRI DWI lesions, because it's sort of like a degree of severity of ischemia, maybe with location mapping even. So the TEMPO2 trial is ongoing. I meant to fill in that box. I don't think I heard back by text from Andrew or Sheila about the enrollment rate. Does anybody here know if how far along TEMPO2 is? I was curious about that. I know this meeting tries to stay cutting edge, which I love. I'll let you know if I find out later. But I'll switch gears then to thrombectomy. And you all know the trials well, and I will ask a pop quiz. How many of the greater than 2,000 participants enrolled in pivotal trials of endovascular therapy, both early and extended time window, had an NIH stroke scale score of 0 to 5? I wish I had like Jeopardy music going. No one's going to bite. Pardon me? 5%. So what would 5% of 2,000 be? That would be like 40. Try 14. That's how many. It was basically 10 from Mr. Clean and 4 from Extend IA. So we did not study these patients at all in any of these pivotal trials we've talked about. So 14 is the number. And the question here is about just keeping in mind this literature gets messy. The question here is always about that immediate decision. We know what to do when they decline. We know when if they decline, we should definitely rescue them. But it's about those patients that up front look relatively well. Not saying they look great, not saying that isn't an important disability, but that look relatively well that weren't put in these trials. Should we allow them that potential for a 20 to 40% decline in that first 24 hours, typically in the first 8 hours, that has been well documented by many people? And there's a lot of reason this group would be considered differently. And I think I don't have to tell this room about this because you all know better than I do, some of you proceduralists in the audience and online. But these are patients who typically have good collaterals. That's how they can have an LVO and have low NIH stroke scale score. And there's great data out there. One of my favorite papers is the Centers paper that showed that there's a dose-dependent effect. The more collaterals there are, the more likely IV thrombolysis will actually work for these patients. So it makes you wonder, does thrombectomy make sense? And then the harder one is that good collaterals often mean underlying intracranial stenosis, which increases our procedural complications as we're trying to get that catheter through that narrowed wall and potentially even inflaming the plaque, leading to reocclusions. So these are real issues. And I think I would say, I'm curious if anyone in this room feels differently, but I think this has been, at least in my career, the most equipoised question that we've had in endovascular therapy because we all just don't know the right answer. There have been a bunch of non-randomized studies, and I just pulled, these are the two that I tend to look at the most. I feel like when you're looking at non-randomized data, it's all about propensity methods. And these two studies, which were large, one was a large Swiss registry on the left. The other was a really nice 3 prospective international cohorts, and then again, propensity matching in both. And interestingly, for both of them, if anything, they favored not treating with endovascular therapy, sort of adding to our equipoise about what we should do with these patients. So our guidelines, basically, the United States says that may be reasonable based on very limited evidence. The Europeans say just enroll in randomized trials, but of course we don't always have those. I would say many of us in our practice think about the blood pressure at presentation, because we know that blood pressure can't just artificially stay up for so long. And those are the patients we worry about. We worry about the nature of the deficits, if they're clearly disabling. We worry about the vasculature and access issues, and then comorbidities to think about these issues. But ideally, we are randomizing. And I will say that I think there is a lot of energy to randomize. So Endo Low is underway, that I mentioned, funded by an investigator-initiated study from Sarah Novus. And we're testing, actually, I need to, oh, that slide, this is a slide I pulled. It's actually within 8 hours. I pulled that by mistake. NIH stroke skill score 0 to 5 within 8 hours. And our enrollment has been 84 patients out of 200 for that phase 2 portion of a seamless phase 2-3 design with sample size re-estimation. And then, that's why I'm reading this wrong. That's our second one. In extremis is the one within 24 hours. And we just heard about LASTA. And so MOSTA is actually doing really well. I swapped those, so apologies. It's 497 enrolled out of the 800 planned. I'm very jealous of them, whereas we're the one below the phase 2-3 seamless. And that's the one that's 84 out of 200 phase 2 patients. And sort of hot off the press, we actually pulled out M2s at the recommendation of our DSMB, because I don't know the full story. I'm not privy to that level of detail, but what I know is that they wanted us to require perfusion imaging to enroll patients. And that was cost prohibitive for us. So I'll just tell you one more development that's nice to know, sort of cutting edge in the field, which is that the Endo Low trial is actually going to fold into the STEP platform that some of you might have heard about, that's been in development and now approved for funding in NIH StrokeNet, with the grant award expected in December. And I think Jeff's going to talk about this maybe later in the meeting briefly. But basically, just very briefly, is it's patients being put into multiple domains of a platform trial, where each domain is a mutually exclusive intervention. And the first one is endovascular therapy for indication expansion. And then patients can be in multiple domains to get efficient answers. And so for STEP, our indication expansion domain will consist of patients who are 18 and older within 24 hours of last known well, with pre-stroke modified Rankins of 0 to 2, and will allow NIH stroke scale 0 to 5. And I'll mention that the modeling considerations, we're going to have data-driven cut points planned. In fact, that's how it's designed right now. And we're going to explore subgroups that include clearly disabling and not clearly disabling to help us sort this issue out. So we're very pleased to see what was a slow-going trial have its data used in a blinded fashion towards a definitive result of a phase 3 trial. So that's going to be good. So I'll just end by saying that treatment with reperfusion therapy, I think at this point, depends on the specifics. Clearly disabling deficit, I think we all agree you need to treat with IV thrombolysis. And if there's an LVO, we ideally would randomize them in a trial that tests endovascular therapy versus medical management, even if they're 0 to 5. Not clearly disabling deficit, we generally aren't treating with IV thrombolysis. But if there's an LVO, we're ideally randomizing. If there's and I have to admit, it's a tough one. It really is a tough one, what to do on a day-to-day basis. So let's get these randomized trials done. So thank you for your attention, and I look forward to the discussion. Yes,
Thanks, Pooja. Just two questions. Well, one is, so I think you mentioned PRISMS and ARAMIS, and there's like a third Austrian registry also that was published in Neurology earlier this year. That's about 3,000 patients, non-randomized, but also showed that DAPT was as good as IV thrombolysis with less bleeds.
Yeah, there's been some non-randomized data. I just focused on the randomized data.
I guess one question I have is, how much confidence do we have about even the disabling low NIH patients? Because this, comes down to this clearly disabling, which is subjective. It comes out medical legally. People get sued because they didn't give TPA for ataxia. Maybe you can't walk after ataxia. NIH is one. Is that something 100 neurologists would agree has to get thrombolysis? So I think there's, at least in my mind, with all these non-disabling studies suggesting perhaps some harm with intravenous alteplase, even for disabling ones where there's a lot of subjectivity, are we really at a point where we have class 1A evidence to say all these patients should get thrombolysis. And then secondly, for the, at least for the endovascular trials, I wonder if we need to be more nuanced as to who to randomize and who to select, because we know in clinical practice, the patients who are super hypertensive, positive heads-up test, fluctuating, are very different than the patient whose blood pressure is 120. You set them up, they're walking around just fine with an M1 occlusion. And so I wonder, just like with ICAD, do we need to be thinking about selecting for flow failure patients? I know you mentioned CTP in the endolo study. So I wonder with the low NIH studies, you know, if the sort of kind of retrospective studies have shown perhaps some harm with EVT or no benefit, if these randomized trials don't show benefit, I wonder if we're going to be going back to the drawing board and saying, we really need to find out the really high risk ones. And do the current trial designs really address that issue?
I think those are both great points, really tricky questions. So I'll start with a second one and welcome any other comments as well. So I think that is really a concern, right? You know, are we choosing the right patients? Are we overgeneralizing? What I will say is that if a site is doing like a heads up type test, we're recording that. If they're fluctuating, we tell them not to enroll. That's as far as we've gone. We have not made blood pressure a make or break decision. It certainly makes me think, Jeff, as we're kind of finalizing the STEP platform, that I really do think Ashu's got an important point here, that if how we can stay ahead of this in the STEP platform in terms of data collection, because it does, I think it's a really, really valid point is the bottom line. And then for the first question, it is, so, you know, the hope was PRISMs was going to be positive, and then we were just going to say, let's just treat everybody, but that's not what happened. And it's a fair point. There weren't that many 0 to 5s in these pivotal trials. So do we have data? Not that much, but do we, as a community, feel that we should randomize somebody who's got an NIH stroke skill score of 3 and can't walk, predominantly with, you know, leg weakness? I think if you just think about the risk benefit ratio in terms of the bleeding being the main risk, that we'd rather take that risk. And I just don't know if anyone would ever want to do that trial. And I don't think we have the equipoise to do that trial. But I mean, if others have other opinions, it would make me very uncomfortable. I'm not sure who would randomize in it is the bottom line, but it's fair to say there isn't a lot of evidence. Yeah. Hey, Eris.
Thank you so much for the great presentation. Two questions. So first question, is testing for non-inferiority appropriate in low NIH? And the reason I'm asking that, because you're expecting a minimal clinical benefit, and you know your outcome is going to be biased towards a null, right? So that's the first question. And the second one, which is kind of attached to that, if MRS is the appropriate score to test as a primary outcome in those trials, whether we need some measures with more granularity, more power, maybe a combined outcome, patient-centered outcomes. So I don't know, what are your thoughts about it? And you know, to my first point, I'm worried about the repercussions of ARMIS in clinical practice, and I'm not talking about places where stroke neurologists are, but because, you know, those trials, the guidelines will be read also by, you know, primary stroke centers or centers that they don't have stroke neurologists. I don't know what is going to be the implementation to clinical practice. So, you know, the worry in here is that, you know, we're taking a step back and taking out, you know, some intervention, right? And I'm not saying that this is not the appropriate thing to do. I'm just sharing my concerns with you and the rest of the group.
No, I'm really glad you brought this up, because I've gotten invited now twice to be participating in meta-analyses where they want the punchline to be, we shouldn't treat NIH stroke skills 0 to 5 with thrombolysis, and they're lumping the non-disabling and the disabling. And there's a lot of potential misinterpretation that could go on here. So I've pushed one of the groups change their definition. And so I felt comfortable participating because I just don't think that was the right question to frame. And we didn't even know, you know, in some of the trials, whether they were non-disabling or disabling, to be able to lump that together like that. And you can end up getting pulled to the wrong answer because the dominant group is non-disabling. So that's one concern that Aramis worries me about. And then your other point about the modified Rankin and I'll tell you the non-inferiority point. I have to admit, Aramis didn't make any sense to me, because we're looking at non-inferiority of clinical outcome for DAPT, which is designed to prevent stroke recurrences, not really affect outcomes. So it was a little bit confusing to think about that way. And so I agree with you that non-inferiority might not have been the right design there. But when it comes down to it, if you'd asked me before Aramis, I would have said, yeah, maybe a more sensitive endpoint would be helpful. But I guess just the logic of having 2 trials numerically favoring antiplatelet therapy in this cohort, and that big crude modified Rankin still going in the wrong direction, makes me say, even if I got that granularity, who am I going to convince to do another trial with granularity? Because the odds are actually against it working if the crude definition is taking me in the wrong direction. But does anybody want to argue that? Because this meeting is meant to be provocative.
I don't want to argue it. I just say it's somewhat subjective about what's disabling and what's not, right? If it's mild ataxia, is that disabling? If it's moderate, it is. If it's severe, it is. If it's a bad sensory deficit, can that be disabling under some conditions to some people? So you're an expert on this. How do you teach your residents and fellows what's disabling and what's not?
Yeah, I'll say that I've really, a couple things. One is the strict definition in PRISMs is not able to do basic activities of daily living. So like that patient, the ataxia, if they're a dancer, that's already clearly disabling for them. So it's like talking with the patient and understanding their lives. Whereas the grandmother who's 85 years old with, stage 4 CHF, like if she's just a little bit off balance, she probably doesn't want that hemorrhage for that benefit. So potential of benefit. So that's kind of the way I frame it in my head. And I sometimes do have mission creep where I find myself thinking on an individual patient level, even about instrumental ADLs based on how it affects their quality of life. But that's sort of my thought process of how I think about it. It's a very individual decision where it's just not black and white. Thank you.
Pooja, thank you. This is a topic that's close to my heart and interest, also as a teacher and researcher, but I want to be also time manager. So I'm the chair of the next session, and we need to stay on time. That's number one. Number two, the next speaker has been patiently waiting. And David, I hope you introduce him. And finally, keep your questions or boiling points for the last hour tonight, because Jim and I are going to duke it out. Look at the program. Last hour, we will have lots of time to talk.
Sounds good. Thanks.
Hi. Oh. Can you hear me? Hi. I'm Naoki, neuroendovascular physician at UCLA. So I'm going to talk about ICAT technical aspect. This is my disclosure. So we have a laboratory on campus. We do a lot of simulation, mechanical testing, and also device testing. We do make a clot, artificial clot, and then we do a lot of thrombectomy experiment. So there are various topics concerning the ICAN management. And since there are rescue therapy talks by Tatsushima tomorrow, and also the balloon angioplasty and the stenting also by Dr. Sakai tomorrow. So today I want to talk about the primary therapy for the ICAD LVO. So ICAD LVO, so when we have a stroke in the area of the stenosis, and then we do endovascular therapy in general. And then if it's recruit, and then we do a rescue therapy if needed. And then if it stays open, and then we just absorb. So what would be the best option for the primary treatment for the ICAD LVO? So we have several techniques: centrifugal only, aspiration, or combined technique. And then there are a couple of papers from East Asia. So this is a paper from Korea. So they compare the centrifugal technique versus contact aspiration. And then they saw the MTK was higher in the SR group compared to the contact aspiration group. It's a kind of a lot. 2B2C is much higher with the centrifugal rather than the contact aspiration group. And they also looked at the side effects too, and they saw a spasm with the central driver a little bit higher, but the iatrogenic dissection or rupture was much higher with contact aspiration. That's kind of surprising to me. I saw the contact aspiration is safe at the time, but the so and then state retriever, and then I saw the stent retriever may scratch the aceral plaque more, and then they make angry. But this makes made me a little bit different, think of a little bit different way. So there another study from Korea, and they compared again the stent retriever versus contact aspiration, and then these so they saw the faster opening revascularization with the stent retriever, and the switching to alternative thrombectomy was higher with contact aspiration. There was 40% with contact aspiration. That's a kind of high too. And then from China, they compared the Slambra technique. There is no detail here, but the Slambra technique, combined technique versus aspiration group. And then, interestingly, the rescue treatment after first line thrombectomy was higher after the contact aspiration. So probably the contact aspiration may make the plaque angry more than stent retriever. So this is the our in vitro model with a stenosis here, and then if there is a clot here, and then the this is a Cat5. That is not that big for the M1 ICA, but if you have stenosis here, that is much bigger. This idea of the aspiration catheter OD is much bigger than the stenotic area. So the atherosclerotic plaque is something like this, and then let's say if we have a 2.5 millimeter ID is 70% stenosis, and then the ID is about 0.75 millimeter, and then if you have a 21 microcatheter, it's a little bit bigger than that, and then SL10 is smaller than that, so it's okay. But if you have a Cat5, it's incredibly bigger. So if you try to push, and then you may dissect. So that's why they saw the higher the side effect, the dissection and also the rescue therapy with the aspiration group. So there are so many names for the combined technique. And then we try to make it simple for the in vitro experiments. So we call the technique stent retriever is pulled out, so ingestion technique, and then pinching technique is a pull catheter and stent retriever together. So this is a combined technique, pull stent and catheter together with Tiger Retriever. Tiger Retriever you can deploy through the 17 catheter, so maybe okay. And then so this is the ingestion technique. So when you do the ingestion technique, you pull together, and then if there is the so the slack in the aspiration catheter, when you pull both of them together, and then aspiration catheter may advance. So that's the thing we have to be careful, and then they may shove that stenotic area. So in general, ingestion technique is safe, but for this purpose, ICAD LVO maybe pulled together may be safer because you can avoid that catheter advancement. So this is the data we evaluated the distal vessel traction for MIVO and the stent retriever versus a combined technique. Of course, the aspiration technique probably leads the traction force, but we compare that pinching technique, ingestion technique, and the stent only. And then if you can see the stent only technique, you pull the vessel more than the ingestion technique. So one more time. And then if you have an aspiration catheter here, and then you can pull the stent retriever inside you here, so you don't pull at all. But if you pull centrifugal all the way from the bottom, and then you pull the vessel more. So this is a force we observed with the centrifugal is much higher than combined technique. And then doing the ingestion technique, maybe least force among these three techniques. But as I told you, if we have a slacks difference between the aspiration caster and the centrifugal, and then if you pull aspiration caster and the centrifugal together, and then when we have a slack of the aspiration caster is bigger than the delivery wire, the slack of the center wire, and then aspiration caster will advance. And then I pull this together at the same time, but the looks like aspiration caster looks a little bit advanced because of this tortuosity. Once you deploy the stand and then you push the aspiration caster later. So that's why if you have a tortuosity and then the aspiration caster has more slacks rather than the delivery wire of the centrifugal. So, and then, so probably the pinching technique would be safer for the this acial region. And we also evaluate how much endostream damage could occur while the centrifugal. We have a technique to coat the endostream inside this in vitro silicone model. So this is a paper we published before. We have a nice 3D rotational machine and then the incubating the culture incubator, and then the culture medium with viscosity close to the human blood is circulated in the model, and then we scratch this model with a stent device, and then so this is the result after this scratch. We observe the endostream under the confocal microscope, and this is a control. So we see the 100% endostream inside the model, and then it travel. This is XP. So there was the 20 at the time, and then you see some scratch with the endostream, maybe more in the inner curvature than the outer curvature. So the Tron is a Japanese company. Centrifugal has a similar pattern, endostream scratch. And the Catalyst 5, that was surprising to me. This is the 2.5 millimeter vessel here in M1. And then I navigated the microcaster in M2 here. So the less endostreal damage, but I saw the more endostreal denudation in M1. So of course, this is an in vitro environment, but if you have done an animal experiment, the similar things happens. Endostream easily denudated by the aspiration caster. So if you use a little bit big size of the aspiration caster, easily you may denudate it and also dissect the vessel, especially in the ICAD lesion. So how about the centrifugal? What kind of centrifugal would be good for this combined technique? So the interesting paper from Dr. Paolo Macchi group. So they compare the bunch of stands, and then this is the radial force. This is a comparable number, but they compare the pull-up traction, and then the difference. So Embotrap is a segmented design, has a higher traction force than other closed cell design. So the other Chinese group also evaluated how much pulling force. We did a similar test. They measure the friction force of the centrifugal, and the Eric is also the segmented design has the most highest pulling force, friction force than the other closed cell design. So this is a kind of old stand, and then so the length is different now. So, so this is my case, and then this is we put the sorry, just 3x20. 3x20 is the shortest stent we have, and then we also have a Tiger, but this is very gentle pull, and then luckily this case it stayed open, so we didn't do anything. So in conclusion, so for the ICAD LVO, so combined technique with the closed cell centrifugal design may offer the increased safety and efficacy. And the so of course we have to have a data more, but so if you wanna retrieve the clot in the maybe this technique may be helpful. And yeah, I'd like to thank the researcher, especially Dr. Imahori and Dr. Tatsushima, Dr. Sakuta here. So that's all. Thank you so much.
Inoki, thank you so much. I mean, I think the work you guys are doing in that lab is really incredible because in many ways, ICAD LVO is one of the last few remaining lesions that we can't treat well, you know, with endovascular therapy, and we made so much progress in other things. I guess the question I had for you is, one of the things that I've been thinking about recently is right now we dichotomize LVOs a lot based on it's ICAD LVO or it's not ICAD LVO, meaning it's a healthy vessel that got clogged with a clot, or it was a diseased vessel and, you know, in situ thrombus or something happened there. But I wonder if it's really not one or the other, but it's more of a continuum. And I think the reason that this matters is as you were showing, you know, there's so much going on with endothelial cells in ICAD compared to non-ICAD. And I wonder if that affects how patients recover from stroke. If we start to think of these LVOs as more ICAD-like, even if we don't see the ICAD in that same sense. You know, earlier we were talking about why patients with large core, they don't have smaller infarcts when you do thrombectomy, but they still do better than not getting thrombectomy. But the converse is also true, where we have plenty of patients that have very small core, small final infarct volume, but they don't. And I'm wondering, you know, I've seen that pattern in plenty of ICAD patients where we open the vessel, they don't develop big stroke, but they don't get better. And I wonder if that same sort of biology or physiology of reperfusion and endothelial injury is happening more commonly than we expect. We see it in the ICAD patients, but it's also happening in non-ICAD patients.
So yeah, that's great point. And there's a one paper from San Diego. I believe that's a UCSD group. So they saw the follow-up MRI, 1 year follow-up MRI, and they saw the 10% restenosis rate after the thrombectomy. And then they evaluated the that how much endothelium is denudated by the centrifugal. So and then that may cause the endothelium injury and cause inflammation or whatever. But most of the case, anyway, we have to open. So and then if we one thing I can tell is how much endothelium is denudated. I think it doesn't matter well in this type of acute setting, but that may cause some damage. But most of the endothelium just recover very well, I believe. So that's why we don't argue that the endothelium denudation a lot. But still, if you denudate more, and if there is, of course, I'm from Japan, I saw so many ICAD patients there. Of course, there's spectrum, right? And then some case, you know, some overlap, and then if you scratch more, then it more, and then pull more, and then of course we may have a higher risk of in the acute setting as well as also a little bit subacute setting. Especially in the acute ICAD case, and then like that, how much more rescue therapy is needed by the each technique, and then they saw the aspiration catheter, maybe rescue therapy was higher, and then centrifugal technique maybe less. So that means that we have to think of how safely or take care of that region. That's a kind of important, but it's a little bit hard to evaluate. So that's why we don't discuss a lot, I think.
I'll have to share my screen, right? Is that okay? Yeah. Okay. So my topic is update on distal lesions, and I think it's a controversial topic. So let's start, if I can, the presentation. These are my disclosures. And we can start with a nice case. So NHSS5 patient comes in the early window, so 2 hours after symptom onset. And we do the imaging on CT. There was nothing important. CTA shows something on them too, but we weren't sure. CTP, our MIVO detector, shows nicely a deficit there. So we went on and treated this patient. These are the angio images. You can see here the distal or non-dominant M2 occlusion there. What do? Go with an aspiration catheter, aspirate, and then vessel is open and patient does well after that. So that's it with my presentation, right? We can aspirate and we can treat all these distal lesions. Well, not really. I mean, in this case, we didn't have bleeding, and in this case, everything went well. But regarding the technique, I'm not so sure after doing a couple of those that aspiration is the best technique to go on and treat those patients. There is this nice meta-analysis where you can see actually that the combined group, even for those distal occlusions, shows better reperfusion results. But more importantly, I think that's what we all think, that if you use more materials and send retrievers in those distal lesions, you will have more severe bleedings. Actually, you can see that the symptomatic bleedings are 1% as opposed to 8% if you do just aspiration. So this is something to keep in mind, and this is something that I also have seen in my experience. You see more of those subarachnoidal hemorrhages or contrast on FTCT. With a combined technique, but the severe bleedings are more with aspiration. Regarding if we should treat all those M2s, well, we don't have evidence at the moment. We have only evidence from randomized trials for M2 dominant lesions. So I think we should randomize those patients and we should do trials. And that's why we started 2 years ago the distal trial in the Europe. It's a randomized trial about distal or medium vessel occlusions. The design is a pragmatic one, so we get the patient in the hospital, we do the normal workup, give TPA, and then we randomize into EVT or no EVT. And the primary endpoint will be the shift of MRS after 90 days. Some of you here in the room are in the steering committee. Thank you a lot for the support. And some of the companies have also supported us unrestrictedly in this trial. So again, thank you a lot. These are the countries at the moment that are in the trial. We started in Switzerland and then went on and included patients around Europe. At the moment, this is the patient count in the beginning of the month, 265. You can see mainly in Switzerland randomized, but also Spain and Germany really strong. This is a graph as of the beginning of October. Today, we just hit 280, so October is going well also. And if we continue like this, we will be ready by the end of 24. Of course, there are also other trials. So if you're not in Europe, you can also randomize your patients in one of those other trials. And I think this is an important thing to do in the next months because we need randomized data on those occlusions. One thing I can share with you is that we had the first DSMB meeting in July for the distal trial, and we did this after 150 patients. They told us that there are no safety issues and we can continue randomizing patients. Let's go on to a second case. 72-year-old patient, NHS of 8 with aphasia and hemiparesis. Native CT was okay. CTA, again, not sure if you can see something there. I wasn't really able to see something on CTA. Perfusion, our MIVO detector, shows a deficit. You go back to the CTA and then maybe you find something, but if you don't, we usually go to angio and try to find the occlusion. Here are your single cards in this case. So again, an M3 occlusion in this case. those runs from the M1 with the big aspiration catheter help us a lot to find the road to the occlusion. So don't just stick with your road maps from the carotid. Do selected and focused runs from the M1 with a big catheter, and then go all the way to your occlusion that you can nicely see here with the green arrows. In this case, again, I use the combination. So mini stent retriever, small stent retriever, and a small aspiration catheter. And then the bigger aspiration catheter is in the M1 and is acting like, if you want, another joint there, or also like kind of a control for emboli and fragments where you're retrieving. The result here was good in this case after one pass. And we see no bleeding on the FTCT and a small lesion on DWI. This is my setup for those M3 occlusions. So usually we try to use a combination of a big aspiration catheter in the one and a smaller one in the M3, but also a stent retriever in the M3 or from the M4 to the M3. Again, I think the time is not enough to go into detail about techniques. You can find all this information also on this publication. We call this the Quattro technique, or also on our YouTube channel, we have an hour-long video on distal lesions. So you can see this there. Regarding the why we use those two catheters is because we want to reduce the forces on the curves. So actually the tip of the catheters is acting like a joint, and when you're retrieving, then you're respecting the curves more and you're not straightening the vessels. You can see it nicely here in this case. While retrieving, you can see how we respect actually the curves here. So again, one problem could be straightening when you're retrieving. The other one is if you aspirate early enough, then you will collapse the M2s, and then you will retrieve in a collapsed segment, and that's going to produce some relevant bleedings. So again, try to time your aspiration at the moment when you reach the clot with a small aspiration catheter, or when you retrieve the clots in the big aspiration catheter, then start the aspiration there. This is another case of, it's the same case with just some numbers now. Just to prove a point, you can see here the small vessel, it's 0.8 millimeters. And one thing that I think a lot of us have been talking to the companies for some years is that we need more devices for distal occlusion. And not just, a stent retriever, we need a setup. We need a whole setup with a small aspiration catheter, with a long microcatheter. And as you can see here, if you say, okay, I'll just aspirate, the vessel is 0.8. A lot of people are using the red 43. It's 152 outer diameter. Not sure if that's the best way to go. I think we need an even smaller aspiration catheter for those smaller vessels. And just a basketball reference, then I think we should name it KD35 as the small aspiration catheter, so no 35 outer diameter. Just to conclude, I think perfusion is still important as a MIVO detector. We use it a lot in Basel. Of course, thrombectomy of MIVOs or DVOs is feasible, but we need randomized data to prove that it's also helping patients. And regarding technique, we in Basel choose the combined approach as shown here. From the whole team, thank you very much for this invitation here. It's a group effort, and I'm presenting our whole team. And of course, the ESOC conference is going to be in Basel next year. So I'm really proud to be part of the organizing committee, and I would like to welcome you to our distal summit also that we are going to do in the pre-day of the conference. So keep that in your calendars. And yeah, thank you a lot for your attention.
That was a great presentation. I had two questions for you, just technique-wise. One is use of conscious sedation versus GA for MIVO. A lot of people use conscious sedation for LVOs, but there's literature's a little bit mixed, and there's operator comfort level. And then secondly, some of the trials are excluding patients that get thrombolysis. And so I'm just curious what your thoughts are, whether if thrombolysis is on board and there's a primary MIVO, does that change your approach, or does it really not matter at that point?
So we don't exclude them in the trial. We have our normal workflow, and we're being pragmatic on that. But I think if you want to show that your treatment is even more effective, you exclude those, and then you go on with a trial that only has aspirin in the control group, obviously, right? So that was the first one regarding anesthesia. I've started using doing distal occlusions with intubation. But actually, at the moment, I just do local anesthesia. Those patients are not severely affected. You can talk to them. You can explain what you're going to do. If you have, we still have anesthesiology in the room for the moment that we pull out, but until then, it's just local. For me, our fellows, they're probably doing intubation still. Thank you.
Hi, everyone. We're going to take a 10-minute break. So see you all again at 3:10. 3:10 Pacific time, to be clear. All right. Thank you. See you guys soon. Bye.
All we need is, yeah, what he's trying to grab some pepper.
Slowing down.
It's going down. It's going down. It's going down. Going going down, down. It's 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 going down. It's going down, down. It's going down, down. It's going down. It's going down. It's going down. It's going down, down. It's going down, down. It's going down, down. It's going down, down. It's going. It's going. It's going. It's going. It's going down. It's going down. It's going down, down. It's going down, down. Down, down. Down. It's going down.
Yeah.
Shinichi?
Yes.
Are you online?
Hi, everyone. Okay. Okay, thank you for giving me a chance to talk about our RCT, Rescue Japan. Yes, thank you. So I'm going to share my screen. Do you
All
see
right,
it?
why don't we switch gears? We're now starting the large core session.
Yes.
And I think we have Professor Yoshimura on the line.
Mm-hmm. Yes. Do you see my slide? Okay. So
We don't
okay.
we don't see your slide yet. Give us a
Really?
second.
Sure.
Okay.
Yonglong, can you get him to share screen?
Okay. Okay, do you see my slide?
Who's presenting? Shinichi? No, Yoshimura, Japanese. Okay.
Okay. Thank you.
Wonderful. Wait, let's just make sure we can hear you, Shinichi. Okay, go ahead.
Okay, so thank you giving me a chance to talk about our RCT regarding large ischemic core named Rescue Japan Limit. This trial was done with Dr. Hiroshi Yamami and Nomiyuki Sakai and other investigators in Japan. This is my disclosures. So this is a AHA guideline recommending the MT for the patients if they meet all the following criteria from 1 to 6. However, our frank question was how many patients can receive MT at a time. In real world, according to our nationwide registry, only 15 to 20% of the patients met this guidelines criteria due to location other than ICA or M1, aspects below 6, NIHS below 6, or other contraindications. So we thought that treatment indication should be expanded to save more patients. There are possible targets to expand the indication of MT from 1 to 5. We focused on large ischemic regions, aspects below 6. Before starting our CT, we looked back our nationwide data, Rescue Japan Registry 2, and found that a clinical result of EBT group was much better compared to that of a no EBT group. Adjusted odds ratio was 2.8. So we decided to perform a RCT to this target. Our study was a multi-center, non-industry supported, randomized, open-label per group clinical trial. Enrollment started November 2018 and finished September 2021, and follow-up was finished December 2021. 45 hospitals in our country participated in this trial. A study design was like this. Patient was allocated to one by one to EBT group and no EBT group. Key inclusion criteria was NIHSS score was 6 or higher, pre-MRS of 0 to 1, ICA or MR occlusion, and aspects of 3 to 5 on CT or MRI. Onset to randomization was 6 hours or shorter, or 6 to 40 hours with diffusion flare mismatch. Randomization to EBT should be finished within 60 minutes. Primary outcome was defined as MRS of 0 to 3 at 90 days. Among the 235 eligible patients, 203 patients were randomized to EBT group and no EBT group, and full analysis set was 100 in EBT group and 102 in no EBT group. This slide shows the patient characteristics of both groups. There were no significant difference in groups, excepting aspects. Aspects was a little bit lower in EBT group, 3 compared to 4 in no EBT group. In the other factors, there was no difference. And primary outcome, MRS of 0 to 3 at 90 days, was frequently observed in EBT group, 31%, compared to 12.8% in the EBT group. Odds ratio, relative risk was 2.43, and p-value was 0.002. It means that EBT improved functional outcome of acute elbow patients with large ischemic lesions. This is secondary analysis outcome, and MRS 0 to 2 didn't differ in our study. However, SIFT analysis showed EBT was better, like this. Safety outcomes. When we looked at the patient CT or MRI within 40 hours after the procedure, any ICH was more frequently observed in EBT group, 58%, compared to 31.4% in no EBT group. However, a symptomatic ICH within 40 hours didn't differ in the groups. There are some limitations in our study. MRI was dominantly used for diagnosis in this study, 86.2%. So we have to pay attention to the difference of the scale because the aspects of DWI might be one scale lower than that of CD. And differences in aspects between CT should be considered to perform the procedures. If you try to perform the MT based on this study. And generalizability might be limited beyond the Japanese population because we employ a low dose of IBTPA, and this study's race was limited. After reporting this RCT, we performed the sub-analysis. Among them, I picked up 3. One is aspects 3 and 4 and 5. We separated the groups like this, aspects 3, or a little bit patient evaluated as 2. So we divided into aspects 3, 106, and 4 to 5, 96. If we see aspects 3 or lower, there was no significant difference. However, big difference was seen in aspects 4 to 5. Another sub-analysis was evaluation of non-contrast CT or diffusion for this trial. Briefly, aspects evaluation on CT didn't provide a significant difference, but diffusion gave us a big difference like this. Number of passes of EBT was also interesting. And in this sub-analysis, we evaluated the TK2B was obtained in 1 pass and 2 pass, and those were related to the patient outcome, and analyzed 1 pass. And 2 passes were much better compared to medical treatment, but 3 to 7 passes or failed reperfusion didn't give us benefit. Conclusions: EBT increased independent patients MRS delta 3 by 2.43 times than medication alone in acute elbow patients with large ischemic lesions. However, we have to pay attention to frequent ICH in EBT group, although symptomatic ICH was not significantly different between the groups. In our sub-analysis, EBT was more effective in patients with aspects 4 to 5, MRI evaluation, and low number passes. Thank you for your attention. All right. Do you hear me?
I had a quick question. I was just struck by how the average age of the patients in your trial are older than in the other large core trials. I was just curious if that's reflective of the demographics of stroke incidence in Japan, and also just broadly, do you think the large core efficacy of thrombectomy is going to have some interaction with age? Kind of the classical thinking is that the older you are, the less you can tolerate a larger infarct.
I didn't hear you well due to echo. But I think that the MT was very effective even in high age patients like 80s or 90s. So we didn't perform the subgroup analysis based on the age, especially focusing on the very advanced age like 90. But in the other nationwide registry, we reported that the MT was significantly effective even for 90 or higher age. Thank you for your question.
Hi, Anna Ranter from New Zealand. Something that always worries me a little bit about these studies where the study power is based on positive outcome, and then you have very high symptomatic intracerebral hemorrhage rates, and it's non-significant, but the study, of course, wasn't powered to find that significant difference. And I was wondering if you could comment on that.
Thank you. Yes, this is our actual result. So we have to pay attention not to cause ICH, because after seeing the intracranial hemorrhage after procedure, we have to wait for a while to restart the anticoagulation. And if the ICH grows after the procedure, patient needs a craniectomy related to a poor outcome. So as your question was very important, and we have to pay maximum effort to decrease ICH, especially to perform MT for large ischemic core. Thank you.
questions from the from the audience. Quick question here and follow up. Based on your trial and experience in Japan, what is the current most prevalent practice to select these patients? Is this multimodal MRI, or you are simplifying it by going by the CAT scan and CTA?
Thank you. Actually, the number of MRI is number one in Japan in the world, and access was very good. So majority of the hospitals and the physicians perform a MT based on MRI evaluation. However, recently, rapid or other perfusion imaging were introduced to our country. So indication is a little bit different between the hospitals. Some physicians try to perform MT based on MRI only, or we personally perform MT on both MRI plus rapid evaluation. So we are now working on sub-analysis of the rapid impact on the clinical result on the patient with large ischemic core after MT. Thank you.
Thank you very much. Are we ready for the next presentation?
Thank you.
No. We're going to Tudor Joven. So now we have a special. Vincent was going to present last, and then, by the way, not to spoil it, they do have the very last results as of a few minutes ago, but they won't spill it here. But Tudor is going to speak now, and to our advantage, he's driving, so he's going to present without slides.
Yeah, so you
They
can't
texted, so I
see
don't
me.
know.
Hello,
they use the
everybody.
poker,
I'm here.
digital poker face. Okay.
That's right. Tudor, are you on?
Yes. Can you hear me? Can you hear me?
Yeah, we can hear you, but we want to see your face so we know whether you're smiling or not with the final results of last.
Okay, if you want to see me, that's all you get.
Wait. That looked like a Tesla, so you don't need hands.
I don't drive a Tesla, unfortunately. Okay, so are we ready?
We're ready for you, Tudor. The 10 minutes.
Yeah, so it's a pleasure to talk about LASTE. LASTE is the last but not LASTE of the large core trials. And when we designed it basically modeled after Hermes early time window trial, and with a thought that in the early time window there's a lot of fast progressors that even if there is a large core, there may still be salvageable brain. Again, my personal feeling and thinking about this has evolved a bit, but that's how it was at when we designed a trial. And it was also a trial that aimed to demonstrate that if you take all comers with an aspect score 0.5, they benefit. We knew that there would be a small proportion of aspects 0, 1, and 2 that even in this population, most patients are going to be on the higher end of aspect 0.5, just based on the distribution in the early time window. So the whole concept was that if this trial is positive, then you don't need to do imaging. That imaging would not differentiate between responders and non-responders. And that's why we included the very large, the largest cores. Of course, when we planned this trial, actually, we planned it at the same time as many others, maybe just before. We couldn't imagine what will happen and that will be in this situation now, and that these 0-2 patients are going to be that sort of precious in terms of the information they're going to give us. Because really that's the question that's remained to be answered, and also perhaps the size of the core in the extended time window, but we did not aim to even address that question. So that's the major difference as far as large core is concerned. It is unlimited in size. It goes from 0 to 5. So that's the biggest difference between this trial and the other 5. The other difference is that it's an early time window trial. Only patients who could be randomized within 6.5 hours. This is based on Jeff's paper from Hermes, where you lose statistical significance for benefit at 7.3 hours. And the only exception that was made is for diffusion flare mismatch on DWI. The planned sample size was, I don't remember the exact number now, but it was around 500 patients. Because of SELECT-2, and in addition to Rescue Japan limit, SELECT-2 and Angel aspects, we had a conference call with the DSMB. We did not plan for any interim analyses. The DSMB has asked that we stop enrollment and that they do an interim analysis. Recommended that the trial is stopped without giving us any reasons. So we don't know the results. I mean, I should say the database was just closed, right, an hour ago. So I still don't know the final results. So, you know, when I say if it's positive or if it's negative, I really don't know. What is there are a few interesting characteristics. The trial took place in France mainly. It's about 20 sites in France and another 7 in Spain. Most of the patients were enrolled in France, and in France it's standard to do MRI at baseline. So the vast majority of these patients are selected based on MRI. I think there's just about around 30 patients that underwent CT. There's, I think, 320 patients, or just 321, or around that number, that were enrolled. The DSMB asked us to stop enrollment when the trial had reached about 299, and then there were another 30 patients enrolled. And then just because of consent issues and withdrawals, a few patients were withdrawn from the study. So the final number is about around 320. The other feature that sets it apart from other trials is that we did not put an age limit. We did an age limit only in patients with the lowest infarcts. So it's very elderly patients could still be enrolled if they had infarcts, aspect scores 4 and 5. And so because of that, the median age is a bit higher than what was seen in other trials. The median, David was core lab. He knows all the scans. The median infarct volume, according to David, obviously in all patients, is around 150 cc's by MRI, because most of these patients were selected by MRI. as I said, there were about 30 patients enrolled based on CT. The primary outcome is a shift analysis. Symptomatic hemorrhages are expressed based on Heidelberg classification. But all I can that's pretty much all I can tell you. Wednesday morning, France time, and probably transmitting it at the time in the morning. The United States report the results of the trial. So that's all I have.
So thank you for joining, Tutor. We'll let you go.
Are there any? I'm happy to answer. I have plenty of time. I'm driving. I can answer questions if there are any.
Oh, you're coming back. Oh, no. We're switching away from you, Tutor. We're ready for Select 2. So Amru is on.
Okay. All right. Very good. But see you all Wednesday online.
Hello.
We're going to Amru.
You guys see my slides?
Yes. Thank you, Amru.
Very good. No problem. Thank you, David, for putting the meeting together. I want to wish really I was there, but after WSC, I need to spend some time home. So this is about Select 2, and I think it's old news, so I'm not going to talk too much about the design and the background. People here are very well sophisticated and know that, but we enrolled 352 patients with aspects 3 to 5 or core volume 50 cc or more. 178 went to thrombectomy, 174 to medical management, 2 crossovers. Only loss of follow-up for 4 patients at 90 days. And these are the baseline characteristics. Regular large vessel occlusion population, a little bit sicker with a bit of higher modified Rankin scale, median core volume around 80. We corrected some cases, as I will show you later, based on the hypodensity, but considering the CTP only, it was around 74 and 77 in thrombectomy and medical management. Very good distribution, I would say, early and late window, and I think that Tudor mentioned that earlier in his presentation, and that will become an important point in large core because there are some conflicting results from Tesla and tension. So we'll learn more as the data get together. The primary outcome is the shift, and this is a population where you do not expect a lot of good outcome. But there was a shift towards better outcome with thrombectomy as compared to medical management with a Gen OR of 1.51 and a number needed to treat of around 5. Looking at the secondary outcome, the MR 0 to 2, of course, much lower than the small core population, but improved with thrombectomy, as well as the MR 0 to 3, which I think is probably the most appropriate outcome for this population. You don't expect a lot of people being independent in this population. Mortality did not increase, but did not improve. Tension, I think, was a little bit different in that department. Symptomatic hemorrhage did not differ. We had higher early neurological worsening with EVT, and those patients went on to do worse as compared to the ones who did not have early neurological worsening. And this could be due to reperfusion and early cerebral edema. I think there is some consistency with other trials. So just since Select 2, as I said, is old news, some thought-provoking points for this meeting. I think it's of significant interest. What do we use to define large core? And I don't need to tell you how each imaging modality does that. CT based on the hypodensity perfusion, on the blood flow and velocity, and MRI based on the water molecular restricted diffusion and cytotoxic edema. And there could be heterogeneity when you use the same imaging, different imaging modalities for the same patients. Two patients with the same aspects can have different core volumes. Does this matter from treatment effect? Probably not, but does it matter for prognostication? Probably does. We'll see, as I mentioned before. So SELECT-2 was not just a large core trial, but we also, imaging is very important. So when we looked at the CT and the CTP, and this is not over and underestimation, this is just which lesion would be larger on the CTP versus the CT. In the early on, when the patient present, you see that CTP captured the lesion more. Later on, the lesion was larger on the CT, and that's due to multiple factors. Could be partial recanalization, clot migration, different reason why this would be different. But this was not due to overestimation on CTP. We have only 3 cases when following on the final infarct volume, less than 1%, that had over estimation, and this went to the per protocol analysis. But we think it's very important to look further onto estimating the core, and Bruce Campbell and his lab did a fantastic job. This is an example, and that's why we came with what we call the composite core, which is the larger of the two, not the sum, but the larger of the two. This is a patient with a core volume of 52 on CT. The core volume was much higher on the CT, and you see the lesion here, and the patient went on to have a very large infarct. Another case with similar illustration of the core on the CT and the CTP, and there is a paper that hopefully will be coming to give all of the details of that. That the composite, or utilizing both the CT and the CTP, give the best estimate of the core volume and the best correlation with the outcome. So this is what you teach the neurologist early on. Don't look at one image, but look at both imaging modality, and the association was not just from volume standpoint, but from statistical significance with the outcome. Is there a ceiling effect of the thrombectomy treatment benefit? Shinichi just presented the data from rescue limit, where there was no statistical significance in aspects of 3, but there was in 4 and 5. We did not have this in SELECT-2. There was benefit in aspects 3, 4, and 5. Of course, the outcomes, if you just look by the simple eye measurement, and this all will be in the imaging paper, you see that worse outcomes as the aspects reduce, which would you expect? It's plausible, it's expected, but the treatment effect was maintained. Same for the core volumes. This is the story with the corrected core volume, so to speak, or the composite. Just for the ones less than 50, all of the adjustments is in the imaging paper, but the same story when you use the CTP only. Looking at the different trials, looking first at SELECT-2 outcomes, you see as the core volumes increase, the MRS 0 to 2 reduced and the 0 to 3 reduced. And I think this could be philosophical. Is 4% worth it, or 13% worth it? You can think of this and individualize by patients. I definitely the number of good outcomes and independent ambulation reduced with increased volume and was limited, but the treatment effect was maintained, which I think is important. People might have different approaches into that, and I mentioned what our colleagues in Japan, Dr. Yoshimura and his group, found in terms of the aspects, which was a little bit different in SELECT-2. We have a greater treatment that is effective in patients even with large core. Exclusion is not what I'm talking about, but prognostication and decision making by patients. I think it was mentioned earlier that Rescue Japan has older patients. Last state Tudor mentions has pretty large volumes. So there are different populations, and that's beauty of these trials in different stroke severity, different median cores, which gives us a little bit of different outcomes. And the sicker the patients, the lower the likelihood of achieving good outcomes. And you see how things were in Select 2 in orange versus Angela Aspects and Rescue Japan. I think the truth is somewhere in the middle, and we'll wait for all of the trials results to know exactly where is the treatment effect. Talking about prognostication, other factors, not just the stroke size, of great importance. Age as a metric of frailty, time to reperfusion, and this is the probability of achieving MRS of 0 to 3. Again, this will be in the paper that I referenced. And as age increases for a certain core, we took 3 cutoffs, 70, 100, and 150. As age increased and as time to reperfusion increased, the probability of achieving MRS of 0 to 3 apparently decreased, and you see more red and less green and yellow when the core increased to 100 and to 150. I think a couple of things that in the interest of time and a number of slides I didn't mention. I think it was mentioned earlier about the how dark is dark and the degree of the hypo density. I think you will see very interesting data on that from us, from Bruce and his group, hopefully at the ISC. It's not just the size of the infarct, but it's what is the degree of the severity of the infarct is an important factor. And that's all I have to share from what we have done and will do in the near future. Happy to answer any questions.
Any burning questions for Select 2? Yeah, Alex.
Is this on? One thing that I have a hard time wrapping my head around is between Rescue Limit, Angel Aspects, Select 2, is the different rates of symptomatic hemorrhage. And I don't know if it's because between Rescue Limit and Select 2, it was, the Japanese population versus US, like are Japanese more prone to bleeding, or I don't know, like Amar, if you have any thoughts on why your trial, why did Select 2 particularly have such low rates of symptomatic hemorrhage, even in comparison to like Angel Aspects?
Right. Well, thanks, Alex. Well, I mean, we okay. I'm hearing just my voice. I think we have very similar rate of asymptomatic hemorrhage. We have over 75% asymptomatic hemorrhage in Select 2. And there is a paper coming from Michael Chen on the subject that discussing the details. I think there were differences in reporting the metrics that were reported. Some of the trials reported Hirschfeld. We reported different scale. We did core lab adjudication of the hemorrhages, and when we pooled the data with our colleagues in China and Japan, actually their hemorrhages rate decreased. In general, in this population, you have patients with very large strokes having to have a hemorrhage that would be symptomatic and worsen the outcome. It has to be pH2 significant out of the proportion of the stroke. I think these are some of the explanations, but all of these details will be in the paper that's led by Michael Chen, as I mentioned.
Are there any more questions for Amr? Okay. It's not coming up.
share. Okay, perfect. Can you hear me? Yep. Okay. So obviously these were presented before, so I'm just going to go through just top line results. We used a utility weighted MRS at 90 days. We used a utility weighted 90-day MRS. The treatment benefit in terms of difference in the utility weighted MRS was 0.63. The pre-specified probability of superiority was set at 0.975. Our result was at 0.957, so it fell just shy of our threshold, so not statistically significant. This was analogous to a one-sided p-value of 0.04, so a signal of benefit that we also saw in our secondary outcomes, 90-day, particularly 90-day MR 0 to 3 with a 10% difference, 13% difference in early major neurological improvement. Also higher quality of life, which was numerically higher. And then in terms of safety, no significant differences in 90-day mortality or symptomatic hemorrhage or in any of the safety endpoints. But I want to focus most of this talk on topics for discussion that I want to open up to the group. So point number one is there a time dependence for thrombectomy benefit in the large core? So you can see that at the bottom is Tesla, that the absolute benefits for 90-day MR 0 to 2 and 0 to 3 are the lowest in Tesla. I think one major explanation is that we were a very late window trial. So if you look at the median time to randomization, I don't have it for tension, but about half of our patients were enrolled beyond 12 hours, so would have been ineligible for tension. And if we break the Tesla results down by time window, early time window, so 30% of the Tesla patients were within 6 hours, and you can see a sizable shift, whereas in the late window, the shift is marginal. And then when you look at the dichotomizations, MRS 0 to 2, there's a 10-fold higher benefit in the 0 to 6 hour window, and a 3 to 4 fold higher benefit in the late window. So if we break it down even further, you can see that the early window Tesla results very much go in line with the other trials. Rescue Japan Limit was an early study. Angel Aspect Select 2, their median times to randomization were 7.6 hours, 9.4 hours. Again, tension, don't know. But half of our patients were enrolled beyond 12 hours. So point number two is that it's not that simple, because as Tudor had mentioned, that the thrombectomy benefit in the late window is variable. So in Tesla, in the late window, the point estimate is pretty close to neutral. With Angel Aspects and Select 2, there was a significant benefit. But also the late window is a large space. And you can see that if we look at the 12-hour window, half of the total trial population was enrolled, approximately half beyond 12 hours. If you look at just the extended window, 70% were enrolled beyond 12 hours. 40% of the extended window patients were beyond 12 hours in Angel Aspect, and 55% in Select 2. So there must be another factor in the late window, I think. And one of them, I think, is edema. And this is, I think this was mentioned by Tudor as well, that the Hamburg group has done great work on this question. They measured edema as net water uptake. And they found that the optimal operating point was 9%. So that in patients where the infarcts are with edema greater than this value of 9%, that there was no association between recanalization and outcome. Whereas with less conspicuous lesions, less edema, that reperfusion seemed to be had a huge effect in terms of causing good outcomes. And you can see an example of this in these figures. In the upper panel is an infarct with high edema. And you can see on follow-up that the infarct is completely occupies the entire extent of that area. Whereas in the lower panel with less edema, you can see that there may be some tissue sparing. So I think aspects and edema may be complementary. Aspects gives you a measure of extent, whereas edema gives you a measure of severity. And then finally, the question is who to treat and when. So for MRI, we'll await the last results, but these are really early window trials. Last, as Tudor said, was within 6.5 hours, and Rescue Japan limit, 75% of patients were within 6.5 hours. And the ones that were beyond had a flare DWI mismatch, suggesting that they were early. As far as the CT-based approach, all the trials agree in this early window, aspects 3 to 5. So essentially aspects 3 to 10 should be recommended. In the extended window, the evidence for time dependence of benefit is conflicting. And I think it would be helpful to separate the extended window into 6 to 12 versus greater than 12 hours. So in the 6 to 12 hours, I think the preponderance of evidence suggests that aspects 3 to 5 patients should be treated. So aspects 3 to 10 again. And that really the uncertainty now is beyond 12 hours. And this is where meta-analysis such as ENCORE, looking at imaging markers such as edema would be important, as well as clinical subgroups in this window. Thank you.
Hey, Albert, thanks a lot for your talk. I think it's just so interesting because as we get more and more of these trials coming out, Tesla, looks like more of the exception to a certain extent, where we have these large effect sizes in other studies, and then we don't see it in Tesla. And so the obvious question is why, which is, I think, what you tried to address today. I think the time hypothesis is a really interesting one, but to a certain extent, at like a fundamental level, it doesn't really satisfy me because, I think in thrombectomy, we've moved away from time so much, right? I mean, since Dawn and Diffuse 3, we really move more towards imaging and away from time. And maybe it is that with more time, we get this edema that you're mentioning. So I guess I'm wondering what it is that you think is going to be the best marker. And if it is time, even within the earlier window, there will be some patients with edema and this kind of thing. And if you envision kind of like where we go from here, how does that look?
Yeah, no, I think that's a complicated question. I think I wanted to raise time and break down the evidence based on time, because I think it's easier in the early window to just say, just do it based on time. Because I think the aspects grading, I think there are huge inter-observer differences. So I think it's hard to make any dogmatic statements about, how these trials differed. But I think that as we get into the later time window, that if we can figure out an imaging pattern that can predict this, who will benefit and who won't, this heterogeneity that I think we're seeing, particularly in the late time window, I think will be the way to go.
Yeah, I just want to remind you and everybody that with the thrombolysis studies, it really wasn't until we pooled the data and were able to really correct for confounding variables like severity and other issues that the time relationship to treatment and outcome really became evident. So I know that there must be plans to pool the data from these trials. You've got so much data there that's similar.
hopefully that should shed a light on it. But I think that's what's going to be needed to dissect out the contribution of
Yeah,
time.
absolutely. Yeah, I mean, all of these trials differed based on time window, based on imaging selection, the criteria. I think, you know, it's apples and oranges right now. And I think the only way to compare apples to apples is to do imaging re-adjudication and then relook at the data, pooling similar patients. But I do think that this time thing, I mean, in my opinion, is real.
Albert, thank you. And it's great to see beginning to tease at the depths of among these trials. And I'm going to sound a bit like a broken record, but the time is an index of penumbra. Degree of edema is an index of time, which is an index of penumbra. You're rediscovering that penumbra is less penumbra at 12 to 24 hours than there is 0 to 12 hours. We know from the IV TPA trials that you can't treat everyone once you lose penumbra. You have to select. And I think there's the idea that there's something mysterious happening in a tissue as opposed to what we already know from the lytics is seems like an extraordinary hypothesis to me as opposed to the ordinary hypothesis that penumbra matters.
No, I completely agree with you. I think that edema will end up being the best marker of penumbra and the loss of penumbra, right? Because I think if you have a well demarcated lesion, that's telling you that the infarct is done, right? I think that, and I think particularly in the white matter, because we do, on a CT scan, we don't have a good measure of involvement of the white matter, right? So, and in those images that I showed you, I think that if you can measure the edema up front, right, that's why I said the aspects and edema may be complementary, right? One gives you size, the other gives you like the severity of involvement, like how much can be spared. And I think that I think the white matter is super important because obviously they're the connections between neurons, right? So like if you wipe those connections out, that will have a huge effect. So I think that the answer is in the white matter, and I think the answer is edema. I mean, this is my guess. Well, I think that the problem with perfusion imaging is that it's non-specific, right? It's like, it'll tell you that there's altered perfusion. This is why I think CT perfusion is so important for distal occlusions. Yeah, but I mean, okay, so so there are two important questions there, right? One is core, which we're not going to talk about. One is the prediction of penumbra, right? So Tmax6, right? When they looked at the final infarct volume, there are studies that suggest that they don't match. That's what I'm saying. It's like the reliability of perfusion measurement isn't at a point where you can set a threshold. Threshold presumes precision, right?
So I just wanted you, first of all, great talk, really helpful brainstorming here. Just wanted you to spell out for me, and I apologize if I missed it, but are we able to then go back and look at net water uptake in some of these trials? And I'm not as familiar with the CT analytic methods and intrigued by this, and also directly comparing it with penumbral imaging, and perhaps we already have that data.
Yeah, so that's one of the major things that we want to do in Encore. I think one of the problems is how do you delineate where you're measuring the edema? Because the Hamburg group, they did it based within the CT perfusion lesion, okay, which, and that might be the best measurement. I mean, you know, we have to look and see if there's another way. Maybe it's like you take a sample and you take, you know, the greatest, maybe above the median greatest degree of edema. I have no idea, but this is something that we have to look at.
Great talk. Thank you very much. I think one of the problems with all the late windows and all the large core trials is that there is no repetitive imaging, even if it were only non-contrast CT. So at the end,
Jeff's point, whether there was penumbra that then went down can only be answered if you look at a CT at day 30 or maybe even at day 60 to see how big the infarct is then. Is there frank necrosis? Is there not frank necrosis? And so the final infarct volume has not been assessed in any of those trials as far as I'm aware.
Yeah, absolutely. I mean, even at 20, as you know, at 24 hours, measuring a final infarct is not always straightforward, right? And then the other thing is that I don't think median is a good measure here of infarct volume treatment effect, right? Because the vast majority of patients are not doing well, right? And so the median just reflects that probably you have to be looking at the 90th percentile, right? Where most of that treatment benefit is. So, I thank you. Oh, okay.
For those of you who are in the audience here in Los Angeles, a couple of housekeeping days will run the drinks will be served at 6 p.m. So it's going to be a working dinner. Please feel free to come out. To come back. And as we can expect, you're going to be well fed and nourished. We're going to have even more exciting discussions. So stay tuned. 6 p.m.
Is association between effect impact over outcomes for endocrine. therapy, the secondary analysis of the angiospect trial. Volume should be 70 to 100 milliliters. Or aspect, if this aspect more than 5 or time more than 6 hours, the core volume should be 70 to 100 milliliters. However, considering the variability problem over estimating vacuum core volume by CT fusion. In an earlier window, large impact is accessed by only one imaging modality may result in inaccurate selection of patients with large impact who may be a candidate for DVT. Therefore, the angiospect RCT combined the baseline aspects and the infarction core volume to assess large infarction core. Therefore, we hypothesized that a mismatch between aspects and the infarction core volume may exist, which could help select patients with large infarct who are most likely to benefit from EVT. Hence, the current study sought to compare the outcomes of EVT compared to medical management in patients with one baseline aspect 325 and the infarct core volume less than 70 milliliters. 2 aspects 325 and the infarct core volume more than 70 milliliters. And 3 aspects 0 to 2 and to verify our hypothesis based on the angiospect trials. The study population divided to 3 groups: baseline aspect 325 and the infarction core volume less than 70 milliliters. The baseline aspect 325 and the infarction core volume more than 70 milliliters, and the baseline aspect 0 to 2. The primary outcome is 90-day modified ranking scale ordinal distribution. The secondary outcomes is 19-day MRS 0 to 2 and 70-day and 90-day MRS 0 to 3. Earlier neurological improvement, change in infarction volume, and target artery recanalization at 36 hours. The third outcome is symptomatic intracranial hemorrhage within 48 hours according to Handbook bleeding classification. Any intracranial hemorrhage, death within 19 days, and decompressive hemicraniotomy during hospitalization. This is a statistical analysis of primary outcome, secondary and safety outcomes, and interaction effect analysis. As shown in the flowchart, of the 456 patients enrolled in the angiospect study, 1 was excluded due to withdrawal of consent, and 455 were included in the subgroup analysis. Of the included 455 patients, 257 were baseline aspect 3 to 5 and infarct volume less than 70 milliliters. 126 were baseline aspect 3 to 5 and infarct volume more than 70 milliliters. 62 were baseline aspect 0 to 2. This is baseline characteristics. There are no difference for 3 groups. For the primary outcomes in aspect 3 to 5 and infarct volume less than 70 milliliter group, we found a shift in the distribution of the 19 and 19-day MRS score towards better outcomes in EVT than medical management. In the aspect 3 to 5 with infarct volume more than 70 milliliters and the aspect 0 to 2 group, the shift toward better outcomes wasn't significant. Additionally, the interaction effect wasn't significant between the 3 emerging subgroups. Regarding the secondary outcomes, EVT was associated with higher rates of MRS 0 to 2 than medical management in aspect 3 to 5 and the infarct volume less than 70 milliliter group, but not in the aspect 3 to 5 with infarct volume more than 70 milliliters, no aspect 0 to 2 groups. EVT was associated with a higher MRS 0 to 3 rates than medical management in aspect 3 to 5 and infarct volume more than 70 milliliters group, but not in aspect 3 to 5 and infarct volume less than 7, no aspect 0 to 2 group. Additionally, the interaction effect wasn't significant between the 3 emerging subgroups. With regard to safety outcomes, EVT was associated with high intracranial hemorrhage rate within 14 hours than medical management in both aspects 3 to 5 with infarct volume less than 70 milliliters group, and the aspect 3 to 5 with infarct volume more than 70 milliliters group, but not in the aspect 0 to 2. There was no difference in symptomatic intracranial hemorrhage, death, and the decompressive hemicraniotomy between the EVT and the medical management group across the 3 subgroups. Additionally, the interaction effect wasn't significant between the 3 emerging subgroups. The limitations, the reduced sample size as partitioned between the 3 subgroups may have limited our ability to detect the differences and treatment effect by baseline imaging status. 2. Some variables, such as social-economic conditions, complex ethnic differences, and the post-discharge factors couldn't be measured, which may confound our findings. 3. The subgroup analysis was underpowered, which might have led to type 2 error due to the relatively small sample size. 4. As the participants in the angiospect trial were all Chinese, our findings may not be generalizable to other populations. So the conclusions, as no interaction effect was found among the 3 imaging subgroups, the benefit of EVT did not vary by aspects or infarct volume stress. However, when studying each subgroup, 1, EVT may be associated with better clinical outcomes than medical management, but with an increased risk of any intracranial hemorrhage in patients with aspect 3 to 5 and the infarct volume less than 70 milliliters. 2, patients with aspect 3 to 5 and the infarct volume more than 70 milliliters may benefit from EVT with regards independent ambulation. but with increased risk of any internal hemorrhage. 3. The outcomes were not different between EVT and the medical management in patients with baseline aspect 0 to 2. Approved and analysis of large point trials stratified by aspects and the impactful volume strata is a warrant. Thanks to Angela's Spectral Travel team, thanks to Angela's Spectral Travel centers, in appreciation, all patients and their families who participated in this trial, all sites, PIs, sub-PIs, CLCs, and CLN, steering committee members, DSMB and the CC board, Imaging collab and the statistical team, Angel aspect management team. Thank you.
Thank you, Dr. Miao. So, any questions?
No, any questions about Angel recording? So we can comment. So Jens had sent us presentations for his 2 other talks, but Jens and Guts are asleep. So
maybe we'll offer them at a more convenient time to comment.
No. We're going to have a non-tension participant present tension because we have the paper. So Sunil Sheth is going to talk about tension, which was just published 2 days ago. Are you on the Zoom?
I did. Yeah. Yes.
Perfect.
Okay, great. Well, thank you, David, for this literal last-minute request. I have no connection to this trial apart from being someone who's. What's that? Okay, great. Yeah, I mean, I'm sure there's people in the audience or on the chat who have inside knowledge of the study. So, apart from being someone who is on WhatsApp groups that gets lots of text messages about pictures of slides, I don't have any other kind of inside knowledge in the study, but it is an incredible trial, fantastic for the field, and really moves us forward. So it definitely deserves its time in this venue. So I will be the Vanna White, I guess, that goes through this study. So this was the publication that we celebrated a few days ago at WSC, and then also here in the Lancet from the tension trial. It's the latest large core trial to come out, and was also very positive. So some of the sort of unique features of this study, you can scroll down. Okay. This was a largely CT-based study. So these are patients that were screened by and large off of non-contrast head CT. Let's zoom in on. Median age was 73, and the median stroke scale on arrival was 19. 83% were screened with aspects off of CT, and the others with MRI aspects 3 to 5. And at site adjudication, the distribution across 3 to 5 was quite even. This wasn't like a, heavily weighted towards the smaller cores of aspects of 5. And even on core lab adjudication, that largely held up. There weren't too many that were too much bigger, too much smaller. The other notable feature, particularly given the discussion we had just a few minutes ago, was that this was by and large a early window study. So median time from onset to thrombectomy start was 4 hours, and then the 75th quartile was still below 6 hours. So these were early window patients that were treated. Sample size was very comparable to the other trials that we saw, very close to this was 250-ish, 250 patients. So I think, as everyone here saw or heard or read, the trial was positive. The score on the 9-day Rankin was heavily shifted towards endovascular therapy and demonstrating benefit. One of the, I think, features that pops out that Amrut also mentioned was the large
MRS6 or mortality in the medical management arm. This was a significant difference compared to the two groups, between the two groups. And I think this is something that is probably worth digging into a little bit more. It's a larger mortality than we saw in some of the other trials, and I also wonder if this speaks to a little bit of practice patterns and variability internationally in terms of how much we do for these patients after they present with a large core infarct and are getting medical therapy. In the outcomes, shows up. Okay, so the primary outcome was the Rankin score. It was, as we mentioned, extremely significant with a very large treatment effect, relatively speaking. I think it is worth noting that the median score for the treated patients was 4. These were not people that were healthy when they came in, and they were better than the controls, whose median score was a 6. So this was, I think, quite dramatic that the median value for the medical treatment patients was death. 17% achieved functional independence, Rankin 0 to 2. So these are numbers that I think were similar to what we were seeing when Amr was showing his slides, but that was still a substantial difference compared to the medical group. MRS 0 to 3 also 30%, so higher, but still not quite high, I would say. The other kind of notable things, at least when I read through this study, that popped out to me were this mean infarct volume at 24 hours. 24-hour may not be the perfect time point to measure infarct, like we also discussed here, but it's what we do across many of these studies. These were large cores, median infarct to 200 mLs. There's no kind of hiding small cores within aspects of 5. These were definitely big strokes, but again, as was also mentioned, there was no difference between the ones that got thrombectomy and that didn't. The infarct reduction didn't seem to be what drove the change in clinical outcomes between these patients. They were large with treatment, they were large without treatment. The authors also spent some time going into this mortality difference. So this was a Kaplan-Meier curve that they showed for mortality, if I can get this to show. Yeah. So this was the difference in mortality, and it really started accruing after that first week, and by 2 weeks, even by 1 week there's a difference, but by 2 weeks there's quite a substantial difference. And I would have to imagine this is when patients are still in the hospital and decisions around end of life are being made. So I think this is something that's worth discussion, and is this mortality rate with intention. And then these were the safety outcomes. So again, as we mentioned, mortality was quite high in both arms, but particularly the medical management arm. Hemorrhages, again, I think a lot of discussion around thrombectomy is, benefit, yes or no, but is it safe? And these hemorrhage rates of 5%, again, very, very comparable to Angel Aspects, Tesla, lower than Rescue, Japan Limit, but comparable to those other studies. And with that, I will conclude my mini presentation on tension.
Yeah. Thank you, Doctor. So anybody? Well, I think it's important to see that difference emerged. Sunil, don't go away yet. Difference emerged in mortality. So presuming hemicraniectomy was performed in both groups when clinically indicated, were there fewer hemicraniectomies in the endovascular group?
Yeah, so they present that, and it's actually the same. Decompressive craniectomy was 9% or 11 patients in endovascular, and 7% or 9 patients in the medical management arm, so no difference.
I think it's important, the more and more these data emerge and are presented, that we are moving forwards to the formerly DCS hemicraniectomy kind of patients, malignant MCA infarctions, even when we're not very close there. I think mortality is not important in these patients. One of the secondary endpoints in these patients needs to be Rankin 5, because that is an outcome that no patient and no relative wants to have. And that has been studied in aftermath after the hemicraniectomy trials, when patients and relatives were asked, would you do it again? And Rankin 6, 2/3 said, yes, we would have tried it again for our deceased family member. And for Rankin 4, it was close to 78% who said we would do it again. And 0% of the Rankin 5 patients, where the patients couldn't answer usually, but the relative said, of course, we will never do that again. I think that is a focus that you need to address. And in most trials I've seen, also Rankin 5 was reduced, no matter whether mortality was reduced or not. And that is a very important point, not to lump 5 and 6 together, and not to lump 4 to 6 together, but look at 5, maybe at 6, but at 5 separately.
Yeah, that's a great point. And I think the other thing, just again, I don't know about the conduct of the study, but the large difference in mortality, you know, when you've done a procedure on a patient, are you more inclined to push for not withdrawing care versus, you know, if you're less invested, you haven't done a procedure on them, you are closer towards doing that? I would tell you, in clinical practice, that's probably the case, particularly in, you know, hemorrhagic disease, whatever else that we treat. If I've spent a lot of time working on someone, I'm less likely to withdraw care. But, you know, this may have been addressed by the trial design that I don't know.
Thanks, Sunil. So on this general issue, one interesting aspect is in the glyburide trial, CHARM trial, we limited the number of thrombectomies because we were concerned that the chance for the anti-edema drug to show a benefit would be reduced because the thrombectomy patients would need less treatment to avoid herniation and craniectomy. And I think that was correct for the small to medium infarcts being enrolled. But in Hermes, Bruce Campbell showed that once your infarcts get above 130 cc's, you actually get more edema with reperfusion in the endovascular arm. And in at least one of the other trials, there was more hemicraniectomy in the endovascular arm than in the control arm. So I think we might see that for large core patients, having an anti-edema agent could be helpful if it avoids not only mortality, but also Rankin 5.
Great.
All right, so one more.
One quick question. So this issue around modified Rankin score 5 and 6, I get now where I practice a maybe different culture, but I think in my population, a modified Rankin score 4 would not be preferable to some people, especially elderly people, compared to a 6. And I have in New Zealand, we have a very large indigenous population, very rural, and shipping people from remote centers to tertiary centers, often hours of driving away. A large proportion still dies, and then they're separated from their family in the moment of death, which is culturally very difficult. And so I just wanted to raise that, and this may not be relevant to you guys at all, and I'm from a different place in New Zealand, but these things, we're discussing those issues around consenting people for these types of patients. It's a huge debate we have at the moment. I'd be interested to hear if this is something happening here as well.
Yeah, I think that's a great point. I mean, I think it's a super important point. And it comes up everywhere. You know, I think that the message can sometimes get lost, and this gets to the nuances of what does informed consent mean. So if we say, hey, you know, your patient or your loved one has come in, they have a large core, but we have data that they can improve if we do this procedure. And for us, improve means, well, at 90 days, the Rankin will be 1 point lower than if we hadn't done the procedure, which you know, is what we make our decisions off of. But in the patient's mind or their family member's mind, improve means some semblance of who they were before their stroke. And I think there's that disconnect. And so, you know, when you consent someone for the procedure, are you going to describe a Rankin 4 and this is what you're going to end up as? And would they want that? You know, I don't know.
before Peter puts a lid on something like that. Thank you for that question, because this conference attendance is 75 countries, at least by speakers. So thank you for bringing this. And there are some cultures avoiding death at any cost, including 5 might be the outcome they seek. So with that caveat.
I also completely agree, but in ex ante making a decision and informing the patient, you have to tell them first you have a chance, a small chance, maybe 1 in 5, to have a acceptable outcome with some disability. What we definitely know is we will not increase 24-hour need of nursing instead of having the patient die. Death might be neutral, but we definitely do not shift towards rank and 5 most severe disability. And I think that is the sales pitch, so to say. And the rank and 4, okay, that is a category that some people would agree. I don't want that. I'd rather be dead. Others say, as we know from hemicraniectomy trials, that's okay for us. But it's about the 5. And I want to reiterate that we do not produce more 5s instead of 6.
So on that point, I mean, I absolutely agree. It reminds me a little bit of the time when we were discussing hemicraniectomy decades ago. So I remember many times, as I'm sure many of you in the audience do, when neurosurgery had nothing to do with stroke. So there was absolutely no involvement. And getting a neurosurgeon involved for a hemicraniectomy was going to dirty their hands and their record. And there was a lot of misunderstood expectations about what was going to happen with the patient, and they would say, "Well, look, I can't save this person. I can't turn it around, and I can't cure their stroke." And and our point would be, well, we're doing it. It's life sparing. It may convert that rankin, it may change it. So it's all about expectations. And at that time, it was about the expectations that the physicians had, that the families have. And, we dealt with this as recently here a few days ago with large core cases where we are making bets or certain guarantees or estimates about what we think is going to happen a few days later, but we don't know. And it's all about the expectations and having discussions, as you said, Sunil, about informed consent. It's not just informed consent, it's informing the patients and the families of the best that we know, knowing that we don't know everything. And just getting on the same page about what might happen, if we go forward. Andre?
I promise never to bring hemicraniectomy and question out again in a thrombolysis meeting. But just for the audience, you guys know Humans 4-volume textbook of neurosurgery. It's huge.
Yeah.
How many pages are dedicated to hemicraniectomy? Take a wild guess.
0.
1.5. Oh. All right, I rest the case. All right, so David, you're next with Encore.
Yeah, so this is a good segue to talk about Encore. What is Encore? Encore is establishing neuroimaging criteria of revascularization efficacy. So in the last year and a half or so, we've heard a summary of almost all the trials. We did hear a summary of the trials today, not all the results. What we don't have is the last, as Tudor would say, but not the least results. And no matter what it brings, it's a slightly different data set, and we'll know next week. And it's different because we know the patient characteristics, some of the imaging, we know the imaging details exquisitely now, and it's slightly different like the other trials. But in some, we have now 6 trials that we have results from 5, and in a week we're going to have 6 where we have all the results available. And as mentioned throughout this large core session, each trial was slightly different around some of these variables. A lot have to do with imaging. There's baseline variables, and there are other variables that are difficult to control for and where there's bias. So the hemicraniectomy question, there's bias in terms of who do you decide to send to hemicraniectomy versus not. There's biases in terms of, withdrawal of care that are very difficult to adjust for after the fact. So there, like we do, as you know, with all trials, when we have several trials along a similar theme, we pool. Encore is now we have for several months, we have agreement from all 6 trials to participate in a pooled imaging analysis, re-adjudication of all the imaging across the trials. So, I think you have to be a little bit careful when you talk about pooled analyses and grouped analyses, because people think it means just, taking the final data sets and putting them together. And over the last several months, there have been a few papers that have tried to do this sequentially. After 1 or 2 of the trials came out, then the third, and successfully pooling. And there are a lot of people that have been involved in trials, in the large core trials, that have said, not yet, just wait a few months, wait till we have everything together. Because otherwise you're going to get, multiple iterations of publications where you're doing pooled analysis of 2 trials, or 3 out of the 6, then 5 out of the 6, and why not 6 out of the 6? So one way to do it is to pool the final data sets. But the problem in terms of pooling the final data sets, and you can do that, is you're adhering to the definitions of those variables in each of those data sets and how those trials were originally constructed. And because it's very complex in terms of the imaging, and the definitions and the readings in these cases, things were done differently in each of the 6 trials. The imaging modalities were different. The imaging subtypes or submodalities were different, and they varied. The nice thing about the data that's available is that there's a lot of imaging in all these trials. So you may pull one of these trials out and say Rescue Limit is an MRI trial, LAST is an MRI trial, and so forth. This study, Angel Aspect, had a lot of perfusion. There's actually, when you look at the raw data from these trials, there's actually a good mix of multiple different imaging modalities. And there was a choice made up front or a priori in each of the trials to focus things around a certain imaging selection. But there's a lot of imaging data in combined use. So, for example, there's a tremendous amount of perfusion imaging in LAST, an extensive amount at baseline. So there's a lot to be learned, but nobody would say that, at least at this point, that LAST is a perfusion imaging study. It could be seen as such. So the other type of pooled analyses that can be done are similar to what we did in Hermes. So as some of you know, many years ago after the landmark trials came out, Hermes was a pooled analysis that was specifically a re-adjudication from an imaging standpoint of the imaging that was reread by expert core labs from the various trials. It was a huge undertaking because it means that you have to get everybody to agree to participate and collaborate with each other. Amongst the large core trials, thankfully, we've done that, and we have agreements to share the imaging and make it available to participants in each of these trials and the imaging experts to do a re-adjudication. Now, the advantage of doing that is in the methodology. And I strongly believe that the value of a study is not the nature of the result, whether positive or negative. The value of a study is the level of quality in terms of the methodology. If you do the methodology correctly, that makes it a valuable study because it's most informative. And what we did in Hermes was we blinded the source of the data. So what would happen here in Encore for the large core trials is when the imaging comes in, and much of it has been collected already. It's all been collected within each of the trials, and we've started the process of pooling the imaging already from these trials that were done on multiple different continents. But nowadays it's possible, much as we did many years ago. Like in Hermes, we make it cloud-based, so centrally available, and it's blinded to the original data source. So a select 2 patient is not identified as select 2, LAST is not identified as LAST, and so forth throughout all of the trials. So the readers have no idea of what the rest of the source of the data, which trial it comes from. The readers have no idea, importantly, to any of the clinical data. So there is no age, there's no time of onset. It's completely separate from the clinical data, and so forth. And multiple levels of imaging adjudication separate from each other. So, which is important as well when you think about the modalities at baseline, when you think about the angiography, and when you think about the post-procedural hemorrhage rates as well. So there's a lot of things that can be looked at in that fashion. And you may ask, well, how does this come together? It comes together in the same way that we did Hermes. there is a link to a central trusted statistician who then can link it back with the clinical data after the imaging has been re-adjudicated. So plans are underway for ENCORE. We've been patiently waiting for all the trials to finish. We didn't think it was fair to embark on trials when, quite frankly, some of the largest trials were just recently completed. And some of the earliest trials to start were just recently completed. And I personally think, and I think many of our colleagues believe that there's a lot of questions to be answered and can be definitively answered in this approach. So probably the biggest challenge is to prioritize what the list of questions is. Core size at baseline is an obvious one. The role of modality, whether it be perfusion, CT perfusion versus aspects versus MR perfusion, which there's a lot of now, whether it's one modality versus the next, based on core size, whether it's lesion growth, penumbral salvage, the amount of edema, hemorrhage rates. There's the procedural aspects. Select 2 had a 20% vascular complication rate that has not been seen in the other trials. And that needs to be adjudicated across all studies because the angiographic outcomes are, what I can say from seeing 2 of the imaging data sets already is, it's not your standard thrombectomy. And I'm not sure why. You actually get fairly extensive reperfusion, not TICI-3s, but you get 2Cs. So there's a lot that can be done with that. The questions, the prioritization of the questions on an imaging side is very important. And the list of questions, as you know, in Hermes, I don't know what the total number, Jeff, the current number of papers that came out of Hermes, it's 50 or 60, somewhere in that range. Right. So, and of course, us academicians like papers, but that's not the measure. The real measure is what can we learn about these variables, such as the time variable, as it factors in. Either it matters or it doesn't matter. It may matter tremendously. We don't know that yet. So those are the plans for ENCORE. We have a paper that's coming through stroke in terms of the methodology for ENCORE. And you will be seeing this evolve fairly soon. And I'm very happy that everybody has agreed to collaborate on this. But just taking a moment before Andre cuts me off, in terms of, what are the implications overall and why do ENCORE? And I think the real answer is because we don't have all the questions answered definitively. Just a couple of days ago, we were in Toronto at the WSC, and when it came down to, how do we interpret Escape Next and Frontier next to each other, it's very confusing. You take multiple trials, and like in the large core trials here, we have slightly different cuts at the same question, but the variables differ. So, as scientists, as clinicians, we need, slightly more definitive answers. We may or may not be able to reach them. So there's a lot of implications of the large core trials. So just to speak about a couple of them that nobody's really spoken of yet. The large core trials were, interestingly, all investigator initiated, but with funds from industry, but to different degrees. They're not really about a thrombectomy device, any of them. The number of thrombectomy devices used and the variability is quite extensively variable. Nobody here on the planet knows the exact list of devices that were used. Which is an interesting thing from an industry standpoint, because from an industry standpoint, the only way you can get an approval and talk about expansion of the indications for thrombectomy, if you care about FDA approval, is to go to FDA. And FDA wants your data on your specific device, not pooled with everything else. So there's a lot of interest from industry. Just about every single one of the industry partners is interested in ENCORE. And has expressed interest in funding such a study, which is important to fuel it and to get these answers. The yield may be or may not be enlightenment of the role of specific devices. There's questions about technique. And then on the larger front, moving it away from thrombectomy, I think there are tremendous implications for the field. So just touching upon these two and just leaving this as food for thought, and then I'll stop, is I actually paradoxically think that the biggest question is not about thrombectomy in large core trials. It's some of our co-readers from an imaging standpoint, from a core lab standpoint, said there's no way that these studies could be positive. And I said, my comment was, it's all about the question. And the question, as Tudor has mentioned, and many of us have mentioned, is the question in these large cohort trials was not, did these patients do well? The question was, how does thrombectomy do versus medical therapy? Because people have asked, how is it possible that a patient with an aspect 0 is going to have a good outcome from baseline? Well, they're not going to have a good outcome. But do they do better with thrombectomy than medical therapy? Many of the trials have said yes, down to very low aspects. And we'll see when we get the final data, the last of the last data. Where is that threshold? Is it an aspects of 0, 1, 2, 3? What's the cut point? And then in terms of the outcomes, as Anna mentioned, in terms of what's the value of those Rankins at a later time point, so without twisting things around, we have the ability to look at this in terms of, blinded, pooled imaging data and separate analysis, statistical analysis of how it all comes together. But the biggest implication is actually for the rest of stroke. I actually think that the large core trials are not thrombectomy trials per se. The biggest yield will be for other therapies, and specifically neuroprotection. I may be wrong, and as Jeff mentioned to me last week, I usually bet wrong, but for the record, I bet correctly once, and that was this week, because I bet that Escape Next was not going to fare well. And usually I am wrong on bets, but the reason I think that neuroprotection is going to be the greatest boon is because it actually, Tudor, I can throw him under the bus because he's not connected right now. But he told me that, if Escape Next is negative, this could be horrible. It'll be the final end of neuroprotection. And I said, no, I don't think so. I think it's still going to be pursued. And that has to do with the trial design of Escape Next. So Escape Next, was slightly different than Escape, the earlier Escape trials. It didn't include very selective high aspects. They did have some patients, 1/3 of patients that were actually in a mid aspects range, not below 5, but in the 5 to 8 range. And the reason I think neuroprotection hasn't worked with thrombectomy is because those patients don't need, if you select patients with high aspects, they don't need neuroprotection. There's no way that you're actually going to show any benefit of neuroprotection in those patients. So I think that what's happening, I know for a fact there are several neuroprotective adjunctive drug therapy companies that are extremely interested in now the implications of the larger core trials and what we can learn from an imaging standpoint with and without thrombectomy. So I think in some, digging deeper into the data is going to be extremely valuable for the entire stroke field and definitely not limited to thrombectomy. So I'll stop there. And if there's any questions, Andre can point them at whoever.
Well, so first of all, I'd like to keep us on time. So we're almost caught up on time with the program. So, and we would still have plenty of time at the end, towards the end, to have discussion. I want to leave you with a note that Greg and I and Damru discussed at the STAIR meeting, that success of large core trial somewhat surprised us. And so deep look is more than appreciated. That's a great segue into some other things I'm going to tell at the end of the day. Break right now. Be back at 5:09 on target so that we can keep going. Thank you. Okay. Yeah, how are you? How are you? Nice to meet you. Yeah. All right. Yes. Yes. Well, waiting for share. Okay.
Confidential.
Check, check. Check, check, check. Check, check. It's working.
You want me to check as well?
Hey, nurses, your mic is good. We're just testing out our other mic over here.
Okay, got it. Thank you.
Yeah, of course. Thank you.
It's going down.
Check, 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 check. All right.
It's going down. It's going down. It's going down. Going down, it's going down, it's going down, it's going down, down, it's going down, down, it's going down, it's going down, down, it's going down, down, it's going down, it's going, it's going, it's going.
Hey everyone. Hey, hello. Hey everyone, we're gonna get started. Everyone, we're gonna get started. Everyone, we're gonna get started.
It's going, it's going, it's going down, down.
I'm hearing a little background music.
Hello. Hello. We're gonna start with nurses. We're gonna start with nurses.
Hi, everyone. You're probably wondering what I'm doing remotely, given that I live about 10 miles from you guys. 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 Uh-oh. I'm getting an echo. Are you guys getting the echo? Okay, well, why don't I dive in? First of all, it's a pleasure to be here, and I'll be there in person tomorrow. I'm flying into LA to see everyone. I'm going to talk today about pre-hospital diagnostics prior to thrombolysis. So I just want to talk about a few disclosures, and then let's talk about the idea of the mobile stroke unit. Certainly, it's a model that has been shown in clinical trials to be of great benefit in reducing door needle times and improving outcomes. However, the mobile stroke unit really does not look a lot like a regular ambulance. It looks more like a large truck with a lot of, it contains a lot of high-level imaging equipment and point-of-care laboratory, including a CT scanner. So I want to ask the question, can we envision a future where other diagnostic modalities can be used in the pre-hospital setting prior to thrombolysis? And I wanted to give you guys a survey of the area. So again, there are some barriers of care for the current model. The cost of creating and maintaining a mobile stroke unit are high. And the mobile CT scanner can't fit into a regular ambulance, so you have to create these other types of ambulances. So are there other imaging modalities out there being tested that could potentially create the mobile stroke unit of the future? So for a mobile stroke unit, you need neurologic expertise, and that can be either in person or via tele. You need to rule out intercerebral hemorrhage definitively, and right now only CT and MRI are validated for this. And of course, you need a diagnosis of stroke. Point of care lab, not in all cases, but it's helpful to have, and then the available treatments. So, essentially the only device I can imagine right now that would be great in the mobile CT scanner would be the this device that Spock is carrying, the tricorder. So I guess the question is, what's going to be the tricorder of the future? We took a look at this a few years back and reviewed all articles looking at different stroke diagnostics that are portable. And I wanted to kind of summarize where they are today. So here's a diagram of some different portable imaging modalities that one could consider putting in a ambulance: ultrasound, near infrared spectroscopy. We'll talk about the portable MRI, EEG, microwave sensors, eddy current devices, and the VIPS device, and talk about each one and where it might fit. And I'm going to keep it very short and sweet. So microwave-based diagnostics are something that's really kind of exciting. Microwaves, they scatter when they go through different types of tissues, and a helmet-like device with antennas can actually pick up intracerebral hemorrhage. The accuracy depends on the number of antennas, and the more antennas you have, the more accuracy you have. But there are devices that are in development. The idea of the microwave is that you can differentiate ischemic stroke and hemorrhagic stroke. Certainly in the rabbit models, that's been shown to have different effects on the microwaves. And there is a device called Stroke Finder. It weighs about 6 kilograms, takes about 2 minutes to detect stroke. And right now it's approved in the European market, but the paradigms for detecting hemorrhage are being developed. So, the microwave may be something that we could use in the ambulance in the future. EEG, it's widely available, and it's actually not bad in diagnosing stroke. not clear that it can differentiate between ischemic and hemorrhagic stroke. Those types of studies need to be done. And of course, the setup time with leads in the head is very challenging. The spatial resolution is poor for a small stroke or ICH. And I think deep learning models have to be developed because there's a lot of information in the EEG that probably is not being maximized. There are studies. There's the electrostroke study, which is coming out in the journal Neurology very soon. And the data are going to show that it's reasonably good at diagnosing stroke. The question is, what role will EEG have? Probably in and of itself, by itself, is not going to be enough. By the way, there was some seed funding for a stroke detectable wearable, which uses a lot of EEG technology. Not sure where the market will be for a stroke detecting wearable, but just letting you know that there is technology there utilizing EEG or EEG-like devices for stroke diagnostics. Ultrasound, it's hard to imagine the Nova guide being put into a mobile stroke unit, but ultrasound, at least in theory, has the ability to diagnose an LVO, potentially deliver sonothrombolysis. So let's include it in our list of potential things we could use. Near infrared spectroscopy. This is this could be worn over the head, and infrared light between 7 to 1,000 nanometers can penetrate the human tissue and is scattered by bone, skin, and cerebral white matter. Red blood cells actually have a low scattering effect and high absorption, so you could actually detect intracerebral hemorrhage with this device. But you see, it doesn't go very deep. It goes about 3 point. It doesn't go very deep, number one. And the other thing is it's going to be able to detect hemorrhages that are rather larger. But another use of near infrared spectroscopy may be oxygenation of blood. You can actually pick up oxygenation of blood differences and pick up ischemia that well. So you can have a hemorrhagic and an ischemic component of the near infrared spectroscopy. And there are a couple of devices on the market now, the Massimo device, which has been tested in the neuro ICU, and the Foresight tissue sensor. So can these devices be put into the ambulance in the mobile stroke unit of the future? Possibly. The portable MRI is very exciting. I think we're going to hear more about it. It's likely to be more expensive and difficult to maintain than a CT scanner. And I'm not sure it can fit in a regular ambulance. It's got to have a large power requirement, but it is a technology which is potentially something that could be in the mobile stroke unit of the future. The VIPS device, the volumetric impedance phase shift spectroscopy, actually is a pretty good device for picking up LVO. The sensitivity, 93%, specificity, 92%. And it's not likely to pick up intracerebral hemorrhage. So we would have to really probably combine the VIPS with other types of devices and technology if we're going to put it in the ambulance to do pre-hospital testing. But the actual VIPS technology is not bad, and it can detect major changes in blood flow comparing, the one side of the hemisphere from the other. So, eddy current dampening is something I've learned a lot about because this is something we've been studying at USC in collaboration with Caltech. Essentially, sensors creating microtesla level like magnetic fields that are essentially moved over the head in a specific the velocity, creating perturbations in the magnetic field, which can be measured. And using this device, we might be able to scan the brain and pick up hemorrhage pretty well. So as far as what the device looks like now, this is the prototype that we're working on. And it produces images that kind of in three-dimensional space tell you where the hemorrhage is. So this device may be something we could use as well. So there is a lot of technology out there: microwave EEG, ultrasound, near-infrared spectroscopy, portable MRI, the VIPS device, and the eddy current sensor. And the real question is, can we develop a mobile stroke unit of the future, potentially using these devices or other devices, or can we develop a tricorder, something to make mobile stroke unit more readily available? And currently, we do have a grant in to study eddy current sensors in stroke, and we are trying to develop better algorithms for EEG. So that's what I've been working on of late. And I wanted to say thank you for everyone and for letting me participate in this.
Thank you, nurses. I think we have a couple of questions. Jeff?
Hi, nurse. It's Jeff. Congratulations, and look forward to trying your device in our mobile stroke unit soon. I wanted to mention one other device. The Mind Rhythm Harmony device, a cranial accelerogram that detects micro movements of the head as part of the cardiac ballistogram, and that's altered with ischemic stroke and hemorrhage. And it's already completed its first pre-hospital study, and the pivotal one is about to launch. I'll admit my COI as being the advisor to the company, but I think it's the one that's actually closest to coming to market at the moment, and looks quite promising.
Thanks, Jeff. I'm going to look into it and learn more about it. I have heard about it, and thank you for that.
Hi, nurses. I just had a question about the sort of finances of pre-hospital diagnostics and treatments. I mean, I think one of the limiting considerations is how exactly these things get paid for and who pays for them. And I worry some of the innovation gets or could get stifled if there's no clear pathways for startups to get picked up if there isn't a good financial sound plan. So I'm just wondering what efforts are being made to make sure that these kind of technologies and treatments get paid for.
It's a great question, and I'll be honest with you. With the eddy current device, we've targeted other disease states like looking at hemorrhage in the intensive care unit and hemorrhage monitoring, because the pre-hospital market is a really tough one as far as paying and as far as finding a place. What I would say is that if we reduce the cost and produce results similar to the current mobile stroke unit technology, and there may be a role, but I have to confess that at the startups that I've been involved with, we have targeted non-pre-hospital for both the EEG and the eddy current sensor because of those particular challenges.
Yeah, and Jim Grotta is clearly the leader in figuring out reimbursement right now, since I'm working with him on some efforts with that. Jim, you had a question?
Yeah, just as much of a comment. Thanks for the discussion. It's definitely an area that needs to be developed with these technologies. I'll point out that the biggest impediment is not the cost of mobile stroke units, is not the cost of the CT scanner or even the mobile stroke unit, but the lack of reimbursement that doesn't pay for this sustaining them and for their operating costs. And that's going to be the case, whatever technology we have. Really, the single most important thing that put stroke on the map was the development of a CT scanner. It's the EKG of stroke. So, I know we want something better, but I wouldn't be quick to get rid of it. It's pretty easy and it's not that big a deal. These mobile stroke units are not that big, and it's not the biggest cost by far in a mobile stroke unit. And so I just want to dispel the notion that the answer to pre-hospital treatment is better diagnostic technology than a CT scan. That's not the biggest impediment to pre-hospital treatment.
Okay, thank you
Very
so
good
much,
point.
nurses.
Thank you all.
All right, our next speaker is Johan Waselius, who's going to talk to us about stroke alarm.
While it's coming up, Pooja had a quick question. Yeah, I was going to cover that tomorrow. But bottom line is that we've got we meaning Presto, the pre-hospital stroke treatment organization, has 2 lobbying organizations currently working, but we need a congressional act actually to identify mobile stroke units as a place of service, because the CMS will not create a new ambulance pathway other than what currently exists that would pay more than a standard ambulance transport. So we need to establish mobile stroke units as an identifiable place of service, and we can discuss more how that can happen, but it can.
Maybe like that. Yeah. Maybe like that. Well, thank you. Thank you for having me. Thank you for David and the organizing committee for inviting me. I'm very happy to be here and long way from home. And since many of you don't know me, my name is Johan Vaselius. I'm an interventional neuroradiologist in Lund, south of Sweden, and a father of 4. I'm going to talk about something in this field. It's called stroke alarm. So it's a wearable stroke detection device. It's CE marked in Europe, but it's not yet been assessed by the FDA, so it's not available in the US yet. I don't have to mention how big the burden of stroke is to you, nor the power of the treatments that we now have available. Unfortunately, so few of the patients are actually treated as only 5% on a global scale. And this has been frustrating. It's frustrating for all of us. And for me, as an interventional neuroradiologist, I believe we can treat anything with interventional means, except maybe man cold. What is the weak chain today is actually the time to alarm, that you need to have someone near to you that call the ambulance. And if that is done immediately, then the stroke chain is ready and very, very aggressive and effective today. Otherwise, not. So we have devised this wearable stroke detection system that we call Stroke Alarm. Consists of these paired bracelets that then communicate with the app in the phone, the user's own phone. So it's the way it works is that it monitors the arm movements continuously. And when we have a persistent arm motor defect of either arm, it initiates a sequence of interactions with users that will, if the user doesn't falsify that first indication, it will generate an alarm to predefined alarm recipients that will then act to ensure that the user is taken care of properly. These are ROC curves. The larger one on the right hand shows you one of the best algorithms and how the different lines here are different time windows. So if we base our decision on a shorter time window, we make a not as good decision as if we include more time, up to approximately 90 minutes. And if you look on the right side, these are the difference for the ROC curves for the day and night, the entire, and this is for day only, when the users are more active and then therefore the signal is stronger. And you see that the accuracy is much worse at night. This is for making a decision based on 30 minutes of data. And if we increase that, you see that the curves are much better based on 90 minutes of data. So we can compensate for the the less of movement during sleep. We also have this device sort of an escalation path to avoid, because you will have all kinds of daily activities where one arm is moving more than the other, and so we make it easy for the user to falsify initial initiations by doing dedicated movements with a suspected arm, or like an in-app test where you can easily show that you're okay. Otherwise, an alarm is sent to predefined recipients. And we have done a first small clinical trial with the entire system in Sweden. And the general experience from these were patients with a recent TIA or stroke, but without a persistent arm deficit. And the overall experience of those patients were positive. And what you see on the right side is that almost everybody would say that they would use such a device again. More than half also said that they felt much more safe. There was not even a question. There was just a comment from so many patients that it made them feel safer, and also their families. This is just something to mention, that these two different user interactions, that most of the patients were very able to do that. The first one is that you draw a circle in the air with the arm, And that is enough to show the system that you're okay. And if you don't do that, there's an in-app test, and that's alerted the patient a little bit more. And you can see that some of the patients found that a bit more disturbing, as it is, because that's the second step of the alarm chain. So it's a bit more serious. This is the way we perceive that it's being done, that it should be provided by healthcare to the patients at the highest risk of suffering a stroke, such as TIA patients, maybe some of the atrial fibrillation patients, and you guys know best who would be served by having a system like this. So how could a system like this benefit the entire stroke care? This is a health economic analysis that we have made in collaboration with health economists at Medtronic, and it shows that we could, it's based on Swedish registry data, Riksstroke. And it shows that if we apply the detection capacity of a wearable system, such as this one, we could move patients into an earlier time window, and that would increase, as you see, the number of patients that could be eligible for IV thrombolysis, almost double them. Also add the patients that could be eligible for thrombectomy. And of course, as you know, by transition patients, these are the patients that have NIH 10 or more. So the effect on transferring them from the late time window where they are not treated, the very late time window where they're not treated, into even an early time window would be a huge achievement for these patients. And the health economic analysis shows that the system is actually cost saving, not only cost effective. So I hope this is something where we can contribute to the care of stroke by bringing more patients to benefit from the excellent treatments that we now have. Thank you.
That's wonderful technology. Thanks.
Johan, thank you for the presentation. And it was nice meeting you just a minute ago. You know, one of the questions I have with wearables is, I guess, two things. One is, what happens if there's no motor symptoms or minimal motor symptoms? And the second is, it just seems to me that if you're going to wear something, it would be helpful if that thing did more than just detect stroke. So, you know, do you want like 8 bracelets, 1 for stroke, 1 for MI, 1 for cardiac arrest? So with this wearable, can you detect more than stroke? Or is that something that you're thinking about?
Thank you. That's good questions, both of them. For the, although I forgot the first question. Yeah, of course. What if there is no weakness? Yes, that's a good way. So when we looked at this, you know, without any, when we thought about this way back, we thought about many different ways to do this. So the system will not be able to detect the stroke if there is no arm motor impairment, of course. But I think that it's a very good biomarker for severe stroke. We know that most patients with severe stroke will have arm movement impairment, at least at the onset. So it's the best for now. It's definitely possible that we could add different of these initiatives to one another. That's also the case with several bracelets, as you said. You don't want several bracelets, no. I think that, but the fact is that every system will have to prove itself first, and then I think they will be all added into one and the same device. Or yeah.
Yeah, very exciting. One question. So if you try to implement this technology to a wider population, a bigger population, right? So how are you going to deal with all this data coming in? And second, with all this, you know, false alarms, right? The false alarms that they may overwhelm systems of care. So any thoughts on that?
Yeah, that's good questions, both of them. The first part, by handling all the arm movement data, that's not an issue today. I mean, handling lots of information it's rather a benefit. The more information, the better the device and the algorithm will be. So that's not a problem. And The other part is that to overwhelm healthcare. Yeah. Well, in the first trial we did with only 30 patients, the user system for 1 month, we did not see any such case where the patient actually was brought to hospital for some without a cause. So I think that the system with the escalation paths and then the predefined, typically it would be relatives to clear out whether the patient actually needs help, will deal with that sufficiently.
John, great presentation, very exciting. I'll go the other way, and instead of talking about multiple bracelets, talk about how much this one bracelet could detect not only abnormalities for stroke detection, but also organs like Parkinson's disease, probably Alzheimer's disease, probably abnormalities in sleep. So it becomes a platform with multiple applications. And thinking about addressing the decreased sensitivity at night, one thought that occurs to me is you could have socks with the sensor that the patients could wear at night, and that would give you more motor information and increase your signal.
Yeah, that's a good idea. Thank you.
Great presentation. I have a comment and a couple of brief questions. Firstly, the comment around having multiple devices. I mean, this seems imminently possible to include in a Fitbit or a Apple Watch. I mean, my Fitbit thinks I swim when I hang laundry, but I mean, there's obviously some refinements to be done, but that seems to me like it would be the future, like AF devices and that sort of thing. So I think that's probably not going to be an issue. But the question I do have is around your health economic analysis. The idea that it increases presentations to 83%, I think, does that actually incorporate the fact that a lot of stroke patients do not present with motor weakness? And do you factor that into your economic analysis?
Yeah. Again, I forgot the first question. You're actually only allowed to ask one question at a time to me.
All right, I'm jet lagged myself. No, I've forgotten myself. No, the first was a comment about the Fitbit, but the question was around the fact that a lot of stroke patients, and you included minor stroke patients in your cost analysis. Did you factor in that a lot of stroke patients do not present with weakness and adjust your analysis for that and only look at the proportion that present with motor weakness when calculating your cost benefit? Does that make sense?
Yes. So we factored in that. Yeah, so that was part of the factor. Also, when we did these initial studies on motor weakness, we included everybody with a arm motor deficit. So they did not have to be a complete paralysis. They could have just a minor, as long as it gave at least 1 point on the sub-item 5. I don't know.
Okay, thank you very much. Our next speaker is Radoslav Rychek. He's going to talk about fast AI.
Well, thank you very much.
Sorry, it's short.
For the invitation and the opportunity to continue to talk about stroke detection through a modern technology. This project is a collaborative effort between UCLA and several Bulgarian centers. I'm originally from Bulgaria, I work here at UCLA, and it's called Fast AI. And essentially what it is a smartphone-enabled machine learning algorithms for autonomous stroke detection. These are my disclosures. The main one is I'm a co-founder of the company that produces Fast AI. So question is, can artificial intelligence detect stroke symptoms? We know artificial intelligence is heavily involved in decision-making in acute stroke, mostly from imaging standpoint, but can we introduce artificial intelligence in clinical recognition of stroke? We know the problem was very well addressed in the previous presentation. Thank you for that. I don't want to repeat it again, but the essential issue is that very few patients arrive in time, partly because of poor stroke recognition or inability to activate 911 system because of their own stroke symptoms. And we all know the reference or the impact of time and treatment. These are examples of strokes that were caught during video surveillance or while individual patients or telereporters were talking on video, and then facial symmetry was captured, and slurred speech was captured. In one case, there was even an example of a patient that was detected to have stroke during Zoom call. So we live in a world where technology can be implemented, as you heard from the previous presentation, and we thought of automating stroke using simple mobile technology. We use the FAST paradigm. The FAST paradigm is a well-known paradigm for stroke education among the population. However, the problem is that only very few patients know about it, and it hasn't succeeded in increasing stroke treatment over the past 10 years. So we automated FAST by using the technology that is embedded in the mobile devices. We capturing facial asymmetry, speech disturbance, and arm weakness. And we do that through the device sensors and video input. We had a project started with Björgen Ingelheim 4 years ago. They gave us a non-dilutional fund, and we started the project. And essentially, I'm going to present to you the latest data from the project. But the essential methodology of stroke detection is basically on basis of 3 elements: acquisition of facial video, voice recording, and arm motion. How does the face detection work? Basically, we capture facial asymmetry, unilateral change of the facial movement using a 68-point open AI model that we now increase to a 90-point unique facial landmark key point extraction model that includes nasolabial folds. And we use dimensionality reduction and neo-discriminative analysis to detect these 2 main features: asymmetry and unilateral change facial movement. This is an example of a patient that has a right lower facial droop. The purple bar shows the side of the weakness, and the orange bar shows the probability of symptoms. We also use, just like in the previous presentation, we use accelerometer and gyroscope to capture angular velocity and acceleration, and by asking the subjects to lift their phone. And this is examples of a normal arm that the data center is showing us how the healthy arm looks, and this is an example of how the subtle weakness looks and more profound weakness. So we have also identified specific gradings of weakness based on the device data. And we hope we can track that weakness over time and potentially patients in a rehab stage. And in terms of speech, we use basically speech variability detection. We use null frequency acceptor coefficients. And this was a established model that was previously published, and we applied it on our data and validated it. And this is our study. We used 400 patients in our study that were enrolled over the past several years, started like 2019. We have predominantly ischemic stroke patients, and only 5% hemorrhagic. We also have Bell's palsy in our databases that we are developing model for Bell's palsy specifically right now, and the next month hopefully we'll have it. And we used a 70-30 split to train the algorithms and test the algorithms. So 280 patients were used to train the algorithms, and 120 patients were used to validate the algorithms. And this is examples of patients with subtle, barely detectable left lower facial droop. You see the technology picks up, the purple bar picks up the patient's left and the orange bar tells us the probability of the symptoms. This is a very obvious right lower facial droop with almost 100% certainty of facial asymmetry. This patient has left MCA stroke. So this is what we did. We used essentially this technology with physician-enabled process. So physicians are testing the technology on stroke patients. We haven't given it to the patients to test themselves yet. And we correlate with neurologist impression and imaging data, and this is how we achieved our validation results. This is how the data looks on the back end, and you see the summary of the neurological examination and imaging results. And essentially, this is our data. We showed that if the test subject is performing all 3 tests, we're achieving over 90% sensitivity specificity for diagnosis of stroke. So each individual test has over 70% sensitivity specificity for stroke diagnosis, but when they combined, we're achieving very good results. And just as a reference point, a human-based FAST or BFAST analysis shows lower sensitivity specificity in clinicians who are using BFAST in a ER or outpatient settings. So our preliminary results that confirm that smartphone-enabled machine learning algorithms can reliably identify acute stroke features with accuracy comparable to neurologist clinical impression. And the answer to whether AI can detect stroke symptoms, we can ask ChatGPT. Let's see what they'll say. I will rely entirely on ChatGPT for all my questions. Thank you.
I think in the sake of time, we should probably move to the next speaker, Dr. Smith, who's going to talk about episodes. You guys have him keyed up. I don't think he's here, right? While we're waiting, it's very interesting technology. It would be interesting to see if you could get it running in the background on Windows, for example, doing constant surveillance, although I don't know that people want to be surveilled that well.
I know, yeah. How are we going to integrate this in our ambient environment is always a challenge, of course, but there's various places that we can be used, and most importantly, having the neurologist in your pocket may be assertive to patients because they can test themselves just using a simple application. Thank you.
I just had a question, just, in light of these sort of considerations about undersampling certain populations in various studies. We know from clinical trials, for example, we undersample minorities. There's certain studies that have undersampled women. I'm just curious with some of this like facial recognition detection, just out of curiosity, is there any kind of data on how diverse of a population you need as your study sample to make sure that you identify some nuances between ethnicities and gender, those sort of things? Is that something that comes into consideration for this type of facial asymmetry recognition technology?
Great question. From machine learning standpoint, I don't think there's a specific number. I'm not a machine learning specialist, but the more data we have, the more precise the results will be. But the facial landmark extraction points that are used to detect a face and therefore detect facial asymmetry or unilateral arm weakness is supposed to be agnostic to race. Those are just human, features. But you're right on spot. FDA may tell us that we need more data from different ethnicities. Definitely applies to speech. Speech is obviously, we detect slurred speech, but it has to be obviously accounted for the language of the patient that we use, and we only used Bulgarian patients so far. We haven't validated this in English-speaking patients. But the more data we have, the more universal the AI will be.
Regarding the speech thing, you know, I didn't want to get back down this rabbit hole of AI because there's so many different applications, but there's a program that analyzes speech recognition that EMS dispatchers are using to detect stroke and make dispatch accuracy more accurate. But so there's, as you know, probably a huge amount of work being done with speech pattern recognition that it would seem to me you could apply to this software.
Yeah, great. I heard about this technology. I don't know how accurate it is, but it's exactly what we were thinking too. And in essence, we just have to validate it. You know, whatever, you know, slurred speech specific to stroke has to have a specific pattern, obviously. But thank you for mentioning this is exactly what we're thinking, the same way, same direction, maybe passive listening to patients, even your IoT, Alexa, you can talk to Alexa and Alexa can recognize that you're speaking or slurring in the morning. Before I have coffee, maybe they will alert me every time, you know, I will have slurred speech, but also has to be unique to the individual. And I think that the most important thing is to have specific baseline data per patient and then detect changes of that data. I think that's where the actual highest precision will be, rather than just picking up random samples.
Okay,
thank
you so much. Let's move on to our next speaker, Dr. Wade Smith.
Great. Can you all hear me okay? Can you all hear me okay? Can you all hear me okay?
We hear you.
Sounds like there's a bit of an echo. There's a bit of an echo. I'll turn down my audio here in case it's for me. So I had David asked me to talk about the episode trial and its update, and we just presented this at ACEP last week. But James Paxton did the presentation and has kindly allowed me to use this presentation. The episode trial itself is a multi-center study. Disclosures, this was funded by MindRhythm, of which I'm a co-founder and have some patents in this space. The objective of this really is nothing startling to this crowd, which is to get LVO stroke patients to comprehensive centers. I think what our adage is STEMI for stroke. Our eventual goal is to create a device that a paramedic can use to do the same thing they would do with ST elevation MI by going to a center that has direct angioplasty capable, that we want to go directly to the cath lab. But it's got to work well enough if it's going to. So we also, for this crowd, there's no lack of knowledge about the maldistribution of comprehensive stroke centers. I was in the Czech Republic a number of years ago and looked at their system, which was perfectly designed geographically. The United States has different incentives, so things are in different areas, and trying to get an LVO stroke patient to the right place is what has been discussed a number of times already in this. We looked at 2 centers in Michigan and in California to do this trial where we enrolled patients who are adults who could accept placement of a headset, which I'll show you, and then later were consented in the hospital for evaluation of their hospital-based data, primarily CTA. They also acquired a LAM score as basically a performance measure against which we want to test the device. And then for those of you who are good clinical trialists, the reason COVID is in the title is because all research was shut down except for COVID. So we said, hey, let's just make it COVID as well. I didn't find anything significant, but at least got it through the IRBs. So some of you may have seen this data was shown before that if you take a person, place a highly sensitive accelerometer on the head, and compared to some of the accelerometers that we've just heard about previously, we're talking about 3 orders of magnitude more sensitive. what we're doing is we're measuring the cardiac induced forces on the head. And this one headset that I designed will transduce that over the temporal bone, but you can pretty much transduce it anywhere in the head. Doesn't really matter because the head is pretty, pretty solid. In a normal subject, if you superimpose their head pulses over each other, they follow a very consistent pattern. The amplitude varies by respiration, but the phasing stays very, very similar across time. So normal subjects and patients with small vessel strokes and stroke mimics all follow this normal pattern. But in this case of a large vessel stroke or right middle cerebral occlusion, you can see that the head pulses no longer follow in perfect synchrony with the EKG. They're what we call chaos. As soon as the vessel's open and we can pull the X-ray tubes out 2 minutes later, you can see how it starts to become more in phase, and then the next day is better. And David Leaps kind of talked a little bit about the fact that this isn't immediately normal might tell us something about collaterals or no reflow. But at this stage, what we're interested in is detecting how often is this pattern sensitive and specific for large vessel stroke. And as I presented a number of years back at STARE, it's about above 90/90 in specificity and sensitivity. So what I'm here to report is the largest pre-hospital study of its kind for a device. We enrolled almost 600 patients in this trial. In this case, the paramedics were placing the headset in suspected stroke patients. We eventually winnowed it down to 158 subjects, which were those that had been, that we used a newer development of a headset, which I'll show you. So this is the headset that we're using and testing currently. It has a couple of processors in it. It has a 3D printed headset. This is an accelerometer here, and it has 3 ECG leads. In the study of over 600, we ended up consenting half. Number went to different hospitals or went in a study network, some refused consent, et cetera. And then we brought it down to this population of 158, of which 26 had LVOs and 32 were non-LVO strokes, 9 ICH. And then a good sign that we were enrolling well is that 91 of the subjects had not stroke. So their paramedics were being sensitive. We had, interestingly, one of the highest African-American percentages of subjects in acute stroke trials, which you know is uncommon. Part of that's because we started in Detroit and then branched out. The demographics of the study were quite not surprising. Our primary results were that if we look at the LAM score, the LAM score was 41% sensitive and 90% specific for LVO. That's pretty in keeping with other studies like Presto trials and others that have looked at the performance of that tool. The device here was 85% sensitive and 89% specific. Now, again, this is data that's fit. This is not overfit. It's been run through a number of different levels to prevent overfitting, but it is model based, and I'll talk about how we're going to validate that. The area under the curve for the device was 0.91. The area under this curve for LAMS was 0.8. Sorry, go back one slide, was 0.83. And LAMS works really well as a tool for making sure you don't have an LVO stroke, right? It's highly specific, so it's far to the left. But the challenge with it is that it's relatively non-sensitive. So the focus and the goal of this device is to try to bring this operating point, the LAM score 4 greater point, up higher. So we want to basically be able to double the sensitivity without hurting specificity. Obviously, specificity is important for delaying care for small vessel strokes that could benefit from TPA. While the sensitivity is obviously important for patients who can get treatment within endovascular treatment. So if we took this cohort of 158 patients, all shown here, and and divided them simply into LVO versus not LVO. And the not LVOs already showed you what that combination was: small vessel strokes, ICH, stroke mimics. The Lamb's criteria misses a lot of the LVOs and identifies 13 false positives. If you use a device, actually the number of LVOs that it misses is far fewer for the expense of taking on 2 more false positives. So how that pencils out is that the device is twice as sensitive than the Lamb score with a very similar specificity. It's not inferior. And these are the primary outcome points for our prospective trial that we're running right now. So to actually put it into the category for the endovascular people who have to get up and get to the hospital, it doesn't change the false. Oops, sorry, what happened here? Put that on my screen. Okay, hopefully you can see my screen again. So the 13 false positives turned into 15. So there's still some false positives, but we doubled the true positive rate. So this is obviously, could be a benefit if it's properly used in the pre-hospital setting to improve sensitivity. Where we are right now is that we've taken the algorithm that we've built. We've tested it against some cases in Buffalo that are endovascular patients, and it found of 9 LVO patients, it found 8 of the 9. And then we threw a whole bunch of normal subjects, several thousand, and it didn't call any of those LVOs. So we had confidence with the algorithm to move forward. We're now about enrollment about 300 in the pivotal trial. And the pivotal trial is to take the device itself makes the determination by itself that it's onboard processor, comes up with an answer but doesn't tell the paramedic. It encrypts that, encrypts the data as well. And then the patients are consented. Information is adjudicated by core lab, at least the CTA imaging is being done by core lab with David Liebeskind. And then we have 2 stroke neurologists who are adjudicating the final discharge diagnosis for the third tiebreaker. Once we have enough LVOs and enough non-LVOs in the cohort, we'll stop the trial, collect the data, and then we'll open the envelope and see if we actually hit on our endpoint. So that's a quick update where we are with episode.
Looks like you've got a question.
Andre.
Thank you. Congratulations. Was following your work for quite some time. A couple of things. Maybe I missed from your presentation. What is the minimum acquisition time of the signal, and how do you control for motion artifact? Because if you don't stop paramedics, the kind of load and go, do you do it on the ground or you do it in a moving vehicle?
Yeah, so it's because we're using very, very sensitive accelerometers. You're right on, Andre, that you really can't use it in a moving ambulance. The workflow is that the paramedic would put it on as soon as they suspect a stroke. The device is quite good about separating gross body motion from the head pulse itself. So it picks and chooses the periods of time that it needs. And it needs about 25-30 seconds of non-degraded data. And we've now recorded from in over 400 or 500 stroke subjects. And we're able to get pretty good recordings, at least sufficient for it to come up with an answer.
I just had a real naive question. In terms of just generalizability, have you looked at the kind of existing accelerometer features like on AirPods, for example, that could be sort of outfitted with your algorithm? Like, are there ways to use other types of existing hardware to couple with your algorithm?
Well, it's also a great question. The challenge is the size, but it's not complicated electronically. I mean, I was able to build the devices, so it can't be too complicated. The concept of micronizing them into earphones or glasses to use for the purpose of point of care diagnostics, but also wake up strokes and other things are quite there. For those, you've worked with accelerometers and stuff, it's a bit like reading tea leaves. The benefit we have is that we can tell pretty clearly if it's coming from the head or external forces. So that allows us a lot with signal to noise reduction. So yes, I think as other presentations have been about detecting stroke when they start, there is a capability here. We want to start with the point of care triage decision from paramedics first. But that's a great application, we think, for the technology. Hey, Jim.
Wait, thanks. It's Jim. So thanks for the presentation. I've also been following the technology, and of all of the LVO detection devices, it seems furthest along, but I was always bothered in terms of the application, the fact, well, you can't exclude hemorrhage. And so you got, thinking about a practicality, you've got a patient with a severe stroke, and they're probably going to be going to a comprehensive stroke center anyway, whether they're, actually there was recent data that just was published from the RaceCat trial that showed that patients with hemorrhage are probably not well served by being diverted to a comprehensive stroke center because of the prolonged transport and added aspiration and stuff like that. So to be able to identify the LVO patient as the one subset of patients that probably should definitely be triaged to the comprehensive stroke center would be really valuable. So I think that additional information has just been published really helps bolster the value of your technology.
Thank you, Jim. One comment on that is that you're right on, and especially if the faster results come out positive, showing that 10A or 7A is going to work, to improve outcome. We have to think very carefully about falsely triaging ICH cases. We are hoping that with the data that we're getting with the pivotal trial, we'll have enough data. Right now, we have pretty good sign that we can tell, cut the folks into a couple categories. One is LVO, not LVO. And then if you say not LVO, we're pretty sure we can tell if it's an ICH and not small vessel stroke or mimic. But that's going to take more data collection and more cases to be certain of it.
Thank you for your presentation and congratulations for this innovation. I have a question. Do you have any results about the subgroup and in terms of sensitivity?
I'm sorry, I'm having a really hard time hearing for some reason. I don't know. Is it loud enough in the room?
Do you have any result about subgroup analysis in terms of sensitivity in different location of the clot of large vessel occlusion? Is that can affect the sensitivity and specificity?
Well, I'm sorry, in terms of proximity of medical centers or temporal timing of the onset of the stroke, I just can't quite hear very well. Can you hear me? I'm just not sure of the question. I apologize. I just cannot hear it well.
Yeah. My question regarding if you have some data or results about subgroup analysis in terms of the sensitivity of detection of LVO with different location of the clot.
Oh, different location of clot. It's weird. And your question's right on. I would have thought that we put the headset on the right side of the head every time. And we can't tell the difference between a right and a left MCA occlusion. And our engineers were really bothered by that. And I said, I can tell you what side the occlusion's on, just by examining the patient. So that's not a problem. But it's interesting that it doesn't really matter. And we've been able to get recordings on either side of the head if we have to. It doesn't matter whether you have thick hair or no hair. It doesn't have to be pressed hard against the head. It's really interesting how insensitive it is to, or how unaffected it is by body characteristics. So we don't yet have enough we have only one basilar occlusion, and we're waiting to see if we get more. And if we do, then we might be able to say something about basilars. But at this point, we're sticking with anterior circulation. I can just say whether it's a T, M1, M2, and that's it. And I can't tell you where it is.
There we go. Well, thank you so much, Wade.
Thank you.
I think it's time for us to perhaps get some food. It is outside. If we could do that maybe in 10 minutes and carry on. I'm getting a lot of faces about the 10 minutes, but let's try and carry on. Thank you.
Hilo, are you there?
Hey, Thilo, if you're there, I think we're ready for you.
It was just the appetizer.
I know. Yeah.
Now getting them back in.
Hey, Taylor. Are you there?
Yes.
All right, we're gonna go to you because Tilo's not here.
All right, let me. Give me a moment just to share my screen. Okay. Well, thanks to David for the invitation to speak to the group today. And I hope you're enjoying your dinner as I give my presentation for the next 10 or so minutes. What I'm going to talk about is the role of low field portable MRI for acute stroke. Obviously, this technology can have other applications as well, but what we'll talk about today is acute stroke. These are my disclosures. So I thought I'd just frame the presentation by reminding the group here of some of the differences between the conventional and portable low field MR, highlighting both the advantages and disadvantages of each. As we all know, on the left-hand side is a 3 Tesla or 1.5 Tesla conventional MR, and these are really fabulous at generating high-resolution images. There are many sequences available, and so it's really exquisite for a wide variety of diagnostic questions. However, to achieve that, it requires superconducting electromagnets that are cooled with liquid cryogens to operate the gradients as well as the RF excitation. It requires quite a bit of power, and the instrument itself is really quite heavy, on the order of 13 to 15,000 pounds. So it requires a dedicated room that is reinforced to support that weight. The room itself is shielded from electromagnetic interference, and the magnetic field strength is high enough that it can pose a significant safety risk. So there's a lot of careful access control features in place to ensure patient safety. And you put that all together, and obviously the technology is incredibly useful, but really quite expensive. In contrast, low field MR has quite a bit lower resolution. And as a consequence, in part as a new technology, but also the limitations of the lower magnetic field strength, there are fewer sequences available. But its advantage is that it uses static magnets, so it doesn't have cryogens. And the device can operate and pulls about the power of a coffee maker. So all it requires is a single electrical outlet in a standard format. Due to active electromagnetic interference, noise cancellation, there's no RF shielding that's needed. and it's mounted on motorized wheels, making it a free-range instrument. And again, you put that all together and you get a lower cost imaging device relative to the conventional MR. So the value proposition of low field portable MR is increased access, but it comes at a cost for resolution and diagnostic sensitivity. But the intriguing thing about it is it changes the paradigm in thinking about how to use the imaging technology. Rather than bringing the patient to the imaging suite, you can bring the device out to the patient. And that really is in a variety of settings. Certainly in the hospital, it can be brought to the bedside at point of care, both in the emergency department, the ICU or inpatient realm, and also in the neurology clinic, as we've recently done. But then outside of the hospital, out in the community, we heard earlier about some of the pre-hospital technologies, and portable MR is certainly one of the potential options in that scenario. But it can also be brought into community health centers, and then also it can be used to increase access in rural, low resource areas and low and middle income countries. But with that increased access, there's this trade-off in image resolution and diagnostic capability. So thinking about that right balance between those two requires a sort of careful assessment of what the proper use case scenarios may be. Within the realm of stroke, the ones that we have been thinking about, although this certainly is not the only possibilities, but the ones that we've been thinking about have been wake-up stroke, and then pre-hospital settings, and then stroke imaging in limited resource environments. And our strategy has been to focus on the first, with the idea that it can feed forward into other and future applications going forward. So together with a close colleague, Kevin Sheth, we showed our first task was just to show that it's feasible to detect stroke in the inpatient population. And I'll say back 5 or 6 years ago, when we were starting to image these patients, DWI as a sequence wasn't even available, and it wasn't clear that it would become available. But through a series of improvements in the technology, we were able to show that in the subacute phase in the ICU or in the inpatient setting, that the scanner is able to detect, in this case, a left MCA stroke on the T2 flare, T1, and DWI sequence, all in acquisition times that are approaching feasibility for routine clinical care, although not quite there for some. The head CT standard of care imaging is shown as a comparison on the right. So one of the consistent features, I guess, of low field MR is that it is a field that is moving at a light speed in terms of the technology. So what's true today will not be true 6 months from now, and certainly wasn't true 6 months earlier. And just to highlight this point, on the top image, I'm showing an example of some acute stroke imaging that we had done with an earlier generation hardware and software. On the left is a standard of care 3T DWI scan showing the right basal ganglia stroke, and on the other side, on the right side of that image, is the DWI that came off the low field scanner, and it unfortunately missed the stroke. It lacks tissue contrast as well as CNR, and due to differences in or earlier generation in the gradient amplifiers, which are critically important for DWI imaging, as well as earlier generation noise cancellation and some of the earlier generation image reconstruction algorithms of partial case space, these factors all combined to occasionally generate images that were non-diagnostic. And certainly in thinking about how to use this in acute stroke, really need to increase the reliability and sensitivity of the device. But on the bottom scan or bottom image is an example of the most recent generation hardware and software that include improvements in all of these factors. And what is notable is that there is not only good normal tissue contrast, but the stroke lesion itself is detectable, and the overall resolution is approaching that of what's seen on the conventional high field DWI. But there are still some important questions that need to be addressed before thinking about using this in acute stroke care. Through the lens of the wake-up stroke patient population, one of the questions that we've been very interested in is first asking the question, how well does the low field FLAIR image represent the tissue clock, which, as we all know, is integral to the concept of the wake-up trial and the use of FLAIR DWI mismatch for guiding thrombolysis in wake-up patients. In the left hand, and this is a cohort of just over 100 patients who've been imaged in every generation of the software, looking at the FLAIR signal intensity ratio of the stroke lesion to the contralateral hemisphere. And it indeed shows that there's a stepwise increase in the FLAIR signal intensity. And using an ROC analysis to define the optimal cut point, what's reassuring anyway is that that optimal cut point corresponds in this retrospective cohort to a signal intensity ratio of 1.15, which is actually quite consistent with some of the literature in the conventional FLAIR DWI mismatch. And so now this has inspired a prospective study action PMR to validate this and for the future. The second question that and I'll give this as an example and then end here, but second question that we're interested in the setting of acute stroke imaging is what's the limit of detection, particularly small strokes? I mean, any technology can identify a large left or right MCA stroke. That's not the challenge. If we're going to figure out how to use this technology in clinical care, we've got to understand its limitations on the side of small strokes. And there are a number of challenges of doing DWI imaging at low field, but essentially they all relate to poor SNR. And so the current approach to dealing with that is to acquire a single direction DWI scan and on the order of around 10 minutes or so. And it's a tour de force to be able to measure that at all. But one of the limitations of single direction DWI is that then it is susceptible to the artifacts of restricted diffusion related to white matter tracks and things of that sort. And the case example on the left demonstrates this, where the small stroke lesion is right inside the area of the white matter tracks that make it impossible to assess the ADC intensity within that lesion. And what we've started to do in collaboration with some of the imaging scientists and MR physicists at our institution is to build a three-direction DWI, and we've been able to achieve some efficiencies in the pulse sequence so that the image acquisition time is really just a small increment longer than a single acquisition. And the advantage here is that it increases the lesion conspicuity not only of the DWI but the ADC. And based on what we've been able to find at this point, we anticipate we'll be able to drive down the time of the acquisition even further. So just like in conventional MR, where we'll get at a minimum 3, but often 12, 21 or more directions, there's benefit in doing that at low field as well. And 3 directions is probably the minimum that's needed. So with that, I'll stop there and just acknowledge the broad team that's been involved, not only at my institution, but I want to acknowledge Kevin Sheth at Yale, and then collaborators, Nimji at Ohio State, Adnan Siddiqui in Buffalo, and Keith Weir in Glasgow. Thanks.
Okay, thanks, Taylor. Great presentation. We're all excited by this technology. Any questions?
Hey, Taylor, great presentation. Steve Warwick here. Can you talk about the portability of this low field scanner, and particularly, you know, when we want to do final infarct volume, it's often hard to get patients to come back to the facility. Is it at all feasible to think about transporting this small low field scanner to where the patient is and doing our 30 or 90-day infarct volume?
Yes, Steve, thanks for that question. It's a great point, and you know, I would generalize it. It's not only related to the follow-up imaging for stroke, but really, frankly, any epidemiologic brain health focused study. The value of having a portable scanner that can go out into the community, I think, is self-evident. There are a number of largely technical and logistical limitations currently that limit that. You know, taking the device out of the box, installing it in a van, and driving it around. Some of that relates to FDA regulations. Others is just, you know, the logistics and cost of orchestrating all of that. But all of it, it's solvable. And I think that's one of the exciting potential uses of the scanner is to is not only think of it as portable within a physical location, but mounting it in a van or an EMS truck, a mobile stroke unit, for example, and driving it around to the community.
Okay, thanks, Taylor. Next, we're going to, I guess, jump up to Sonus. Thilo Hoschel is going to give us that presentation. Welcome, Thilo.
Yeah, so I'm ready. Oh, it's shared. Hold on. Looks better. Yeah, here we go. Okay, thank you very much. I would like to introduce you to the Sonus device and our first results we have. I guess it's probably new to most of you. Sonus is a battery-powered portable ultrasound device which actually assesses brain perfusion. Easy to use, it's very safe and mostly cost efficient in its potential uses in the pre-hospital scenario as well as the bedside. So Sonus has three components: the actual operating unit, a headset which is attached to it, carrying two ultrasound transducers, and the test kits, which is to be used similar to an EKG and EKG patches. The short video should show you how Sonus works. It works in conjunction with so-called ultrasound microbubbles. The ultrasound transducers are placed on both sides on the head, being in a ping-pong fashion, transmitting and receiving on both sides. Ultrasound contrast agent is then being injected through a peripheral vein. ultrasound contrast agents are used normally for imaging modalities in cardio as well as in spleen and liver imaging. The ultrasound microbubbles for our purposes are not being used for imaging, but as signal tracers are being injected. They, as a bolus, they arrive, being then transmitted with the ultrasound, being activated, producing resonance frequencies, so-called harmonic frequencies. And these are being detected and then actually then calculated as bolus kinetic curves. So the assessment is very similar. The basic concept is very similar to perfusion-weighted CT or MRI. And the same parameters are being used then for further analysis, especially the time to peak component. So we have done a first safety study here at UCLA using this device in comparison to perfusion-weighted MRI, pre and post. The perfusion-weighted MRI, we wanted to see if the device is safe, which it is. It doesn't cause an impact of the blood-brain barrier. The bolus kinetic curves generated are very similar and correlate very well to the ones from perfusion-weighted MRI. So this was the first study we have done in humans. Then the report you see then is actually nothing else but these strip shots. It's version 1 of the device, 1.0. So you get a time to peak assessment of the whole head as a reference, and then we split the time signal into half and get signals. Then the perfusion assessment for both hemispheres, right versus left. This is how it would look like in a normal patient where the perfusion is not impaired. For example, by an ischemic stroke, it's always a comparison right versus left. So, and we build the differential between the right minus the left and the left minus the right, which is then shown as a delta TTP statistic chart on the bottom. Everything which is green is the normal range. Everything which is beyond that in the brown would be then a suspicion of a perfusion impairment. Now, in case of a stroke, you might see then a situation like this, where you look at the time to peak in the whole head being in the normal range, the one on the left side being in the normal range as well. And then you see these two peaks on the right side, one in the normal, one in the abnormal range. The differential of those would be the delta TTP suspicious of a stroke on the right, or the perfusion abnormality on the right side. The reason why you see this is due to the fact that we scan a volume of the brain on both sides. This volume might contain then an area which is perfusion impaired, such as the branch occlusion, and that's why you have two different peaks in this area, and this is why these two peaks are being shown in the test result, as you can see it here. So that's version 1, left comparison to the right hemisphere. This is how we started with. Just from the perspective of what we have today. Today now, with a new version which is being released very soon, we have the ability to split the hemisphere once more in so-called quarter spheres, and to allocate the quarter spheres to actual vessel territory in the anterior circulation, means left MCA, left ACA, as well as right ACA, right MCA do the same thing. You assess the time to peak, which is then presented as a plot or chart, as you can see it here. We are now actually able as well to, in each of these quarter spheres, to take the perfusion information and normalize it against the mean, the average arterial pressure, and get a flow index, which is equivalent to a resistance index for each of these quarter spheres, I mean for each of these vessel territories, and compare each of those against each other. So we are doing now clinical data gathering. We have clinical partners mainly in Germany. 7 sites are using this device in clinical use right now, whether it's in the stroke center, comprehensive stroke center, or on the neurointensive care. First and foremost, the Charité, but the universities in Gießen and Freiburg are collecting data as we speak. We have new clinical partnerships here in the United States, very new, which is right now the Northwell Hospital Group as well as the Mount Sinai Group. The device is currently being used for 4 different applications. That's perfusion screening. That means patients are coming in with stroke symptoms and then being assessed whether they have a perfusion abnormality, yes or no. We use it for perfusion monitoring post-treatment at the patient's bedside. We have a neurosurgical site which uses this device for vasospasm monitoring and for intracranial pressure monitoring. Reason for ICP monitoring is that we have detected that the flow index we can generate for each of the quarter spheres correlates very well actually with the actual measured ICP, for example, in patients suffering from suboptimal hemorrhage. So where are we right now, just in our development? So I've mentioned we have done a safety trial here at UCLA. We have performed a phase 2 trial in patients suffering from LVOs, where we could show that the device, in comparison to perfusion-weighted CT, has a sensitivity of 91%. Specificity we couldn't test to this extent, which we're doing right now because of the patient population we enrolled. We have a CE mark for the device. It's a class 2 device. We have about 300 data sets collected right now for all the different indications I've mentioned. We are currently in preparation for our IDE application. To be mentioned here that the filing for the IDE application will be a joint filing together with one of the major microbubble manufacturers, which is a pretty unique approach. And we have first publications, which I would like to refer to very briefly in the next slide. So in all of this available, so I'm happy to obviously provide all this data. I didn't want to do it now in terms of times, but we have starting with the first case reports showing that the device really does what it's supposed to do to detect the perfusion deficit in ischemic stroke patients and allocate it to the right side. We have published the safety data, which we've collected here at UCLA, showing that there's no blood-brain barrier damage with the device, and the correlation of the time intensity curves is very well with MRI. The main paper is currently in review at SVIN. That's the summary of the first feasibility data to show that the device has a high sensitivity correlation to perfusion-weighted CT in actually LVO patients. And very recently in Barcelona, our first presentations on first case series that the device can be used for ICP monitoring as well as for vasospasm monitoring. The next slide just simply shows where we see the device will be used. We think that it's going to be used for treatment monitoring, first of all, at the bedside. Then it might emerge into the actual acute setting where we use the device for stroke detection until it then at the third stage will probably be used at the pre-hospital stage for the same reasons actually we've heard already earlier today, such as reimbursement. But we do think that this device will be a device which can be very well used for early stroke detection and bringing more stroke patients to allergic and mechanical thrombectomy. Last slide is just simply, I just would like to mention being here for this prestigious audience that we are in preparation for our FDA clinical trial. We are now seeking for clinical centers here in the United States who might be interested in the technology and participating in the clinical trial. And with this, I would like to end my presentation. Thank you very much.
Tilo, congratulations on making steady progress and getting for prime time. So we're looking for a site for a clinical trial, sign me up. But let me ask you a couple of questions. So you mentioned you're doing ping pong with information. And one of the problems with transcranial Doppler was always focusing on the MCA. Your technology has ability to actually calculate total everything that travels through the terminal ICA, ACA, MCA proximally. Have you tried to, and you mentioned flow index, have you tried to actually predict the total cerebral blood flow volume?
Not yet. We have the data to do that, but we haven't approached it yet from an analytical perspective, but we have already the thought to the same extent. Yeah.
The bubbles give you ability to depart from the knowing arterial diameter. You can actually calculate actual blood flow volume. And then kind of a final question is, again, I'm intrigued with this ping pong because there were a lot of mathematical algorithms from time of flight to reversed acoustics and stuff like this. So what do you do if you can disclose that? You mentioned harmonics, but is there more basic information? Are you still utilizing Doppler shift? Anything to help you more than just harmonics?
The technology has nothing to do with Doppler. Spectrodroppler is not involved in this. It's simply knowing too much to the extent I can mention when an ultrasound wave travels, how long it travels, how long it excites microbubbles, for example, when the excitement stops and when it starts to get silent again to that time point and then release the other sound.
All right, so I'll help you with the with non-disclosing your methods. So the beautiful contrast accumulation curve, which is very similar what CT perfusion and other tracers do. What's your time resolution on that? Can you tell us how many times per second can you calculate that curve, or is it aggregative of how much time that you have to observe bubbles behavior?
So the length of the ultrasound pulse is 100 microseconds. So we collect data to create these time kinetic curves for about 40 seconds. In these 40 seconds, we generate about 8,500 different data points. Version 1. Version 2, which I just simply imply to, will double the data. So we will get about over 16,000 data points within 40 seconds, which will massively improve our signal to noise ratio. So we can really damp down the noise and get the signal.
It would be great if we can do it real time.
Yeah.
Very exciting, Thilo. I have a question though about left ventricular dysfunction. Have you looked at different ejection fractions in relationship to this? Because while we would think that it would be equivalent on both sides if you have a low ejection fraction, oftentimes that's not the case because of atheroma in the arch or the carotids or other things. So I'm just curious to see what the performance looks like in those low flow bad EF states.
But honestly, we haven't looked at it. And the only thing we just obviously take into consideration, because we need it for the calculation of the flow index, is the arterial pressure at the time we do the measurement. But ejection fraction, for example, is something we haven't looked at, but it's a great point. We will consider this. Thanks you. Thanks you.
I feel wonderful to see all the progress. It's come along amazingly. A lot to ask about, but I'm going to ask about the subarachnoid hemorrhage application. It makes a lot of sense that it could be done at the same time as standard TCDs. What would it add to standard TCD measurement of vasospasm by looking at perfusion?
You don't need the technical expertise anymore of a technician to find the MCA or any kind of MCA branches or ACA branches. And what you do with doing Doppler is it's a local assessment of the flow phenomena in a piece of the segment you just get. With the technology we have, you just simply insunate a volume with contains the vessel or suspect, and then you follow that. So you don't need it. So the technology is so simple to use that you just have to read the manual once, and you can proceed it in a technician. So every nurse can do it. You don't have to have a technician anymore.
Great, thank you.
Okay. Great presentation. A lot of interest in this technology. No, that's okay. No, not a question. I think we need to move on to the next presentation. I think the next one's on AI, because I think we're skipping one. Jens Fieler is going to tell us all about AI in 5 minutes. Right, David? Is he next?
Hello, dear colleagues and friends. My name is Jens Fieler, Hamburg, Germany. Unfortunately, I can't be with you in LA, so I have to record it because when this is shown, it's in the middle of the night. So, subject is AI, and I didn't have any more instructions, so I took the liberty to share what I always wanted to tell you. My disclosures, yes, AI training. I think it's very important to think about how this is all working. So you have Hello, dear colleagues and friends. My name is Jens Fieler, Hamburg, Germany. Unfortunately, I can't be with you in LA, so I have to record it because when this is shown, it's in the middle of the night. So, subject is AI, and I didn't have any more instructions, so I took the liberty to share what I always wanted to tell you. My disclosures, yes, AI training. I think it's very important to think about how this is all working. So you have training data, patient data in our case, imaging data, clinical data, whatever. You put them into a computer where a model is trained. And the output of this whole thing is a prediction model, which is essentially kind of a formula. And this formula is the product of a long training, very demanding, challenging from a computational perspective. But then we apply the whole thing. We apply the next patient, the pre-treatment data is fed into the model, and the model predicts something with a predictive score. Let's say infarct risk here, distribution of infarct risk in our case, for this patient based on the knowledge of many, many more patients. So it's essentially put into perspective with the training. Then the next important thing is that we need a decision. It's not just some scoring, but we need to do something with it. And how is it done? We need a human, typically, to assess the predictive scoring and do something with it, the decision. So we could theoretically have an automatic decision or decision support for the physician. And I think it's very important to always understand that it's based on training data that is maybe biased, and that we have a predictive score that we need to work with. And this applies to all the AI applications that we are using in our practice. How is this training done? This training has advanced massively. So this is 6 years old, the graph that I'm showing to you. So to be better than the best human trained Go model, this is alpha 0. So this is without, this is just a model that was fed with the rules of the game and then trained itself. And after 3-4 days, it was better than the model that was trained with human play. So this was absolutely superhuman in the game ability. So no Go player has a chance nowadays against these programs. But we are talking about neurointerventions, and the basic applications are image analysis, so detection and assessment. So for instance, detection means aneurysm, yes, no, LVO, yes, no. And assessment means we really have a more qualitative or quantitative view on the size of the infarct or something like that. It's not a yes, no, it's beyond that. Then we have the organizational application for prioritization, internally, external notification, study enrollment, and then device cycling for flow diverters. And the future applications are more interacting with the physician, so guidance in DSA, analytics of thrombus, in silico trial, brain-computer interfaces, and so on. So when we assess an AI application, it's important to understand what do we want to achieve. Do we want to automate something just below expert level? Just prioritize ICH, is there an ACH, yes or no, and to have an earlier reading? Then to improve towards average performance or even expert level? Or finally, do we want to achieve something superhuman, so beyond the typical expert? So do we want to be better than the best image analytic expert? So this is important to understand, what does the software want to do? let's say in the field, just detect an LVO that the expert can easily detect, but it's quicker and it's more standardized, can be used without a radiologist? Or do we want to be way better than what a radiologist can do with radiomics, with 6,000 features for differentiating different types of metastases and so on? And then to assess the risk benefit, we need to think about how close are we to therapy decision making. So what's the actual difference? So actually, not legally. And if we think about stroke, we can differentiate into pre-hospital, acute therapy, ICU, rehabilitation. So pre-hospital, typically symptom recognition, phase recognition. You see there are different startups that are looking into this. LVO detection in other hospitals, hospital selection, pre-notification is something we will mention quickly. Then for acute therapy, basically it's imaging related, which is a big chunk of all the AI stuff that's going on, but not everything is really AI. Something is, like David usually says, automated imaging, not artificial intelligence. And then thrombectomy, many applications here, and ICU rehabilitation, so neuroprosthesis, essentially brain-computer interface, and so on. This is all very heavily based on AI, but 10 minutes, we don't have time to cover all of this. So I would like to go to one example that I like a lot. So let's assume this is the endovascular center, this is the non-endovascular center, and this patient is somewhere in between. So where does this patient go? And this is dependent on different factors. So for instance, how good is the non-endovascular center? What's the door-to-needle time there? If the patient waits 2 hours anyway, then he can go directly to the endovascular center. But let's say if the door-to-needle time is very, very poor, it's even more important to go directly to the endovascular center. So a lot of factors go into this decision-making. And we looked into this and we compared a grip and write approach. So when we go to other hospitals, to mothership, patients come to us, and grip and ship patients come from other hospitals to us. And this is the pattern or the environment in northern Germany. This is Hamburg, this is the environment. And this is the normal setup. So there are some regions where we go because it makes most sense. But if we have very little resources, so all our NGOs are occupied, the region where it makes sense to go is larger than before. And this, as it turns out, is even dependent on the time of the day. So if the traffic goes into one or the other direction. So this could be very useful also for directing patients dependent on the time of the day. And this can be combined with what you know, automatic LVO detection, notification system combined with the traffic. I think this is where we need to go, because including real-time information from traffic makes a lot of sense. The other interesting subject is endpoints. So for clinical studies, so randomized controlled trials are obviously the gold standard. What we typically are doing is comparing new single-arm therapy with old therapy from the literature, but we could also do a virtual comparison. And this is what we did here in the ERASER study. Typically, you compare outcomes from the old therapy with the new therapy. But what we did is we trained a model, machine learning model, with the old therapy. Then we used the pre-treatment data of the new therapy patients and predicted the outcome with the old therapy. So we compared each patient with herself here, with the actual observation and the prediction, and then we could make a difference. So I think this is a very interesting approach for clinical studies. So don't have time for this, but yeah, essentially the summary of my talk is many applications, but really think hard about what you want to achieve and so-called in silico trials are very interesting thing for the future. Thank you very much, and yeah.
Questions or comments? I guess John is not live, but do we want any discussion or should we go on to Sunil? Sunil, are you up next on A? I have on my calendar here, generative AI for precision medicine. Unless you need a few more minutes. Oh, is Greg next? Okay, my bad. Oh, it's a panel. Okay, sorry. Okay, David, you tell us what's going on.
So we're waiting for Mark Rebo to join via Zoom. He's on the Zoom. Yeah, Chung Long said he's.
Yes, I'm here. Can you hear me?
Yes, we can. Thank you, Mark.
Hello.
And I was just, I'm going to try and get the others and find where they are virtually. But if you want, you know, so the next session is the first of three that are open discussions, debates, trying to make it controversial or just open formulative discussions on each topic. So if you want to start speaking, Greg, and then get into some debate on this, that's fine. We have Mark online, Sunil. I was trying to get Kambiz Nael as well as Mahmoud Musa as well. So let me find them but go ahead.
Okay, great. Just do a few slides, and then I think Sunil has a few slides also. Disclosures or a schema view. This is the company that purchased the Rapid software from Stanford, and I've been involved with the Timeless study for the last few years with Genentech. So we'll start off with some limitations. I'm often surprised when people are surprised when an AI software makes a mistake. Somehow they think that computers must be perfect, but everything I've seen has false positives and false negatives. So it's important to be aware of those outcomes. And that's why clinician oversight is mandatory. I never think of this as something that's out to take our jobs, but to make our jobs easier and to make us better. That when we do studies and we look at how the AI does on its own, does pretty well. How does the human do on its own? Pretty well. But if you put them together, they do better. So it's really to make us faster and more accurate. One of the things that's really important is that imaging protocols are evolving rapidly. And these AI softwares depend on how they were trained. And if they were not trained on a protocol that's now being used in practice, they may not perform so well. So I'll give a quick example of one of those. And then technical issues, such as what's the field of view? If the software is trained for one field of view and you use a different one, your results may vary. And then it's also important to realize that a lot of these AI softwares are triage and notification. They just say, hey, I'm suspicious of a disease, but you need to find it. Whereas as we move to the future, it's nice to actually find the disease and tell you something about it that you wouldn't know on your own or the radiologist couldn't tell you. One of the things that we're seeing now as AI is getting a little bit more mature is that new versions are a lot better than the original. There was a huge number of ICH detectors. They had issues with false positives, and they didn't provide the volume. So the new versions are doing better. This is a study that we just finished with 900 patients with a new version of an ICH detector. It's faster. Its sensitivity is very high for very small hemorrhages. And most importantly, the specificity is moved up from 95 to 99.5. Why is that important? If you're looking at an uncommon disease like finding aneurysms or hemorrhages, and most of the scans are not going to have that disease, you can wind up having more false positives than true positives. So the false positives can actually be a big issue. So having really high specificity is nice. So AI can do a good job in finding volumes, but it's very hard to get the FDA to approve an AI software that gives you a volume. So you have to have different strategies to get around those FDA restraints. One of them that's been used here for hemorrhage detection is to take a scan, identify all the normal hyperdense structures, suppress those, and then give you the volume of anything that is left that's hyperdense, which 98% of the time is a hemorrhage, right? So this is a FDA cleared module that allows you to get hemorrhage volume, and very accurately, if you compare it to what a neuroradiologist hand draws very painstakingly slice by slice by slice, Pearson correlation is 0.99 and the median error is 1.5 ml. So if you're looking at stability scans and the patient is a little tilted and radiologist doesn't know is the hemorrhage grown or not, here you can get an actual volume, or a new neurosurgical procedure that depends on treating somebody with a specific volume. One of the things that's overwhelming for physicians, and is going to get more overwhelming, is you can imagine that you've got a patient and there's 12 different AI modules that run on that patient, and you blast it with 12 different results, at least half of which have no relevance to that particular patient. So the FDA has a breakthrough designation that allows modules to work together. So the first one that's approved through this breakthrough designation is called NCCT Stroke, which is allowing 3 different modules: ICH detector, a hyperdense MCA detector, and a hypodensity detector to work together. And it can give you notifications that tell you that the patient has a suspected large vessel occlusion. Specifically, the MCA occlusion is what this first version of the device does. So it's looking first for hemorrhage. If there's no hemorrhage, it looks for the hyperdense MCA sign. And since that only occurs in about 45% of patients with an MCA occlusion, it also looks for hypodensity in the MCA territory. And by putting those together, it picks up close to 2/3 of the M1 occlusions from a non-contrast CT. So this can be helpful, particularly for sites that use the common approach of doing a non-con CT, taking the patient off the scanner, thinking about it, talking to somebody, and then putting them back on to do the CTA. Because here, you know, at the time of the non-con that you've got an LVO. This may be particularly helpful as you look at countries less sophisticated than ours, where there is less availability of contrast and less availability of CTA. Everybody knows about the LVO detectors. Some of the limitations are that the ones that are on the market in general are not picking up Baslers, they're not picking up MEVOs, they're really focused on ICA, MCA. And just to give an example of how a technical issue can cause problems, this is a patient who actually has a normal circle of Willis, no MCA occlusion, but was scanned with an incorrect field of view. The software was not trained for this field of view. So if you scan with the field of view that is specified by the software, and that's important to know as you're using softwares that you have to have your protocols match how the software was trained, then you see that there really was no LVO. So another approach to vessel imaging is, rather than just saying I'm suspecting an LVO, do something that shows you the blood vessel density. And this can pick up MEVOs. So here you can see where you're picking up a reduction in blood vessel density, so you can get beyond the proximal vessels and start looking at those, M3 vessels and ACAs, PCAs, et cetera. We talk a lot about aspects today, and the fact that guidelines are probably going to drop our aspects limits down to 3, at least for early patients. So we've got a couple of automated aspects programs that are on the market in the US. They've been shown to have ability to make your typical reader more like the super neuroradiologist reader, improving their ability to read aspect scores. But in terms of technical issues, you have to, again, watch out. This was an interesting experience we had when University of Wisconsin which is Howard Rowley's group, really sophisticated neuroradiologists, said, hey, the aspect scores are not working. Something's wrong with the aspect scores. And took a look at a bunch of their cases, and indeed, they were not accurate. The aspect scores didn't work. And to make a long story short, what happens there in Wisconsin is they're developing new sequences for GE, and they were doing thick overlapping slices on their non-cons. Software was not trained for that. So in the thick overlapping slices, you wound up getting a lot of false positives in the software. So just by taking those thick overlapping slices and turning them into thin non-overlapping slices, you can get this false positive where this normal scan gets called a 6 with the software looking at a sequence it hadn't been trained on, and then to the thin slices, it goes back to normal. So we talked a lot earlier about hypodensity maybe being important. One of the limitations of aspects is it doesn't correlate so well with volume, and it doesn't correlate with the severity of the hypodensity, as was pointed out very nicely by Albert earlier. So these are maps that were introduced a couple years ago to be co-registered into the CT perfusion. The reason for that is I used to get a ton of calls where people would say, hey, the CTP missed the core. And the CTP didn't miss the core. The CTP tells you how low the cerebral blood flow is. If the cerebral blood flow was low yesterday and then it's better today and there's a subacute infarct, CTP may look normal, right? So putting this in allowed people to see the subacute infarct along with the acute area that currently has low CBF. And as people looked at these maps, they said, hey, this looks like something I'd like to have even if I'm not doing a CTP. And what Amru alluded to earlier, didn't want to give the details because it's being held for Bruce's presentation at ISC, is that there's a lot of interest in these large core patients in not all of these aspects of 3 look alike. Some of them look pretty subtle with mild hypodensity. Some of them have very severe hypodensity, and very severe hypodensity, even a small volume, may be a bad prognostic sign and may have an impact on therapeutic response. So this is an FDA cleared hypodensity volume and severity detector. So you can see the areas that have a substantial Hounsfield unit change in the range of 10 to 12 Hounsfield unit drops. What's that value? How much volume has 7 to 9 or less? And I think this is really something exciting as we dig deeply into the results of these large core studies. If you want to go straight to the cath lab, some people might like to know that there's still a perfusion deficit there if they got treated with a thrombolytic at the outside hospital. There have been a couple of studies published recently showing that you can get reasonably comparable results to what you get at CT perfusion in the ER when you do it off the cone beam CT in the angio suite. So it's just a minute scan, and you can get, not quite the signal to noise, the quality, but you can certainly tell, is the vessel occluded and does there look like there's a very large core? So a couple of the papers that are published, I think we're going to see more on this over the next couple of years. And I'll finish up with just commenting about differences again between triage and notification versus detection-based AI software. Aneurysms aren't all that common. You're going to feed in a lot of cases. Software says aneurysm suspected. If the specificity is 90%, you can see more cases where you go through and you don't find an aneurysm. So software says aneurysm suspected, you look and look and look and it's not there. So having one that you can find the aneurysm, shows you where it is, and then gives you a measurement that you can't make yourself. So that measurement is surface area and volume that can come off the AI software. Why is that important? This was a very provocative study from Dan Saline and colleagues at Ascension, published about a year ago, where he looked at the cases that are rare but very upsetting, right? You're following a patient who's got an aneurysm, it's not big enough to coil or clip, and you do your repeat scan, and it looks fine, it hasn't grown. You tell the patient, don't worry about it, come back in a year, everything's fine, and they come back in a month with a subarachnoid hemorrhage, right? So he had 5 of those and said, well, what if I had AI software and I could have fed it through the AI software? Would the AI software picked up that that aneurysm was actually growing? And the answer was 5 for 5, yes. Here's an example of a case. You can see the CTA. Both the interventionists and the neuroradiologists looked at that case and said, this aneurysm is stable by their standard linear measurements. It's not growing. Patient, you're stable, come back later. Patient has a subarachnoid hemorrhage a few months later. So then feeding things retrospectively through AI software, you can co-register the aneurysm to the the baseline to the 7-month follow-up. And when you do that, you can see that there's been a change in surface area and volume. So they suggested in this paper that maybe that this is the way we should be doing it, because a single linear measurement is not nearly as accurate or as sensitive as surface area and volume. So it's a quick overview of some of the very exciting things about AI, but also pointing out that there's limitations that are important to be aware of.
Thank you. David, you want questions for Greg now, or just we all present and then afterwards? Okay. Okay, then I will go and then pass it off to one of them. Can you guys, I'm sharing it. Okay. You know it's not showing? I guess I'll just do it like this. So thank you, David, for the opportunity to talk and be a part of this great group. I'm a stroke and interventional neurologist at UT Houston, and great to be back here at UCLA, where I trained for both my fellowships. Thank you. Thank you. It's good to come. It's good to come and give a talk after the 2-drink minimum has already passed too. That helps. In terms of disclosures, most relevant to this talk is I have grant funding and consultancy fees from Viz.ai. I'll be honest, it's not that much money. I don't think I'm that conflicted. I do have an R01 for developing machine learning algorithms for stroke imaging. These are all free software. There's no commercial advice there. So for the next 4 hours, David gave me permission. We're going to be taking a real deep dive into machine learning and going through some of the algorithms. There wasn't my idea, but there's going to be a quiz at the end. Your hotel may not get reimbursed if you don't pass them. Of course. I'm not going to go through a lot of details, but one of the points that I want to make in the next few minutes is that it's very important, I think, for us as vascular neurologists and neurointerventionalists to be very literate in the world of machine learning, and specifically, what is happening in these algorithms? How do they work? When do they fail? And Greg kind of talked about that a little bit as well. And how do you measure their performance? In the same way that to do clinical care, you have to have some understanding what is a p-value, what's an odds ratio, what are the models that generate these numbers, logistic regressions, these shift analyses that people use these days. You don't have to know all the math behind it, but you have to know in general what's happening and when can they go wrong, and how do you interpret these findings. And it's the exact same thing for machine learning, is that you have to kind of have some sense of what's happening under the hood. I won't go through some details, but just at a very high level, there are many steps along the way that go from your scan to the result. And we're focusing here just on imaging algorithms. There are steps that go into the process before the machine learning algorithm actually does anything in pre-processing steps. And then there are several different types of machine learning. And I want to take just a second here to talk about some of the more traditional machine learning algorithms versus what we call deep learning. And machine learning, you use oftentimes you use something called feature extraction. So feature extraction is essentially what we do all day long. So we have a stroke patient, or we're doing a trial on a stroke population, and we're trying to figure out, does intervention X help or not? We've heard so many of these trials today. And what feature extraction is, that we tell this algorithm, maybe it's logistic regression or something else, these are the variables that we think are important. We think age is important. We think stroke scale is important. We think occlusion, location. We think aspects. And we feed these. We extract. The human expert extracts these features. It then gets fed into the algorithm, and the algorithm does its work, and it gives the prediction. Deep learning is a very different situation, where the feature extraction is being done by the machine. You are not telling it, oh, look here, look here, look here, look here. There's some mixes between these two, but essentially the machine is determining for itself
these features that need to get extracted. And we were just talking a little earlier, which is the fun part of these meetings, is that you can have all these little discussions. But if I were to just take a step back, and we're supposed to be a little controversial here, I guess, but if I were to take a step back and think about, what were the imaging features that we used, human learning imaging features to decide about reperfusion therapies. And I wasn't really that into the field at the time, but in the 90s, we looked at things like 1/3 of the MCA territory, right? So the NINDS trial, we're thinking thrombolysis. We said non-contrast head CT, 1/3 of the MCA. If it's more than that, it's probably not a good idea to give them thrombolysis, but if it's less than that, it's probably a good idea. And then, a few decades later, we thought, well, maybe the somatotopic organization of the brain matters, and not every voxel of the brain is worth the same amount as the other. So we developed this aspect system. So, there's some introduction of eloquence in aspects. And we had the 2015 trials that ran largely off of aspects. And then after that, we thought, well, you know what? Why don't we actually just measure how much brain we think is alive and dead? And we started using more perfusion studies and looking at CBF and Tmax and looking at mismatch. And then we did the 2018 studies, or the late window studies, and now we're in 2023 in the large core world, where we're thinking, actually, maybe these aspects and these core measurements that we're getting off of CBF, aren't that meaningful. Maybe it's something else. Maybe it's the density of the edema, like Albert was talking about, or the degree of hypoattenuation of the tissue. And so it's taken us, let's say, 30 years to get to this one feature of attenuation on CT, degree and volume. The thing is, if you feed this through, that's one feature. If you feed these through these algorithms, it's going to find 10,000 features that we wouldn't think of in 100 years. And it's going to process these on its own. So, what are features? It can be anything. It can be really anything that it's going to derive by its own effort. And it's going to be things that we have thought of, things we have not thought of. And that's where they're kind of the magic and the secret sauce of what's happening in these deep learning models. So as much as, my view is, as much as we like to kind of perseverate and pontificate, and how do we define X and how do we define Y and what's the cutoff and this kind of thing, I think we don't need to spend that much time doing this. If we have the right data set and we can train it, these algorithms can do this. The thing that I think we fall into the trap of a lot is if you don't have a good understanding of how these algorithms work, there's a tendency to want to ask a question and then just like think of machine learning as a button. You press the button and it solves the problem for you. And I think people like to do this with ChatGPT, like Otto does. We know that, but it can't solve every problem. But there are some problems that it's very good at solving. And in my view, this problem is one that machine learning would be very good at solving. So the other thing, like I was mentioning with p-values and odds ratio and stuff, it's good to familiarize yourself with how we measure performance. So with classifiers, meaning, it falls into this category, that category, it's the same type of operator, same type of method that we'd use for, conventional frequentist statistics with receiver operator curves or precision recall. Precision recall is something we're probably not as used to, but it's more invariant on incidence or prevalence of outcomes. Segmentation is something we use a lot in imaging, so predicting those ICH volumes or predicting those infarct volumes, and there are many different metrics to do it, but the one that people use most commonly is F1 score. That's the kind of graphical depiction of how you calculate that. But it's, again, something that when someone comes to you and they're trying to sell you their machine learning software, ask these questions and try to get some of these numbers to understand, is this worth your time and effort? So just in the last few minutes, because I want to save some time for discussion, I have some more slides, but we'll go through them quickly. What can machine learning do for you? And I'll give you a couple sort of examples of what I think is very useful in the world of stroke that machine learning can provide. And the first is workflow enhancement. So this was a study we recently published looking at workflow enhancements after we implemented automated LVO detection. And there had been several studies beforehand, but this was a topic that I think, like with any intervention, deserves to have relatively rigorous, trial-based evaluation. And so we set this up that as we were implementing our LVO detection software, we did it in this randomized stepped wedge fashion. So it was this cluster
randomized intervention, and then we looked at what the effect of that actual intervention would be on our door to groin time at 4 comprehensive centers in Houston. And this I think addressed some of the limitations of prior studies that were more pre-post based. When you particularly have when you have a thing like door to groin time, which every hospital in the country is constantly trying to improve, but when you have this more randomized setup with this wedge design, then you can address this in a more quantitative fashion. And we found, I think, as everyone would expect, that with LVO detection and with automated notifications, we got faster. This is just a depiction of the cluster design, the step wedge, and all these photos, by the way, are the people that helped on this. So this is JC, one of our former fellows, who's now faculty with Rishi in Atlanta. This was, again, our outcomes. We found a reduction in door to groin time, and also, as you'd expect, CT to thrombectomy time. So CT to groin time also went down. That was the main reduction, which is what translated to the door to groin time reduction. We heard a little bit about aneurysms. We also ran a lot of our images through an aneurysm detection module. And this was actually pretty humbling and enlightening for me, because I had made a few assumptions about our ability to detect aneurysms. And I thought, one, we work in a really good place. We have great radiologists, we have great neurologists, we have great neurointerventionalists. And if we have an aneurysm on a scan, we're going to catch it either on the radiology report or when we, the clinicians, go through the imaging reports or go through the images ourselves. I thought that if we miss aneurysms, they're going to be small, they're going to be cavernous, they're going to be things that we don't really care about too much, and there's not a huge price to miss them. So we ran all the CTAs that we did over about a 9-month period that were obtained on code stroke patients through an algorithm. And what we found was there was actually a surprisingly large proportion of patients that we missed. And by missed, I mean they didn't show up on the radiology report, or they did show up on the radiology report, but we didn't really schedule follow-up with them. And again, I still think we work in a very good place. We have amazing leaders that founded the program. I don't think this is reflective of a local experience, but more a general truth, which is that there are probably many aneurysms that are being missed both by the clinicians and the radiologists. And these were not small aneurysms. There were many aneurysms that were quite large in size. If you look at the distribution, the ones that ended up in follow-up versus the ones that ended up not in follow-up, the distributions overlap substantially. The median phases score, which is something we use to predict rupture, was around 4. This is a video of one such aneurysm that we did not pick up, and as you look at it on this sequence, it's pretty clear that there's an aneurysm there, but in the course of this patient's care, this PCOM aneurysm was completely missed. So I think the take-home message is that having someone look over your shoulder with the expertise of a great neuroradiologist and just tapping you and saying, just take another look, I think would be very, very useful. The last point that I'll make is about access. I think that whatever we do, in this room or in this, conceptual space has to be something that can apply to the majority of people. And I think it's great to really theorize and hypothesize about, very fancy sequences that can be obtained, in a handful of patients in specialized settings. But with the resources that we're lucky to have, I think we have to use these things to help as many people as possible. And this is Dr. Kim. Oh, I forgot to mention, this is Steve Kim, who's one of our fellows, who's now with Albert, finished his fellowship. And this is the other Dr. Kim, who's a faculty at the School of Public Health, who did this work. So I think the concept of what makes sense for imaging has to incorporate who can get it and how quickly they can get it and where this can be offered. So if it's going to be used for screening patients in general, it has to be something that people can get. So to conclude, I think that as we think about advanced imaging, I wouldn't classify this as something fancy, sophisticated, limitability. I think advanced imaging should be intelligent imaging that takes imaging we can get and analyzes it in a way that makes us help our patients. With that, I will conclude and just encourage everyone to take the time to try and understand what's happening under the hood of these algorithms, it will help you in your clinical decision making.
So we also have Mahmoud on the line, as well as George Harston and Mark Rebo, and joining us from Europe. So I don't want to admit it, but it's quite late there. So guys, thank you. Do you want to speak next, or comment, or have an interactive discussion?
Yeah, can you hear me?
Yeah. Go ahead, Mark.
So yeah, thanks, David, for inviting me to this discussion. I did not prepare slides, but I had some ideas I can share here for the discussion. I agree with what was said. Until today, for the last 15 years, we have been looking at AI basically in relation to two things, core and LVO detection. Now it seems that core, we're going to be caring less about this, less and less, but still the opportunities that we have with AI and imaging are huge. You have mentioned here the how AI can somehow substitute the use of contrast especially in those places in which there is difficulty to access contrast. And I can mention some other examples that were not really, I think I didn't hear you mention, but agree, you need to make this technology useful in daily clinical practice. We can work in detecting or predicting ICH, that differentiating those that will still expand or those who are not going to continue to grow. Also, we had a very nice experience predicting infra growth, and Greg just published, I saw it yesterday, a paper in relation with Timeless, how you can predict very well how patients will grow their infarct or not, the speed, and this has a special value in the scenario of neuroprotection trials. In the April trial that I'm going to comment at a later session, we use the AI to select those patients in which we only included as an inclusion criteria for the trial. So we wanted to exclude those patients with very good collaterals, in which infarct will not grow, that will have an excellent outcome with the standard of care. Those were going to dilute the effect of the neuroprotection drug, and therefore we end up having a positive study with a neuroprotector by having only 50 patients per arm. And because we managed to select the population in which the treatment effect of the drug was going to be maximal. And also a very relevant question is to try to dig deeper into the nature of the clot, into trying to help us to predict ICADs. So this has an immediate effect in the what the interventionalists were going to be using to treat that case. And finally, also, we did not mention here that this technology allows us to combine different sources, not only imaging, but we can combine other clinical variables into these algorithms. We can feed these algorithms with clinical and imaging variables at the same time, and we can enhance their performance. I wanted to share with you these ideas, and I'm ready for further discussions later.
And just to add to the discussion, I think these are areas that we've certainly been working on. We've published data on intracranial hemorrhage, showing really how accurate these algorithms can be in terms of detection of hemorrhages. In addition, specifically in the area of small hemorrhages, how AI can potentially enable detection of those smaller hemorrhages. You know, the question is, across the board, how valuable is detection of those? We have seen a couple of them that have grown, but obviously a majority of those small bleeds don't end up progressing. But so in that setting, there are potentially a few of them that will change. In terms of our analysis on aneurysms, our data was a little bit different. I think for us, we found that a majority of the aneurysms were detected by radiologists. There were a few more misses by radiologists than the AI algorithm, but generally it performed pretty well. What we found was that smaller aneurysms certainly were better depicted by AI, but at the same time, in terms of ruptured aneurysms, the radiologists actually did better than the AI algorithm. And potentially one reason for that is because we use secondary clues in the setting of rupture. You know, when there's subarachnoid hemorrhage present on a CT, CTA, the neuroradiologist is likely to spend more time searching for that aneurysm and potentially detecting it. So that could be a potential area of improvement for some of the AI algorithms is, you know, they don't have that functionality where each case they're going to look at the same. And for human raters, we'll have that additional kind of indirect data that we'll input in terms of our analysis. But in the end, I think it's a very helpful and beneficial aid in terms of us evaluating studies. One other thing I did want to mention in terms of LVO analysis, and you know, and the other thing I want to mention is between the different algorithms, performance is going to differ. There's going to be, you know, performance drift in terms of different environments. You know, when you apply an algorithm that was developed, you know, with a specific data set, you apply it to your own data, your institution. The performance may be a little different than you know what exists in the literature based on prevalence of disease, based on training, and based on a host of different factors. So it is important to ensure that, you know, whatever AI algorithm you're looking to implement works appropriately on your data set. But I do want to mention, I think sometimes there are some errors that we end up seeing. I think in one data set that we were looking at, there were aneurysms that ended up getting flagged for LVO, large vessel occlusions. And so in that setting, I think that could be a potential pitfall that you can look out for. But in general, I think there's certainly a lot of benefit clinically that's been shown. I think, especially depending on your practice setting, if you don't have a subspecialized neuroradiological group, it can certainly be even more beneficial in that setting to provide that extra layer of evaluation. Anyone else have additional comments or?
Yeah, I was going to. I can't hear anything from the room, but I'm hoping that they can all still hear us. So I think that I do agree very much with all the comments that have been said so far. I was just going to share a couple of slides because I think there's one of the things that I think particularly interesting around AI is around evidence of value and what that means and what evidence performance as well we need. So hopefully that's sharing now. So I work at Brainomics, so we're a UK-based a company. We're just entering the US actually. Our products are now FDA cleared, and thinking a lot really about what the opportunities are to improve healthcare in all healthcare systems. And I think just setting a step back, thinking about the sort of where we can add value to a patient, which is ultimately what we're trying to do. There's sort of different parts of the decision making that you can influence, and I think, you know, we're, in terms of what we can do at the moment, you know, and I mean sort of generally in all fields, is screening and triage is clearly big business. You know, in lung cancer screening, there are sort of algorithms for looking for nodules and what have you, and in stroke as well, thinking about suspected LVO. But these are all still decision support and not really at the level of a standalone diagnostics at the moment. But I think that's you know, something as the technology develops and the algorithms develop, I think we'll get closer and closer to. But of course, we think a lot about treatment decisions and particularly balancing risk versus benefits and then treatment monitoring clinical trials. And I think one of the I find really interesting is the concept of extracting value and information and value from imaging, and I think the AI has got a great opportunity to do that, particularly from more simple imaging, which can be contains a lot of information. It's just a matter of being able to understand it. So this picture here is Sir Godfrey Hounsfield, the inventor of the CT scanner, and he actually died of fibrosing lung disease. And one of his great frustrations, I found this out from a chance conversation at RSNA, was one of his great regrets is that his innovation couldn't help him because his imaging, the image, even having had a CT scan and showing this, it didn't really help his treatment decision. So I think unless imaging is linked to a diagnosis or a treatment decision, I think it's clearly has very little value for a patient. So I think this is really where AI has a fantastic opportunity to support that. And so we can identify more patients for treatment. I think we can, think about patient selection and the right patients for treatment, but also treating patients faster as well. And we've heard a bit about workflow, but only really does that have value if it impacts on patient outcomes. Actually, we should need to think about patient, the difference between surrogate endpoints and, of course, endpoints that have direct value to our patients. And we all know that imaging sort of paradigms and the way that imaging is used in different workflows can vary between hospitals, but this is a sort of schema to show some of the strategies that people might use. But I think for me, if you really want to add value to a healthcare system, you double down on your sort of simple imaging. And I think we're seeing the trends that are that simple imaging is being used more and more. And I think we're revisiting the non-contrast CT in particular and identifying more patients for treatment and getting more value out of that particular imaging modality. Skipper, we all know this, that actually AI is now sort of effectively a standard of care, particularly in the US, but also in Europe. And I think we're all familiar with the various sort of triage systems to identify suspected large vessel occlusions. But I think one of the things that's interesting for me as well is that we spend a lot of time thinking about algorithm performance, sensitivity, specificity, areas under the curve. But actually, it means nothing unless people use it, unless it's adopted, and unless patients can or doctors as their sort of as the sort of champions and users of the AI can access the results. And so I think there's a whole piece around the way that it's embedded in a healthcare system, making sure that the time is really optimized from sort of scan to output, and making sure that it gets used in as an accessible way as possible. Because I think that's just, if not more important, as, for example, fractional changes in areas under the curve. And I think one of the challenges we have is we're comparing different solutions is it is completely meaningless to compare a sensitivity and specificity from different data sets. The way they're selected, the way that they're the prevalence of the condition in the data set, and the sort of data quality. We really do need to be comparing apples with apples and not apples with pears. So one of the things I think that I think is really exciting is the opportunity to use AI to get more information out of simple imaging, as I said. And this is some work that we do, and straight physicians and radiologists in Europe have been enjoying this for years, and delighted it's now available in the US, is thinking about how you identify ischemic change on the non-contrast CT scan. And we've heard about aspects in the way that provides a framework, but actually using the AI on non-contrast CT, you can segment out what we estimate to be ischemic core. And I think that's a really really exciting opportunity to do more with less and to get more information out of routinely existing data. We've heard about identifying patients with hemorrhage, but also with evidence of large vessel occlusion and how that can accelerate time to treatment and improve patient outcomes. So when we develop AI algorithms in healthcare, very simply, you might think about the patient need, the data sets, the product, the validation, trials, clearance, and then adoption. But for me, this really hinges on evidence of value if you want to drive adoption. And a bit like, unless you can use the algorithm, you can get it on your phone or you can get it on a cloud or whatever it is. Unless you show people that it's valuable and encourage them to use it because they see that value, then again, it's not going to help any patients. And in order to do that, yes, we need these focused imaging studies, but we need to build on that confidence and understanding. And I think we really need to think about how we then make that clinically relevant, think about patient outcomes, prognosis, patient selection, and how we might modify our treatment decisions using these bits of information to give them some value to a patient, but then of course making it work at a large scale. And you can do that with different structures. So you think about standalone testing. This is a very popular study design. People like to do this a lot. How does AI compare to radiologists? And you know, and that certainly has a place. We need to understand what we're measuring and how it's performing. But actually, what we really want to do is think about how it's informing practice. And so the next step is then to think about how does it affect a radiologist? How does, for example, in this these graphs on the bottom right are looking at aspects, you know, as you'd expect in red is the unassisted reads, you know, and more specialist doctors do better. But actually, can we add value in green with an AI to improve the reads of all doctors and standardize and make it more equitable across the board, regardless of which hospital or which specialist or non-specialist you see. But ultimately, we've got to add value to patients. And so unless we can show that, then I think persuading people to buy and use technology is going to be very difficult. And so it's important to have patient-centered outcomes, and that might be, you know, access to treatment. So we might look at in an individual hospital, the number of patients being treated, and here you can see at the top sort of before and after AI implementation year on year. The access to thrombolysis, and then next to that is the in this MRS distribution is the access to thrombectomy. So after the introduction of AI in the top bar, you can see more patients being treated, but importantly, more patients with better patient outcomes as well. So it's not just we're treating more patients, we're treating them, they're doing better. So you're treating the right patients more as well. And so this sort of evidence, I think, is actually essential if we want to persuade people to actually use the technology. And similarly, we've heard about workflow, and you can show, you know, time saved on door in, door out time, but really just as important is to show that then equates to improved patient outcomes as well. And you know, here, you know, this was just using simple imaging, so CT and CTA, we're able to show that there was over an hour saved door in, door out time, but that corresponded to a large increase in the proportion of patients, as you'd expect with that dramatic time saving, having a good functional outcome at 3 months. But an individual hospital, I would argue, is not enough. Actually, we need to be talking about systems of care and generalizability. We often think about generalizability of AI in terms of, you know, data going in and for validation and things like you know, ethnicity or other sort of characteristics, and making sure that performance is consistent. But we also need to make sure that when it's used in the real world, performance is consistent across different hospitals, and that it's not just your select hospitals which are getting value from your technology. And this year we've very fortunate to have been able to do some work across the UK looking at sort of thrombectomy and impact of thrombectomy, and you can see the national average in the darker line over time in terms of access to thrombectomy and in this cohort of patients, and then in the evaluation sites, when we put the technology in, you can see the sort of the shift in numbers of patients treated. This is data that's being presented next year. This is preliminary data, but the full report's coming out next year, showing an uplift in the number of patients getting access to thrombectomy across a truly representative network of, I think in this case, about 37 different hospitals, going to 5 different hubs. And then just to finish, I just thought it'd be worth just touching on some of the sort of views for the future of AI and where we go. And I highly recommend this paper, which I had nothing to do with, but I think is a really nice, more general view on AI and healthcare that was published in the New England Journal earlier this year, which really speaks towards thinking about how we sort of build sort of the dimensionality of AI. I think we're very lucky, fortunate in stroke and in imaging to have really been at the forefront of the adoption of AI into routine patient care and the value, demonstrating the value that it can affect. But actually, as we go forward, how's that going to expand, including non-imaging data, fusing that data together? And we've heard a bit about that earlier. You know, features around the patient history as well, and all this information, as I think we're increasingly realizing, does require AI technology in order to fuse together in a robust way. But the other thing I thought was really interesting about this paper was actually thinking about the outputs as well, and having, it's not just about the inputs, but it's the outputs, and who's going to be the end user. Is it the radiologist? Is it the physician? Is it the treating physician? Is it the patient? And I think that's a really a really important point. And as we develop AI, it's not just about the algorithms, not just about the technology. At the input side, it's also about how it's output, how it's used, how it's adopted, and how it's trusted or not. So I'll wrap up there. I yeah, just wanted to share those thoughts about validation, and very happy to discuss anything about that.
Thank you to the speakers. I would like those in LA, please take the stage. We're going to have a brief discussion, and I'm kind of going to open it with a couple of statements. And first, thank Greg for excellent overview of what you are offering. So it was Brainomics and Sunil and Mark Rebo, and disclosure from Mark that you're about to go to dinner in Barcelona, right? The time difference. But anyways,
sure.
Wake everybody. So by definition, AI promise stands with an A, artificial, right? So you need to start building somewhere. And so the question is, some of you have very successful products already on the market. So first of all, how you started it with what was the gold standard? And then second, how do you evolve with your algorithms, and what do you use as continuing gold standard? Because unlike chess, where you can develop AI and beat finally the chess champion, which is human, I don't think there is that easily achievable goal for your product. So why don't we start in brief statements, please? Brief statements.
Yeah, so we started with MR. We're big fans of MR at Stanford, and we think that's the gold standard for finding core, and does a nice job with Penumbra. And then from there, that's not going to be practical. So we needed to switch it to CT perfusion. So for Swift Prime and Extend IA, they weren't going to be able to use the MR module, but the CT perfusion was going to fit fine. And then now we've been putting most of the effort, and what I showed you primarily is what can you get out of a non-con CT, right? So digging deeper into the non-con CT to try to get some of the same information that we were getting from MR 20 years ago.
Thanks, Greg. Well, you know, I would actually think of this in a different way, which is that the gold standard is clinical outcome. So is this patient going to benefit from this intervention? Yes or no? And what I think what we have been doing to date with machine learning algorithms on neuroimaging is we've hardwired them to output things that we think are important. We think aspect is important. We think CBF volumes are important. We think core defined by diffusion is important. But as we're learning, they may not be important, or they may be much less important than we think that they are. And so it feels to me like we as a group are going to Nobu and Malibu, and we're asking them to make us chicken tenders, which is with machine learning, when in fact there's so much more sophistication that could be coming, and we are kind of hard coding them towards giving us outputs that we may not really need to be looking at as closely.
Any online comments?
Yeah, no, I would echo that. I think, you know, broadly, you can be reductionist about this things. I mean, you can have your endpoints for benchmarking be imaging based, and they could be consensus, or, you know, as we've heard, you know, another imaging modality such as MR if you're using CT. But actually, ultimately, you want those clinical endpoints and patient-centered outcomes. So just to bring a sort of pragmatist hat to, I completely agree that I think there is an opportunity to do more that and sort of have not constrain AI with our preconceptions about what's important or not important. And I think that's a goal that I'm sure we'll get to. I think as a pragmatist, I think there are, if you want people to use these things, you have to start in as an explainable way as possible. So things that we know are important, or we think are important, I think that's a good first step in terms of driving adoption and driving a sea change and a change of way of thinking and an acceptance of AI technology. But I completely agree that I think as we get more used to and familiar with AI, the limitations, how we need to validate it, and then really importantly, the regulatory framework evolves to match that, then I think we'll see those more exciting opportunities that AI can afford in terms of, but it is more black box, and I think that comes with significant challenges in terms of implementation, trust, and adoption.
You know,
so
as
the
author on that statement that you quoted about artificial intelligence that came out from the American Heart Association. I can tell you that was a hard sell. And you know who was the hardest sell? The Comprehensive Stroke Center folks. Because we all feel like we don't need this, right? But we talk about the fact that we want this Camelot where there's this system of care that pulls everything through, and we know what patients need at all levels, and we make it happen in a streamlined manner. But that's not going to happen unless there's a way that artificial intelligence can be used at all levels of services and allow all of us to be able to see that case that's out here that maybe the emergency physician out there is clueless about, you know, and like basilar artery thrombosis cases that get missed all the time. And, you know, something like this is what's going to enhance the system so that you can call from that CSC down to that acute stroke ready or PSC hospital and say, hey, did you realize that you've got this sitting there? I'm working on a bed and your transport for you. How do we make this clear to people that this is not your enemy? And I think, Greg, you talked about this, that it's never going to be perfect. It takes the human and the AI together and kind of get over that so that we can facilitate everybody having these systems available.
This is my, I think, 33rd year of taking acute stroke call. And my life was completely changed by having the AI out at the community hospitals. So I'm at the comprehensive center. We have many reasons we like it, because it's not always easy for us to tell who's having a stroke when somebody rolls into the ER. But the big change in my life is when I'm on call and I get a call from an outside hospital. I used to be on there for 10, 15, 20 minutes trying to figure out what the hell is going on. And do I really want to transfer this patient? Because our beds are pretty full and I don't want to transfer somebody who winds up being drunk or having Parkinson's disease or a brain tumor. And now by the time the ER doc picks up the phone, I've already got all the information because we've got our 10 most common referring hospitals doing all this, you know, so I have CT perfusion, I've got the CTA, I've got the source images. It just completely changes the efficiency. The ER docs love it because they want to clear that ER. I don't get patients who are futile transfers. The transfers are people who really need to come. So that's the biggest change for me, is being able to pick who needs to move from that primary to the comprehensive center, because it is a fortune spent, you know, over the course of my career, flying people in who didn't need to fly in.
Okay, our next question before we end this discussion is from David. David promised me a very good question that we may actually open to all participants. Again, few punchy answers, please.
It's good that you called on me, but there wasn't one question. We're not ending the discussion right now because we've heard a lot about different approaches here. So there are a couple things, but I wanted to see if Mahmoud wanted to say anything in addition, because I think AI Doc and their approach is a little different in terms of the strategy in the field. But to frame it around, so Mahmoud, you can take the opportunity to speak on this topic. But you know, we've been presented with not just now, but over the years, a number of different parallel approaches that have been evolving. And the question is, you know, are they all the same? Some hospitals align with one particular technology versus another. How do we evaluate all simultaneously? Do we do it independently? And how does the field move forward? So in terms of, even from a business strategy standpoint, there's obviously, I can throw Tudor under the bus again because it's late night for him, and he's not here. He who famously says that imaging tells him nothing, or that it lies to him. I think everybody else does believe there's a lot of value in the imaging inherently. How do we maximally extract the most useful information is a real question. So in terms of the various strategies, one could take a step back and say, it sounds like, all the different companies are working on very similar technology. They're doing the same thing. There's a certain approach with aneurysms in terms of growth, in terms of LVO detection, in terms of, core detection. They're similar, not that different. I don't know, Mahmoud, if you want to comment or anybody comment about, how it evolves. And the second point that I'll put out, just so we don't forget about this, is the purpose of this just to improve, as Ann says, workflow at one institution, or is it for what has also been put forward in terms of drug discovery, therapeutic discovery? Are we going to be able to inform our clinical trials and development any better in terms of any therapy? So we figure out who the drug or device is working in better than in the next patient. So two questions. One, from a business strategy or a product development standpoint, are the systems any different, or are they in parallel? And how do we work together across the field and across companies? And then secondly, is it for improvement of current clinical workflow or future therapeutic development?
Yeah. So thank you, David, for that question. So in terms of discussion of business approach, and we've certainly had a lot of experience with Schema View, with some experience with Viz AI, and a lot of experience with AI Doc as well. And I think at baseline or at initiation, I think each company started at a different point. When you look at AI Doc, they started certainly on PE and intracranial hemorrhage, and those were really where they leveraged high quality algorithms and slowly progressed from there. But their focus was initially serving as an imaging aid in terms of diagnosis, where they fed through radiology departments and catered to radiology departments to provide these alerts to help in terms of diagnosis. I think Viz AI focused a lot more on their mobile platform initially and providing diagnostic information and image viewing to the ordering provider, specifically the stroke neurologist, the neurointerventionalist at baseline. And I think a Schema View was kind of in between, where they did provide the CTP communication across the board to all members of the team. And eventually, I think all those companies started kind of converging, where I think they all saw the benefits to other companies' approaches and really tried to converge. All of them now have those mobile viewers. All of them provide information and data to the ordering provider. And all of them have those AI triaging and detection tools. And I think for us as a department, we really grappled for a while in terms of how to best allow the algorithms to communicate with ordering providers. With AI Doc, initially all that communication came to the radiologist, and then we determined what we thought was the diagnosis and communicated it forward to the ordering providers. And actually from our ED, they didn't want alerts in terms of AI, because there was certainly a concern that they would act on an AI diagnosis prior to a subspecialized radiologist seeing it, and if there's divergence, that can create potential issues for them. Now we've kind of moved towards direct communication between AI and our ordering providers, with the caveat that the diagnosis may end up changing once the radiologist has reviewed it. So certainly it provides quick communication of what AI is seeing, but at the same time, it's not a final diagnosis for them to act on. So I think in that setting, you kind of get that benefit of that rapid communication. If it's something you really need to act on fast, like an LVO, confirming that you believe it's real, and kind of activating that stroke intervention cascade, versus things like a PE that maybe is not as like a subsegmental PE that doesn't require that quite a rapid response, but at the same time we provide that communication just so it's in the record. So I think there was a divergent approach between the different vendors, but I think they've really started to converge on the same point and have a lot of the same algorithm offerings for the different users. I do think still there are some institutions that will use multiple vendors, and I think we still fall in that category because we are still using a Schema View for CTP and stroke, and we use AI Doc for most other things. And at this point, we actually have two different stroke algorithms operating between those two vendors.
So let me just before you
Sure.
get to the other point, I know Neil wanted to say something, and maybe George and Mark want to say something as well. But the practicality of this is that the way it works at most institutions in the United States and probably around the world is this decision is up to the chair of radiology. The chair of radiology at an institution, he or she is going to tell you which product to buy because they don't want to buy anything else. Now, if we're all free, then you can use multiple products. Sorry, Andre, it looks like you want to say something, but like, how do we approach this?
Correction, stroke director, stroke center director.
You pay for it?
Radiologists are not even involved in what we're doing. I didn't want to start just the whole new discussion.
I feel like that's going to be your punchline with Jim when you get up on stage.
Exactly.
So the stroke center director pays for it.
It actually, I'm responsible in justifying the budget.
Okay, go ahead.
Well, I was going to tug on that string a little bit, Dave, which is that, as you're saying right now, all these software costs money, and you have to make a business case for why it makes sense to spend that money. And when we were bringing in our LVO software, we had to show in some way, and the NTAP helped a lot, but we had to show in some way that this would result in more money to the hospital, which we made the case for we'd be doing more thrombectomies. There had to be some business case for why this made sense, and this is maybe just my academic, naive, optimist view of things, and I totally agree with what George was saying about yes, it's great to have clinical outcome as an endpoint, but you have to have something people understand. That's the only way they're going to buy the software, and I completely understand that. But I'd say there's a few changes I think that are happening now that make this much more likely to be easier to do in the future. The first is people are just getting more accustomed to using AI. It's less of like a mysterious, scary thing to them. The second is, I think, and I hope that this happens, is that regulatory changes make it less expensive to get a software to market. Fewer things you have to do to get clearance for your software device. And the third is, I hope that it becomes easier to share images and data to train these algorithms to reduce the cost of development. And if all these things can happen, then hopefully the cost that goes to the user is less, and the barrier towards getting in, why not have multiple softwares at your institution? I mean, there's no reason not to. On my computer, I have multiple browsers, and I hopefully with some of these changes and just broader adoption, it becomes less of an issue.
I think the cost of these algorithms is a factor, but I think the other factor is IT bandwidth at a lot of institutions. And I think for us, that is certainly served as a major obstacle, major barrier in terms of implementation of new AI algorithms. And I'm sure that applies for a lot of academic institutions. When folks say we want to trial something, those trials are very tough to implement due to IT bandwidth, and also due to a lot of times, free trial means you have to upgrade servers, you need to upgrade other things in order for implementation. So I think that ends up serving as a major barrier as well.
Yeah, I agree. I think it's not just the license cost for the it's a lot of heavy lifting at the moment, at least, to install different technologies. I just wanted to touch on David's point about who decides about what software you have. I think that it's very interesting. I think people will have different perspectives, and I think there's probably quite a lot of variation, not just within the US, but actually certainly around the world. And in a lot of healthcare systems, the payer, who ultimately makes a decision is going to be, could be at a government level or at a large scale, and depending on who it is that makes that decision, they're going to have different requirements for proof of value. And if you're talking to a government, it's not about number of thrombectomies necessarily. It's about patient outcome, wider social health. Now hopefully that aligns with number of thrombectomies, but they're not looking to make money out of the number of thrombectomies. So I think it does depend on who you're talking to as to what the and I think it's not just certainly outside the US, it's not just the chair of radiology, but they're clearly the radiologist is always going to be essential. So you do need both the evidence of the sort of algorithmic technical performance, which perhaps a radiologist will be more drawn to, but I think we do need to think about how we demonstrate value to wider society if we're going to be a sustainable technology that's going to grow and do all those things that we've talked about.
Now, in the US, there are there have been temporary technology reimbursements from CMS that can support certain AI algorithms. And I know a number of the companies, including AI Doc, Viz, Schema View, got that NTP licensing where they indicated that there was benefit in stroke. So with LVO detection, there was a reimbursement component.
Yes, so quick. So everybody has said in these presentations that at the end of the day, we have to show better outcomes. And I guess my question is, are these platforms so embedded in our systems of care now such that won't be able to really do the study to show that clinical outcomes are really better if we use them than if we don't use them? Because I'm not aware that really any such study has been done, but I'm not sure they'll ever will be done.
To that point as well, similar to what Jim is saying, when it comes down to therapeutic development for a drug, FDA is not going to care what an unvalidated or limited or premature or unvalidated approach from an imaging the algorithm is going to show you about a drug. They're going to want to know about clinical outcomes. So the end result is clinical outcomes. All right, Raul is saying no.
Well, I think it's an oversimplistic view. It's not really clinical outcomes. There are many metrics for this, right? So first of all, clinical outcomes in who, right? If you look at clinical outcomes in acute reperfused patients, you have the denominator fallacy. You're not looking at the overall population. You have to look at the overall population. So a lot harder to do. But one of the things you note in our system is we had 60 transfers less after we installed one of these AI systems in comparison to the same period prior to the installation. How much is a transfer? Does anyone have an idea? How much does a transfer cost? How much?
Yes, I do. So if you fly the person, it can cost the person up to $20,000 extra bill.
But for the system is a lot higher than that.
It's
a lot higher.
Yeah.
No question. So the point is, you look at 60 transfers, and this is almost nothing in our system. It's like 2-3%. Okay, and it ranges between $20,000 and $50,000 actually. So you're talking about $1.5 to $3 million in savings, and you have not even touched outcomes. You're just decreasing, and I hate the term futile transfers, not to be confused with futile thrombectomy, which almost doesn't exist. I think you can say that now. So please, let's not get in the air. But the futile transfers, they do exist, right? It's the patient that you transfer and you don't offer anything at the comprehensive that you couldn't offer at the primary. And that's a waste of money. That's a great metric that has nothing to do with patient outcome necessarily.
So I would like to echo what Raul just said, because I had exactly this conversation with CEOs in my system. And I said, we need artificial intelligence cloud-based image exchange just to minimize the transfers. And that was number one. And it's easily quantifiable. And that's why stroke center director, not radiology chair, stroke center director can authorize that expenditure. However, and I'm closing this session with this remark, and Greg, you will like that. I'm still on call, probably about the same number of years. And I told my team, if Rapid or Viz or whatever Brainomics alert comes with saying elbow, and you did not diagnose it as a human expert, you're obsolete, you're done, you're history. So our goal on call is still to beat your alerts by looking at the images ourselves and find LVOs. All right, so David, next session. Thank you, guys.
All right, so let's move on to the next session. That was excellent. So the next session is on generative AI for precision medicine. We have Ashu Kunikorn and Alex Zapp, Professor Zapp, come to the stage. So Ashfaq is still on the plane, and Max is traveling as well. So just to distinguish this a little bit, people have only spoken about generative AI in the last year to 2 years. And this is a new topic, and it's different. It's not general AI, it's generative AI. So slightly different focus. And what was intended here was to talk about how AI can be used to better inform us in terms of treatment of patients from a precision medicine standpoint. So what's coming down the pike, in terms of, is there anything that can help in terms of, that AI can supplement truly in deep learning, whether it's based on basic information, textual information, language transmission, imaging, or anything else that can make us be better at treating patients on an individual basis.
Yeah, and I think we spent a lot of time talking in the last session about use of AI for stroke detection and triage. And I think going past or beyond that topic, large language models, I think there's probably, I would say, 3 domains where large language models are potentially going to be helpful. I would say the first one that's very kind of mundane, but probably a big contributor to burnout in medicine is electronic medical records and taking large amounts of information from the medical record and synthesizing clinical notes. For those of you who've been taking stroke call for 30 years, you spend a lot of time documenting those encounters. I think a lot of that could be automated. So there are healthcare systems focusing on trying to develop those kind of algorithms. I think secondly, a lot of what we do in medicine is we have, I guess, what you call hypothesis-driven approaches to science, is saying, okay, let's say blood pressure control is a way to predict outcomes after thrombectomy. So we've seen now a series of clinical trials capping blood pressure at different ranges. So we kind of took a biomarker that was associated with bad outcomes and tried to do a trial using that as a target. But, to some extent, maybe a lot of this is, if we get enough data, we don't need to have a hypothesis. It's possible that there are markers that we would never predict are important in outcomes. And AI could potentially, in an unblinded way, identify new markers or new measurements that we should be targeting. So I think there could be some novel approaches to therapeutic targets. And then, of course, with these large data sets, there's going to be more sort of efficient ways to do clinical trials. I think modeling devices in silico, rather than doing device trials for every individual device, trying to simulate those in silico in sort of computer models could facilitate device design and mechanisms of trying to find faster iterations of clinical trials in this simulated fashion. So I think these large language models could help in those particular ways.
You have to be a gentleman, ladies first.
I mean, I think precision medicine in pre-hospital is difficult because you're trying to treat a large number of patients and you're trying to get the treatment to the largest number of patients. So number one is, how do you get patient education, precision medicine to patient education? I mean, this is like trying to address disparities in care. And I think that like AI is not going to address disparities in care. There's going to be limitations to the amount of technology. I mean, we've been seeing tons of presentations on technology to help identify strokes in these patients. But at the same time, these low resource income countries do not have access to this type of technology. So at the end of the day, you're not going to supplement these patient education with these technologies in those settings. So if you take out precision medicine from the pre-hospital setting, I think that it's going to supplement our use in the hospital setting for the present, but I don't think it's going to replace the physician. I mean, I can't see, and maybe I'm the skeptic in this crowd, but I don't see how precision medicine is going to be applied to the pre-hospital setting when we can't even establish that the reimbursement for a pre-hospital setting exists. So you're not going to replace a human with AI that hasn't even shown better outcomes in that setting to begin with. So I think the first thing is establishing clinical trials showing better outcomes in these patients in the hospital setting, and then maybe you could apply to other settings. But the first thing is it's not going to ever address disparities in care that we are seeing throughout all of our clinical trials.
Thank you, Alexandra, for the skepticism. Anyway, so for me, like, I'm actually a little bit on the other side of the fence compared to Alexandra. So, in terms of my role, like within, Society of Vascular Interventional Neurology, like mission thrombectomy. So I think that, like with my experience, especially, for me, working a lot with the Southeast Asia cohort, and doing a lot of like work, within Southeast Asia and South Asia itself. So we're starting to see like a lot more of these patients, who are actually, pre-hospital, like well, there's no pre-hospital AI or anything, but as of right now, the system is being established currently for large vessel occlusion treatment, and a lot of these countries, like especially those that has a national reimbursement system, are going to, move much faster than other countries which does not. But in that case, like in some times, for a lot of these countries, there are very rigidly like following national guideline, like from American Heart Association, and they, follow this like almost to the T, and actually almost like memorizing them. On the other hand, that their patient population is actually much more different. And as large vessel occlusion, like within, like the United States and in Europe, like we barely see like intracranial atherosclerosis, and much more of like these diseases. But on the other hand, like with our work with mission thrombectomy, we've seen that in Southeast Asia, and even in South Asia and India, I've seen so much as almost 50% intracranial atherosclerotic disease, and they're following the same exact guideline, as the Caucasian, cohort within the US, which obviously, like the outcome is going to be very variable. So in this case, I think like AI might have sometimes some help into that. So the first thing is I think, in at least like two aspects. So the first one is that because a lot of these like countries, are having a very rigid guidelines, based on former standard of care, which is like IV TPA, and prior to thrombectomy. And since then, like a lot of the country, especially like, one I'm very familiar with, which is Thailand, which is where my hometown is. There are a lot of what they call like a stroke node. And these stroke nodes are basically IV TPA nodes, and they receive like IV TPA for any stroke symptoms. On the other hand, they're not mechanical thrombectomy centers, and right now, since because they're doing extremely well, giving IV TPA. On the other hand, the large vessel occlusion treatment, once mechanical thrombectomy has started to emerge, very fast, it is very hard to change the system, in a rapid manner without really any help. And so right now, like they're still following the same guideline. Basically, if anyone has stroke symptoms, they would just go to these stroke centers where they are just given IV TPA most of the time, and then it takes them a much longer time to be transferred. In this case, my point I'm trying to make is that to be able to assist these countries, especially in lower in Southeast Asia, or like in India or in South Asia, to have like an AI, generative AI to be a part of this, might be able to help distinguish this patient and transfer them, or even propose that this is like a large vessel occlusion or so, in a more precise manner. It doesn't have to be like extremely precise, all to the point where okay, you're telling this is an LVO related to ICAD or LVO related to anything, but at least just assisting these very rigid guideline country to help a system transfer a patient in a more efficient manner into receiving, let's say bypass like an IV TPA node and going straight to a thrombectomy center where they also can get IV TPA there. That's one of the things I think that could be very useful in this case, a little more precise medicine. And on the other hand, like to be even more precise in that, then would be, a more like a more AI approach to diagnosing like LVO and knowing, like more of the source of what is the cause, in terms of like, especially like I said, in this country, a lot of ICATs, and a lot of failed thrombectomy because, we never knew. And a lot of these places are very poorly equipped to treat ICAT because a lot of them only have a mechanical thrombectomy treatment device, either just aspiration or maybe a stent retriever. But in that case, if a precision medicine would be involved, we might be able to, identify certain LVO causes and then refer them to a more specialized center. So that's why I think there is a lot of rooms for improvement in this part. I'm just talking about in the pre-hospital and acute setting here. So I'll pass it on to.
But before you get to that, I have a provocative question for you. So AI can't exist without data. And in this country and in Europe, maybe it's slightly different in Europe, the main source of data that we have on our patients is language. It's the medical record, the EHR. I don't know what the current percentage is, but if you asked, and I'd be very curious if anybody actually knows this, but what is the validity of the data that's in the EHR aside from lab tests and imaging? Most notes, as you know, are cut and paste from the day before. The history is repeated. It's a summarization of all the lab values and all the other results. It's duplicative. It's not generative. So if your source is very limited because it's duplicated and copy and pasted from day to day, it's going to be very, very limited in terms of learning anything new. So is the source large language models from the EHR? Is it variations in vitals and in labs? Is it imaging? What is it going to be based on? Because I think it's a no-go to doing anything in medicine in general if your source of your data is limited before you get to the AI.
All right, well, David, Alex wants to reply to that.
I think if you're going to use EHR, the question is AI using precise medicine or accurate medicine? Because EHR is very limited. It's not going to be able to distinguish like patterns of variation in vitals or labs. So then the use of AI in EHR is more accurate medicine rather than precision medicine. It's not tailoring it to the patient. You're not going to be able to develop deep algorithms in that patient. It's going to be very limited, especially, based on unless anyone else tells me otherwise, that there's some kind of like software available for EHR. But I think that is a limitation. And you're never going to be able there's, in terms of pre-hospital, there's no EHR available for pre-hospital. EMS data is very limited. You have run sheets when you drop a patient off at the hospital. So I think that in that case, AI is just accurate medicine rather than precision medicine. You're not tailoring it to the patient at all. You're not tailoring it to any kind of algorithm. You're just based on a set of numbers. So then you're asking yourself, is it precision versus accuracy?
Let me just ask you one thing, Alex, about this. Going back to the last discussion we had, is that not just what Viz and Brainomics are saying in terms of not being the EHR, but being a layer on the EHR as an alert system? So you're faster in terms of detecting signals, not necessarily more precise, but just alerting the physicians and other providers to then intervene and get to the answer faster. You're just facilitating or accelerating. Is that the equivalent?
I think that's true. There is so many times on the mobile stroke, where we've seen LVOs, but it's actually just due to, a critically stenotic ICAD lesion rather than an LVO. But when you have the clinical history of the patient presenting 17 times to the hospital prior to that, you're able to augment, not replace.
David, you started discussion almost to the point where I wanted to bring it all. So you saw optimism from Ashu, and then cold shower from there, reality worldwide, and then interjected. So let me put where precision and AI will come to a perfect marriage, and I believe we were shown that in Star Trek Next Generation, when someone comes in with a tricorder, right, who has no medical background, scans the person, beams it up, and then a neurotic hologram of a doctor comes up and explains what the options are in treatment. So that's kind of where we want to be, right? with AI and precision medicine and our fantasies. Right now, we're making baby steps. And what you just identified is our limitations of where we are going to go into this. So the weakest part of electronic medical record is a free text. Because the moment you type something up in a free text, it's lost for mankind because none of the softwares that are out there, none of the reporting can give you a full assessment of the free text. So the question is artificial intelligence ready enough to analyze that free text, like ChatGPT, write a thesis for you? And the question is, what goes into assumptions in these analysis software? Are they able to then give you constructive suggestion or what you're missing? Or like what you described, you come in the morning on Monday and there is a transfer or there is a consult for you and there is hundreds and hundreds of notes. There is no way you can siphon through this in any reasonable period of time. You're looking for buzzwords. You're looking for bold text from other notes and stuff like this. So you need help there. At the same time, we need AI on cloud-based imaging to give us I mean, I would never be expert in aneurysms, ever. So if you can give me that I can show a three-dimensional image and explain why and make an intelligent referral. So this is another baby step that we can make right now. And then for radiologists, look, it's probably their worst nightmare that they will be replaced with portable equipment, cloud-based imaging, and artificial intelligence interpretation. Some of them are already embracing it and saying it will help me to read images. And particularly when you're in Asia, when you have one radiologist, whatever, for 1 million people, he or she would never be musculoskeletal or neuro or cardiac, but using that artificial intelligence cloud-based image, that person would be able to provide at a low-income country. So that's kind of a wrap it up thing. And David? I'm trying to keep everyone on time, so we have time for a couple of questions.
Well, it's not a question, but one area of pre-hospital generative AI I alluded to earlier is with dispatch. There is this software that can learn from listening to patient calls, whether it's a stroke or not. That's a perfect example, but I would maintain that still, why does AI get to be used and employed when everything else we have to do has to show better clinical outcomes? And AI is just, we adopt it without showing that it improves clinical outcomes. So if I'm going to do an algorithm, I'm sorry, I don't mean to say the same thing over and again, but why ever incorporating these platforms just because the FDA approves them and we can, get them approved and whatever? I think they still, at the end of the day, need to show better clinical outcomes, including generative AI. But I do think that's a good example.
I will quickly respond to that by saying I agree with Greg. It made my call damn easier. I'm not going to tell you what I do with this, but I can drive and still look at this thing. Whereas before I have to stop, find the internet and look at packs. Greg, go for it.
So what study was done to prove that CT scans or MRs are useful?
According to Powers, there is no use for them in select stroke patients. Thank you, Greg. Thank you, Greg.
I was wondering about, so we all agree that the greatest benefit is likely in the underserved areas, right? So why don't we take advantage of that, because it'll have the greatest treatment benefit and it'll give us the best outcomes for clinical trials, and trialing these tools in that setting by providing for free the software to these areas in a cluster step wedge design with a rollout to a whole country somewhere. And I have several that I'm working with in the Pacific that actually have the technology as far as CT. They even have access to CT perfusion, which isn't actually as much of a barrier that's sometimes is alluded to. I think it's the bigger problem is they don't have radiologists to look at the images. They don't have the technicians to, push the contrast in the right time frame. And so if we did a bit of training and a package around it and do a very pragmatic designed trial, I think we could get some really excellent outcome data. serve underserved populations and yeah, maybe progress the field. What do you think?
Thank you. Well, that's why it's international conference, and for this day and then the next 3 days, we're going to cover the globe twice over, I hope, and discuss specifics with countries, and please spread it up at Oceania. And my personal bias, and I'm going to finish this section with this little statement, which may be a little bit off the topic, but you know what is the number one disconnect that we have on a daily basis? We come in, we see the patient, we examine the patient, we talk to the patient, we talk to the family, we explain risks and benefits, and we make up this plan and talk about to the most intelligent patients about the most sophisticated diagnosis. And then all of that is lost because it needs to be captured in your notes. And most of our notes are not written in real time. They're written next day, maybe 2 weeks later, and some of us procrastinating. All of that is lost. Where I need AI is someone to capture the essence of interaction with the patient and what the message was conveyed. If I can get this instead of a scribe, which we all tried and failed, in particular in emergency medicine, they come and go. I don't see them regularly. If we can get AI monitoring of what we do and generate that really a note that differentiates a good doctor from the doctor who is just like checking boxes and doesn't even bother talking to the patient. So thank you, guys. I'll finish at that next session.
Or we need precision medicine for AI for patients, because they, number one, don't understand what we're telling them for the patient education. And number two, we're not even addressing secondary stroke prevention of how we're preventing them from coming back to the hospital. So it's not just for us, it's for them.
Awesome. So next session is Dr. Grothe.
Right. So the next session, Andre gets to stay up there. So thank you, guys. So the next and last session of the evening is, I should explain a little bit. It's acute ischemic stroke therapeutics, everything, everywhere, all at once. So we've talked about a lot of different therapeutic approaches. There's not one, but multiple drugs that have been tried in the last days and weeks and years. We've had many drugs that are tried, again, focusing on acute ischemic stroke therapeutics. That being said, when, I said this to a colleague the other day, that when you look back and asked how many therapeutics have been approved by the FDA, have been approved in general by a regulatory body, at least in the United States and in the West, in our history, it's extremely limited, right? We have TPA, right? And we have thrombectomy in select patients. Am I missing anything else for acute therapy?
Aspirin.
For acute therapy? Was that never approved?
For acute therapy within the first 24 hours.
All right. So in the last 50 plus years, there's 2 things we have, and that's it. And one in a very limited, so today in a very limited area. One of the things that we're conflicted about, at least I'm conflicted about, is that, we go through trials, not year by year, but decades after decades, right? And we try and, as I said, integrate all this information in terms that we get from the trials individually and make sense out of it. And the pace of advances is extremely slow, exceedingly slow. So, some trials obviously focus on certain investigational products, devices, or certain drugs. And then we always get into the debate about, well, what's the interaction with, the other therapeutic approach? What's the interaction in which patient population? Did you diagnose that specific patient that's going to be ripe for that therapy? So it's, so there's a lot that's still on the table. Most recently, we've revisited this issue, and we had a debate about this just this week in Toronto at the World Stroke Meeting. About the fate of neuroprotection, and now neuroprotection with large vessel occlusion. We have been waiting. All of us remember enrolling patients into neuroprotective trials 25 years ago. Now we've gone through another generation. We waited 8 years for Frontier to be done in Canada. Escape Next to be done over several years, 4 years or so, as well. Escape Next, floridly negative. Frontier, exploratory, maybe signal of something, maybe after adjustment. And where does it lead? Is this a positive sign for neuroprotection? Is it a bad sign for neuroprotection? Should we just give up? So how do we trial these things and think about all these things all together? Should we think about them individually or everything?
Yeah, well, I don't want to get into the pros and cons of neuroprotection. I think that's probably for tomorrow or some other session. But first of all, I don't think we're doing that bad in stroke. Look at other fields. Yes, we only have two main approaches, but how many treatments are there? Acute treatments for coronary disease, really, there's thrombolysis and there's PCI. I think that if we're going to make the biggest main treatment for acute ischemic stroke is getting the artery open, we all know that. Any additional benefit is going to come in small increments. So to me, the problem is not so much in that we don't have good ideas, but we're not doing the clinical trials well. And why, let's turn around, why we hear at the World Stroke Organization and at the International Stroke Meeting, why are all these studies being done in Europe and in China and not in the United States? What's happening to our, too bad Pooja's left, but what's happening to our clinical trial machinery in the United States that's not enabling us to get these trials done here? But we need large thousands, like the study that was done in China with 9,000 patients in 8 months of enrollment. Why can't we need trials like that in order to be able to see the incremental benefits? Because I think if we do get neuroprotection, it's only going to be a small incremental benefit. If we're going to find another approach to thrombectomy, let's say, it may be a small increment, but I think we need to be able to do our clinical trials more efficiently, larger numbers of patients, and we in the United States need to answer the question, why are they not being done as frequently here?
Just a brief comment on that. The answer to that, at least in my mind, is very simple: money. Who's paying for it? And if the yield is not there, it doesn't matter whether it's a drug or device, it may not be worth it. If you have to do a 2,000 patient study, there's a very concrete cost of doing that study, and it may not be worth it for whoever's developing. Cost is a lot higher in the United States. What else?
Okay, so Raul just said that the cost in the United States is prohibitive compared to the rest of the world. So I have a comment on that because my personal philosophy was always do first in man trials in the country of origin of invention. And in other words, American invention. Why do we need to go somewhere else? We need to be able to do it here. Second is the cost may be because, yeah, we pay a lot more per hour than other countries, but I think the bigger reason is we have very scrutinizing and hard to handle IRB system that is often unreasonable. I lost a lot of centers because of endless battles with IRB. That's something that we cannot fix at this meeting, but we can just raise the issue that honoring central IRB should be something that local hospitals, particularly those who don't know how to do clinical trials, should embrace. But leaving that aside, going back to a question that David posed, yeah, we do not bad. We have 2 treatments with number needed to treat 2 to 3 and 3. That's not bad. Cardiologists do not have it. One of them is systemic thrombolysis. David, by the way, thank you for putting me at 7 a.m. to talk about some unpopular topic. All right, but we're gonna talk about this at 7 a.m. tomorrow. So we are doing not bad, but we need to embrace the culture of clinical trials, particularly at comprehensive stroke centers, get it to fruition. About neuroprotection, we were all interested in Escape Next trial. And I'll tell you, after I had a couple of glasses of wine, that I didn't want it to succeed. And you can say, well, that's counterintuitive. Why? Well, because that was the trial of neuroprotective agent on the way to thrombectomy without TPA. What if it was positive? Do you know what would have happened? Everyone who is questioning IV TPA and was opposing to IV TPA would stop giving IV TPA, saying it's a dangerous drug, you don't need it. Here is your neuroprotective shot, and off you go, 2-3 hour transfer to thrombectomy. God knows what's going to happen to you then, but you got that neuroprotective agent. I mean, it's a bad thing to say about my fellow clinical trialists. They put blood, sweat, and tears and investors' money into that, but conceptually, that would have been a wrong message. I think Frontier is a different story when you have pre-hospital thing, but overall, I think Frontier was flat with intention to treat. With modified intention to treat, if you dig in, then maybe there is some subgroup. But if you want to bring neuroprotection in a pre-hospital setting, you have to make sure that you power clinical trial for all comers. And all comers includes noise such as stroke mimics, seizures, ICH, TIAs, and then you have your 2 to 3% improvement attributable to neuroprotection in the pre-hospital setting. All right, Aristides.
Well, let me just make one comment about that. The reason I put Frontier together with Escape Next, obviously they were presented together 2 days ago, or 3 days ago. But the conversation that took place in Toronto was, in my eyes, illogical. You have a singular investigational product that's been in trials for a very long time. You have a phase 3 adjunctive therapy with endovascular therapy with treatment, and an exploratory pre-hospital study, and the arguments are almost opposing. The argument in Frontier was exactly what you said. It's without TPA. The argument that was for the explanation for the result post hoc was that the TPA was given and the drug was given before the TPA was on board. So, it got there to so-called freeze the penumbra, despite the fact that nothing changed in terms of the circulatory system. That these people had the same occlusive status, same collateral status for that period. And then they got TPA after the drug was not inactivated. It doesn't make much sense to me. And you have 2 different stages of development that are being presented at the same time.
Yeah. So question is, was the drug unmodified for all these years? Is it the same drug, or they learned something from Escape NA1 and figure out the modification that is more friendly to TPA? That's the question to development.
Yeah, so my question as a younger colleague is why are we repeating the same mistakes? So we have lost billions and so much time with neuroprotection, and the reason for that is also reproducibility, right? So we do animal studies, and these results, they don't get reproduced. So why don't we look for multi-center studies in preclinical research so we can have some robust data? That's the one thing. And the other thing is, and ask if by searching in neuroprotection, we have this inferiority complex with cardiologists that we are not following their step, but because we're neurologists, we're dealing with the brain, we want to prove ourselves that, we're taking a different pathway. So maybe we should have more robust translational research and make sure that the agents that we bring into clinical trials, they have been reproduced in different settings and with adequate number of mice model or macaques or whatever. I don't know. What do you think about it?
I agree with that. And I know Pat was on remotely. I don't know whether he still is, but we do have the network of preclinical trials that's supposedly coming up with the best candidates for cytoprotection. And there's a new round of that about to start. Having said that, I'm not really an optimist. So we use cytoprotection or neuroprotection as sort of a big category, but in reality, if you're talking about drugs that target the early steps in the ischemic cascade, like neurotransmitter release, ion flux, and stuff like that, that occurs so instantaneously after a stroke. I think we've tried trial after trial after trial. It doesn't work. And when you're talking about more downstream things that may complement reperfusion, then I think we have a chance, particularly the downstream inflammatory stuff that happens during reperfusion. I think that there's a better chance that we'll be effective there, or other drugs that may enhance reperfusion in the microcirculation. I think that's where we're going to get the incremental benefit. But I think in order to, and I do think it's worthwhile getting those incremental benefits. After all, a several percent increase in the percentage of patients achieving a good outcome is meaningful, I think, and probably would be cost effective. But it's going to take large trials to show it. And I don't think it's just a matter of money in getting these studies done in the United States. I think in other countries where the healthcare system and the hospitals are more orchestrated, and you can get a comprehensive stroke center, you can get them all cooperating and capturing all the patients in a particular country that come into the comprehensive stroke centers. They get studies done. We can't do that in the United States.
So I'm going to say something provocative since this is a world conference. The story of neuroprotection is not dead at all. In fact, cerebroprotection was inadvertently invented before the even term existed in Austria in 1950s. So an Austrian scientist said, okay, well, brain is injured, ischemic. It's looking for some supplies, some nutrients. Why won't we extract from an animal that is close to humans, pigs, humans, okay, very close, extract neuropeptides, irreplaceable amino acids, put it up in a 50 plus molecule launch and give it to the brain acutely, subacutely, and in chronic stage. That was the first cerebroprotector as now described as we were looking for it. I gave it to the patients when I was first year resident, way back in the Iron Curtain. It's called cerebrolysin. It's out there. We're gonna put up a review for you guys to see. It has been around and it is used worldwide, Austria eastwards, particularly in Asia. So for those of you who see international patients, be prepared that they will ask about a 3-week course of a neuroprotector that actually improves ability to restore arm strength and neurorehabilitation in a randomized trial. All right, I'm just gonna say it because, okay, he can. I have first given it in 1989 before I started drinking vodka. Okay, right. So anyway, so this medication has been around since 50s. So this has been neuroprotection is by no means dead, and we do have Rhapsody 2 trial going. Yeah, Rhapsody 2. I think we should invest in that. What other trials are down?
Well, are we going to have a neuroprotection session tomorrow? Yeah, maybe we should probably wait. Raul, what did you?
I mean, I think that the lack of cooperation, going back to this issue of why a lot of these trials are happening in Europe and Asia, I think the lack of cooperation and the lack of funding or the high prices are related topics because, I mean, to some extent, the elephant in the room is StrokeNet. I mean, StrokeNet trials, they don't pay a whole lot. If you're a stroke center that's trying to balance the books, it's much easier to enroll a patient financially into Masters or Charm or some industry-funded trial that reimburses a lot more. And so as a system, we're not organized or cooperating because there's realities of keeping the boats afloat and, screening for Sleep Smart or Arcadia, they don't pay a lot. It's a lot of it coordinator time to screen for those patients and find those enrollments. So I think as a result, our enrollments take a longer than the organized network that is MR Clean or Barcelona or even Calgary. They kind of lockstep, pick a target and they just invest in that trial for 1 to 2 years and they get it done. Here, we're kind of a scatter drill because the truth is priorities are competing. And I don't think it's a lack of desire to cooperate. It's just that the financial realities are that the industry trials kind of subsidize the StrokeNet trials and allow you to stay afloat as a stroke center that's trying to do clinical research. So I think these are actually interconnected.
But a lot of correct me if I'm wrong, I'm not an interventionist, but this morning we heard about all the large core trials and intervention trials, and most of them are industry sponsored. And most of them are carried out in Europe, if I'm not mistaken. Right?
a lot of them are investigator initiated.
Investigator
We
initiated.
actually, we actually put the very first large core trial as a stroke net proposal and went down in flames. So there's like 7 years, was the very first one. We had the first pilot data in a case control start of large core central stroke net. Doesn't go anywhere, right? So because there is this thing, oh, you're gonna do step, and then it's gonna be close to a decade that you haven't done anything meaningful in one of the most powerful treatments in stroke. And frankly, you're looking at just occlusions now in the step platform. By the time that we start that, all the other countries will actually have complete their trials. So there is big inefficiency, but at some point you're going to start. And I think from that point on, hopefully you're going to be able to contribute. But yeah, I agree with you. It has been very disappointing.
I mean, I think the other sort of danger in this is that like something like STEP, which is, again, not very well funded, is going to struggle answering maybe higher quality scientific questions, because a new device is going to come along and pay you a lot more to put your patients in their single arm, registry or prospective study. So I think that we do need to take a closer examination of how we're doing trials in the US, because there's a million reasons why things happen the way they do, but IMS3 took 5+ years. We were not randomizing consecutive patients. Along comes Swift Prime Escape. Within 2 years, you've got RCT data. Dawn, within 2 years, you had RCT data. So clearly there is some hybrid model here that works better, which I think needs to have an open conversation about.
But isn't this quite simple? I mean, going back to what I was saying, it's all about the money. I mean, business is business. So if you do something in business and it doesn't work, you fold. So the headline today was that Athersys is on the verge of bankruptcy for stem cell therapy in stroke. We've participated in 2 trials in that regard. And the fact is that when something doesn't work in a clinical trial and you're part of a business, the business folds. That's not true on the scientific side. As I say, there's always time for science, as long as someone's paying for it. So the impetus, the momentum is not there, like you say, Raul, in StrokeNet. And I apologize that we all participate in StrokeNet, but that Pooja's not here to defend StrokeNet on this regard. But the incentives and the motivation are not the same, and you can't mess around in business, because when things don't work, that's the end of your business.
I think another problem that you have is stroke is a very time sensitive issue, and the whole consent issue, that's a huge barrier, right? So you go to countries like Germany, where they allow this kind of more like a physician-based consent, or even in Spain, they actually put the patient in the trials and they consent the patient to use the data, but not to put the patient in the trial, because there is obviously they are doing a trial because there is a perceived benefit, and that's enough. And here in the United States, this is just impossible to do it. And there was that fiasco, right, with the anti-epileptic drug trial, right, that got completely blown out of proportion, and I think was extremely detrimental to the waiver of consent process.
Just one question to the audience. We're talking about neuroprotection, economics. We heard about analysis of economics. I think we all agree that early treatment and proper triage and reperfusion are the 3 major determinants of outcome. If we think about economics, if we think about actually taking resources and apply them there, of early diagnosis, early triage, early reperfusion, instead of going to, pardon me, voodoo or questionable billion-dollar drugs that may or may not work, wouldn't we achieve better outcome for our patients?
Here, Absolutely. There's no question about it.
So why are we not working in that?
These things
Yeah,
should
we are-
work in parallel. There are
No.
different forces that drive these things.
Exactly.
Should work in parallel. One thing doesn't prevent the
I know
other.
it's not.
One is like infrastructure. It's like public healthcare. The other one is, yes, you need partnership with pharma and with device companies to make medicine evolve. These things, one thing doesn't compete with the other. They should exist in parallel.
And I agree. I mean, but systems of care to deliver faster treatment to more patients that we have is going to make more of an, in my opinion, much more of an impact than a small increment with with a cytoprotective drug or whatever. But as Raul says, we can do both. And one example we're doing both is, and to StrokeNet's defense, is with the fastest trial. And in the fastest trial using activated factor 7A to prevent hemorrhage enlargement, we are using EFIC, and we're doing it in the pre-hospital setting as well. And I would submit, if we can do EFIC, and it's so easy to enroll patients into that trial, it makes it so much more streamlined. I still don't understand why, if we can do EFIC in a hemorrhage trial, why we can't get it accepted for ischemic stroke studies.
Yeah, so I think in this conversation we've outlined at STARE, there are some obvious low-hanging fruit to improve the efficiency of the trials. The consent process is one that you just mentioned. I would actually come back to what you said about the large core trials. Those were all investigator-initiated studies that were sponsored in part by industry. That's not a bad model. It's what happens, and this is very true in the distal occlusion trials, the vast majority, except for one, are all investigator-initiated. Now, what happens with that, there's no guarantee in terms of what happens with one of those trials. And there's no result that goes straight to FDA. There's no approval of anything based on it. Only if somebody then initiates and takes the data and does something with it, which, give me a sec, Ro. And in the large core trials, there is a path to doing that. You do your trials, and then you can go and use the data and look for the signals of efficacy once you've already established the safety. The other aspect that is not being considered in terms of efficiency of trials, and it's sort of miraculous how this has been left off the radar completely, is FDA, whether for a drug or device, wants controlled, contemporaneous controlled trials. And unlike our cousins in other fields of medicine that are, that have filled their fields with registries, in the stroke space, we have not. And we've stuck to prospective randomized controlled trials. And the fallacy of that is that they don't really control for very much. And there is a cheaper, more efficient way of doing that. So you have post-marketing surveillance that's now being required in Europe. You have post-marketing surveillance that is a lofty goal of all of FDA, except the neuro branch has not realized this, or the message has not gone down from FDA Central to the neuro branch, that post-marketing surveillance should be taking place. And then for every single patient you enroll at a clinical trial of let's say an endovascular device at a center, there's 10 other patients that are being treated on that same day or that same week with an approved device, and there's no data collection on that. So your control can be those other patients that are being treated. So there are mechanisms that are available. I think we have to be creative about how we study things through all these, whether it's the consent, whether it's use of a certain design of a trial at a certain stage, how it's funded initially, and how you use the data, and then as well in terms of prospective contemporaneous controls. Sorry, Raul, if you want to jump in.
David, a quick question. This is not the title of the session that we designed, Everything, Anything, or All at Once in terms of treatment, and Rado was putting us back almost on that discussion. So not clinical trials, not neuroprotection. I just did a kind of sideline comment. So we promised that during this hour, we're going to discuss questions that came up or maybe were not fully addressed during the day, because the day was actually quite densely populated with some great science that is already out here. And so if you guys have a question that you want to ask, please grab the microphone.
I have a question that synthesizes things. So the morning was spent to a great extent on large core. We heard that large core may be heterogeneous concept. There may be large core that's dead, large core that's got islands, whatever. And then we heard the evening on AI. How can machine learning that Sunil was telling us about take a picture of the car or the large core, and will it be able to answer that question as to which is the large core that should be reperfused and which should not, or can it? Is that the answer to trying to make sense out of this large core data?
So actually, Jim, thanks for that comment. And I want to call on Greg and maybe bring us back the memories of STAIR meeting. So at the end of the STAIR meeting, the question was, weren't you surprised that large core trials work? And in fact, some of them were stopped for efficacy earlier. So we thought if benefit, if any, is going to be that small, bleeding is going to be that big. Instead, benefit was that small, bleeding was that big. So it came to questioning either imaging inclusion, what we consider the large core, or something else. And so, Greg, I have an explanation, and if you want to comment on that, I don't think it has to do with imaging. Maybe that's one thing that Tudor is right in saying imaging does tell me anything. Well, imaging just shows you a scare picture. Oh man, that's big. I would not have touched that with a 10-foot pole because we did not have tools to address it quickly. But the difference between when we derived criteria for the large core and now is that we do have a very effective reperfusion therapy that gives you one pass, open up, and perhaps you can change the natural history. So to synthesize your NCORE project with what has been observed, I think we need to look back at the imaging criteria and perhaps say that nothing is obsolete. Maybe within that presumed large core, we still have salvageable tissue. And I really, really would like to see research that would be applicable worldwide on a non-contrast CT scan. Greg, I'm setting up for a bunch of comments.
Well, I mean, I think we've talked about it a little bit. Jeff mentioned earlier that a lot of these large core patients may have had substantial penumbra. It looks like the patients who were treated earlier, as we discussed earlier, seem to do better. And then, you know, Amru alluded to some of the work that's being done with SELECT-2. It's really interesting to look over the hundreds of cases that were enrolled and all thought to have an aspects of 3 to 5. They look totally different, right? There's some that just like so dark and so obvious that there's a huge infarct there. And there's some where you got to be a very good aspects reader to pick up the subtle area, and not everybody's going to agree on it. So I think that AI does have a shot at trying to say that there's a lot of heterogeneity within these large core patients, and there may be different responses. It's interesting. The biggest hospital that I know of in the world is 115 in Vietnam, gigantic group of patients. And, you know, they switched in February after ISC to treating everybody. A couple months later, they changed because they wound up seeing a lot of things that they didn't expect, big hemorrhages, very bad outcomes. And, you know, our folks have been a little nervous to just throw the doors wide open because our beds are pretty full. And when these patients come in, we can't transfer them back, right? There's no transfer back agreement. So it sometimes means that there's not a bed available for, you know, the 45-year-old who's got a huge mismatch, right? So, you know, there's interesting ethics that get involved.
And that you have to treat most, if not all patients, like cardiologists have to do for years. They turn out this uses. No. So they can hear you online. Sure. So this idea that I'm not gonna treat this patient because if I treat the patient, gonna do badly. I mean, the trials show not all patients are gonna do well.
But if you don't treat them, they're not going to do any better. So you're not going to have that bad. It's not that bad that you reserve for that patient you didn't treat, right? It's going to now be empty. You're actually going to have a patient there that is going to develop cerebral edema. I don't get that point.
Well,
I
that's
feel-
not the, I would, let me just, before you guys get into a fist fight, let me just make the point. You know, again, I mean, whether or not you treat the patient is not just the only question. The question is, why do some patients with large core do well or get better and some don't? Hold on. And would AI help us understand that? That's not to say we shouldn't be treating the large core patients until we understand maybe something that would identify a particular patient that wouldn't do well, in which case it's futile. We don't know that yet at this point, but maybe, and that's what I think Sunil was saying in his comments, that machine learning can do. It can look at a picture, and right now we're looking at hypodensity and other issues about the core that we know about, but there may be elements to the image that we don't even recognize that might be relevant in terms of determining outcome. That's the reason where I think the beauty where AI could be applied to this question.
Yeah, if you identify such a factor, then it's completely okay, right? But if you just look at other models in medicine, like the way we treat ST elevation MI, the way we treat sepsis, the way we treat trauma, they don't ask those questions. They don't. We are the only group that has this obsession that every patient you treat has to do well. And the more you walk around with these patients doing all these unnecessary tests, we've been having this discussion for years. Was CT perfusion, then the malignant profile, go like, no, the malignant profile doesn't exist. If you open the patient, gonna do well. Now CT perfusion doesn't do anything for prediction of treatment effect. Yes, it's a great predictor of outcome, but it doesn't nullify the treatment effect. Now it seems that even aspects 3 and above, right? It's not, so you just have to embrace this and move on. Okay, but it shouldn't be such an obsession. I think you actually have much better things to do. For instance, how I get those patients that benefit from treatment, but don't necessarily do great to do better, right? And then there is now, out of a sudden, because escape was negative, a loss in the interest in looking at neuroprotection. No, you have to perseverate and fight that battle, because it's very different than 20, 30 years ago when you didn't have effective reperfusion. But this idea to say, if I treat this patient, I'm gonna take a bed of another patient. No, that patient is there. That patient is in your hospital. He is not gonna disappear unless he dies.
Yeah, I was talking about transferring patients. We get calls from all over the place that have gone a little wild lately. We get the 92-year-old who's got a significant disability and a lot of pressure to treat this patient. And if you throw the door open and say, absolutely everybody.
But Greg,
gets
if the
treated,
patient is in your hospital, can we agree that if the patient is in your hospital, can we agree that there is no benefit in not treating that patient in terms of preserving a bed? Can you agree?
I was talking about the transfers. From our experience, the vast majority of our patients get transferred in. We don't live in a huge city that maybe you do, but I think that's part of the issue is deciding, you know, what about patients who didn't quite meet the criteria? A lot of these patients who wind up in the trials are patients who you decided that you wanted to put in a trial, right? And then I think it is important to start looking what's happening as we now expand our
They are horrible patients. The mean core intention was 200 cc's. Can you also agree that's a large infarct, 200 cc's? The mean core in your trial was 170 cc's. By the way, apparently it didn't change in treatment and control in the follow-up image. How do you explain that? But the patients did a lot better. Can you just agree that you should be treating these patients, and maybe you shouldn't transfer them because you don't have the resources, but the response is you have to create the resources like cardiologists did to actually treat ST elevation MI, most of the country gets covered. So that's the answer, is not coming up with machines that will over-select patients like you have been doing over the last several years. I love CT perfusion. I think it's great for us to understand the case, but not to exclude people from treatment. I think you have
well,
to embrace
I think like any,
very few, because there are many PCI centers.
If we follow the STEMI paradigm, which we are, reperfuse because there's a occluded vessel, which we all agree that's beneficial, is do we bring the patient to the right center? And the transfer paradigm in stroke continues to exist where the transfer paradigms in STEMI doesn't. And I'm
because we have
questioning the
every
obvious.
cardiologist does a
I want to address the elephant in the room. How do we bring the patient to the right center at an early time window?
Rather, there is one comment. There is one
And
there is one
reperfuse them, and that's it.
There is one
know.
parallel between STEMI protocol and STEMI protocol and what's happening here.